हो गया यस डन 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 नहीं एक ही काफी हेलो गुड मॉर्निंग and this is our 13th CME and we are very thankful to all of you for coming so much early in the morning. And at this era of MRI and CT, most of the time we go for MRI and CT for even the smaller thing. But actually, if you have got a good radiologist who can read the X-ray, there is nothing like it. And there are many things which can be explained better on an X-ray. We have Dr. K.K. Saxena with us, and I don't think there is any better person at least in Delhi, who can read X-rays better than him. He has totally dedicated his life he has not diverted his attention to the MRI, CT, ultrasound. So for last 40 years, he is looking after our radiology department and head of the department for maybe more than 20 years or so. So there is no better person to explain how to read the X-ray chest, which is the commonest X-ray we need to know. So with that, I'll invite Dr. Saxena, and he'll be briefing us about how to read the X-ray chest.
Good morning, everybody. And I'm very thankful to Dr. Harbaz Lal and his team for this opportunity to be given to me. And although it was quite cold since last few days, but today the day is little better, and early morning risers are ready to reach here. So I'm very happy and I welcome everyone. And once again, thank you to the team of the organizers for this opportunity. X-ray was invented in 1898, but the use of the X-ray and first X-ray chest in the medical field was done in 1912. After that, so almost 112 years had passed. X-ray is being used in the medical field. And the most common thing which is used is X-ray chest. X-ray chest is a very simple thing you can undergo, or you can send your patient to anywhere, and these are available anywhere. But depends, now the things are progressing fast, and the quality of imaging had changed in the X-ray field also. Now there is no wet film, nothing like that, but things are done on the imaging sort of thing. Platform is changed, it has now turned into electronics, and initially CR films were there. Nowadays the small clinics are using all CR technology, computed radiography. But now DR had come into the offing, and digital radiography, DR plates are there, flat plates, which are very costly. We have got two equipments, one is 1.8 crore, other is 1.6 crore, that sort of thing. But quality of images is different, definitely different. So getting done X-ray at a smaller price will not give you that good resolution as you will get in the DR rooms. We'll start now. So while doing X-ray, we should look at an X-ray chest in a different way. We should not look in a tunnel way, but we should have a whole look at the whole of the field. So we should not have a tunnel view when you miss other things. Like here you can see that if you are looking at a smaller thing, not whole of the film, we should look at the whole of the film. Now normal X-ray chest, there are little differences in the male and female X-ray chest, but I'll try to explain everything. And here, this is the clavicle, other clavicle, then this is the midline spinous processes. So centering of the X-ray chest should be such that midline of the spinous process and the clavicle end should be equal on both the sides. And we should count the ribs in a different way. I'll tell you afterwards. This is manubrium border. Then this is costophrenic angle. This is right diaphragm. So this is called as right cardiophrenic angle. That is left cardiophrenic angle. This is gastric bubble, which has got a very great importance in cases of achalasia cardia, which becomes very smaller or absent. But in case of surgery, like nowadays, a lot of surgeries are being done, like esophagogynoscopy, you may not find all this. So you need to correlate with the history also. This is left costophrenic angle, this is right hilum, this is left hilum. So right hilum is little lower than the left hilum, and it's one rib higher up, one intercostal space higher up left hilum. Hilum are consisted mostly of the pulmonary vessels. 98.5% of the content of the hilum is due to pulmonary vessels. Rest 1.5% is because of the lymphatics, lymph nodes and bronchi. If hilum are larger, more than 1.54 centimeter, then it is enlarged. There may be so many reasons for that. It may be enlarged lymph node, it may be pulmonary vessels which are larger in size, like that. You can see a small density over here, which is inferior vena cava. This density is because of the superior vena cava, and this is trachea. Whatever you are seeing, black thing is coming down, is trachea, which is bifurcating here into the left bronchus and into the right bronchus. Right bronchus is almost straight to the trachea, and left bronchus has got an angle. Angle in between the two bronchi is called as angle of carina, and angle of carina is usually up to 40 degree to 65 degree. After that, it is, we say that angle has increased. In case of female X-ray chest, you may find that breast shadows are overlapping, so there may be some haziness in the lower lung fields. That is not because of the infection, but that is because of the soft tissues overlapping there. And rest of the things are fine, similar way. And we count the ribs from back side, not from the front end. These are the anterior ends, and that is the back end. So we always count the ribs from the back end. 1, 2, 3, 4. I have marked them till 12th rib. These are all digital images which you are seeing. And now if you see the old quality image, which are on the CR, you will feel the difference in the quality of the crispness is lost. Here the image is very crisp. You can see every details. But in CR system or in the analog system which we used to follow years back, there was a difference in the appearance. We should have a system to see the X-rays. Here I had covered the whole of the lung field, so we should see initially into the mediastinum. This is all mediastinum. At the angle of Louis, we divide it into the superior and inferior mediastinum. And we cover the lung field so that we are not concentrating on the other things. After this, we cover the, like here, we can see the cardiac border. Here is the superior vena cava, then ascending aorta, and right border is formed by the right atrium. Here is the aortic knuckle, which is due to the angle and curvature of the arch of the aorta. After that, this is the pulmonary way where the main pulmonary artery comes out. Then the left atrial appendage. And after this, the whole thing is formed by the left ventricle, a thin rim. And base of the heart is formed by which is sitting on the diaphragm, is formed by the right ventricle. how we calculate the cardiothoracic ratio. That is the important thing, that we calculate from the maximum border of the heart to the midline, and from maximum border of the heart on the left side to the midline, and we add up, and then we calculate by divided by the inner margin of the maximum curvature of the rib to the inner margin of the maximum curvature of the rib on the other side. So we divide by that, and almost 50%, 40 to 50% is the normal range. After 50%, it is increased in size, so heart is enlarged, definitely. Now we see at the lung fields. Lung fields are divided into, you might have seen it, that radiologists write the upper lung field, middle lung field, lower lung field. So here we divide by the anterior margin of the second rib. This is first rib, and this is the anterior end, this is anterior end of the second rib. So till the end of the second rib, we draw an imaginary line. So this all is upper lung field, and fourth rib. So in between fourth rib and the second rib, there is a middle lung field, and rest of the lung fields are lower lung field. We are not talking about the lobes of the lung, but we are talking about the lung fields. These are imaginary, arbitrary areas. Lateral fins are very important. Sometime you may see a lot of details in that, but they look very dangerous to even students of the radiology. Something wrong. This is all right. Time there. There's some time in that. Okay now. So while we are looking at the lateral films, we find abnormalities hidden in the frontal view. And you can appreciate the shadow of the trachea coming till here and then bifurcating. This is the left main bronchus, this is the right main bronchus, and there are pulmonary vessels seen around. Then you see at the posterior costophrenicus, which is not seen on the PA film, and these are the domes of the diaphragm. The one which is seen all the way is left dome, and the dome which is seen only in the posterior two-third is left diaphragm, because heart is sitting over there. So to confirm the abnormalities suspected from the frontal film or PA film, we always need a lateral film. And the amount of radiation given to the patient on the X-ray chest, we had drastically reduced by introducing the DR technology to only 1 milliampere second per exposure, in comparison to a CR which is utilizing around 14 MAS. So you can imagine the radiation dose to the patient and to the surrounding has reduced by 14 times. Hilar structures are seen like this on the lateral film, as I explained you. This is the left main bronchus, this is the right main bronchus, this coming down. Then pulmonary vessels, this is left hilum, this is right hilum. If you are seeing a soft tissue ring around the hilar structures, then there is a possibility that these are lobulated soft structures coming. This indicates that there are enlarged lymph nodes, which are seen on the PA film like lobulated appearance, and they are irregular and lobulated. Sometimes radiographer may make you feel different by giving bad exposures or giving bad position. Then film become very difficult for us to understand, and it looks something abnormal is happening. So when it is a standard thing, you will find that everything is perfect, midline to clavicle distance is okay. Then we are not able to see much of the vertebral bodies through the heart shadow, but we must appreciate that we are only able to see the intervertebral disc spaces through the heart shadow. That is the most ideal film. So positioning is important. We should keep it as straight as possible. There should not be obliquity. Like here, if the patient is oblique, if it is perfect, then it is fine. If it is oblique on the right or oblique on the left or perfect, then you can feel the difference in the size of the heart depicted on the film. So heart will become smaller and smaller and smaller. So most ideal is midline. It should be perfectly positioned. When it is AP film, then it looks different. When it is PA film, it looks different. AP film, you will see the heart is enlarged and clavicles are going up, more up than the horizontal clavicle which are seen on the PA film. When the patient is erect, we are taking a film, then most of the pleural effusion is in the lower zone and in the right costophrenic angle. But if it is supine, it will spread like this along the lateral chest wall and on the back of the lung. So it will look hazy. whole picture will look hazy. Technical factors are very important. If the patient is positioned not well, or the tube centering was not perfect, the clavicle may go very up and heart may look little larger and ribs will look not perfectly. They will look like oblique. So positioning is very important. It is lordotic view and that is normal view. Kyphosis. Some patients has got kyphosis when the neck and chin of the head will appear on the upper part of the chest. So we have to be very careful that if there is a reporting of this X-ray, then this is nothing. This is normal because the patient is not able to extend the head like in ankylosing spondylitis. If positioning is not perfect, then there may be some difference in the mediastinal contour. Like little oblique, the heart border become very straight. And then we may get confused with the mitral stenosis in which the heart of the left side is totally straight. Depth of inspiration is very important. Patient should take a full deep inspiration so that his diaphragm is at least at the level of the 10th rib from the posterior side. Like here, patient has not taken full depth breath, so there are haziness and looks like coarsening of the markings or crowding of the markings. And 1 minute later, if we take the same patient, same exposure, diaphragm is at the right place and then lung looks perfectly normal. So these are the points which we should be careful about because sometimes technician might be not taking the picture perfectly. Body habitus is a very important thing. Like the person, if we are taking X-ray chest PA view of such a person, then it will look like this. All the soft tissues will be all around and lung will look so small and heart will appear apparently larger because soft tissues on the front of the chest are so thick that the patient goes a little away from the film. So distance from the film increases, then it will look larger. That's why we always take PA film because the heart is very close to the film and will not be much magnified. These are all films of the same patient taken within 1 month. And you may see how technician can fool a radiologist. It may look globular heart or enlarged heart. Mediastinum is very large, mediastinum is large, ascending aorta is dilated. Ascending aorta is dilated here also, but here it looks like more emphysema. Diaphragm is not having that good contour. We should look for the alveolar space filled with something like fluid or some mucus plug. So you might have seen the radiologist report like consolidation, air space opacities, fluffy densities, infiltrates. And non-specific are atelectasis, pneumonia and bleeding or edema or tumor. Silhouette sign is a very important thing in the interpretation of the X-rays, and this indicates the airspace disease. Obscuration of a normally seen border like diaphragm or heart border is a very important thing. If it is there, then we should suspect something wrong and there may be consolidation or a mass. Opacity with a sharp edge along a fissure is also very important. Like here, this is a X-ray in which you feel that things are fine, but if it is right diaphragm, which is obscured, then there is something infection or something wrong in the lower lobe. If it is right cardiac border, then it is middle lobe. If it is left cardiac border, then it is lingula of the lung. If it is left lower lobe, then the left diaphragm will be obscured. And lower lobe collapse consolidation will look close to the vertebral bodies. Here is a depiction on the lateral film that if we draw a line a little behind from the anterior costophrenic races to the D4 level and a horizontal line from the left main bronchus, then these are the lobe areas divide right upper lobe, right middle lobe and lower lobe. Similar way left will happen. What happened here, if we see carefully, there was a opacity, triangular opacity with linear opacities and some non-homogeneous irregular opacities obscuring the right diaphragm. But if the patient was intubated and then aspirated and then cuffed out, so mucus plug has gone out and the atelectasis has resolved. In the case of lobar atelectasis, there will be a shift of the fissure, rapid development and clearance. In case of atelectasis, air bronchogram, if non-obstructive, secondary signs are like mediastinal shift, elevated diaphragm, ribs closer to each other, or vague increased density. Like here, if we see, there was a faint opacity coming in the left pericardiac area, that's all. But next day, the whole lung collapsed and there was a clear opacity behind the heart. This is the heart border and there is the opacity, so left lower lobe collapsed. Like here, upper lobe is collapsed, trachea is little pulled to the right, horizontal fissure which was supposed to be here is gone, reached here, and right diaphragm is also little higher. But next day, the clearance is there and then the horizontal fissure is at the right place. Here, like the blurring of the right cardiac border, it indicates that the middle lobe is involved. Here is the middle lobe which is involved and then you can see the line. Horizontal fissure should have been here, it has reached here. Similar way, if we see carefully, we are able to see the left hilum, but there is a vague opacity here which is homogeneous and extending till the cardiac border. So this is the sign which indicates that something is wrong with the lingula of the left lung. And you can see whole lingula and anterior part of the upper lobe is collapsed, consolidated, and this is the fissure which should have been at the D4 level had reached up. So left upper main bronchus is involved in this disease. Pneumonia, hallmark sign of the pneumonia is air bronchogram. Air bronchogram I will show you. Air bronchograms are these black things where the air is there and rest of the lung is consolidated or solid lung. But when it is passing through the soft opacity, then something wrong. Here you are seeing a vague mass with air traveling up to the almost periphery. This is consolidation, but here it is not traveling and the air is reaching beyond this mass. So air is traveling through the mass, then this is a cancer or carcinoma or a mass lesion. Here, like to confirm the thing on the CT, you can see the air traveling up to the periphery and here the air is passing through the mass and you are seeing normal lung tissue beyond that. Here again you are seeing the horizontal fissure is here rather than up at the second rib. So this indicates that lower lobe atelectasis has happened, right cardiac border is not seen very clearly, means middle lobe is involved. So middle lobe is involved. Here again you are seeing the horizontal fissure and some opacity anterior to it. Superior to it. It means that upper lobe is involved. Right upper lobe, this consolidation is happening in the right upper lobe. Here you are seeing another opacity very close to the base of the lung. That is the opacity which is obscuring the right diaphragm on the posterior side. So this is left lower lobe, posterior basal segment. Right lower lobe, posterior basal segment. Again, opacity just below the hilum on the right side, which is seen here against the spine. So this is called as spine sign, and this represents the apical basal segment of the lower lobe involved. Again the same thing. If you see carefully, there is a opacity here which is seen over here, and these two vertebrae are involved. You can see irregular end plates and sclerosis. This may happen with the tuberculosis, which is very common in our country. Another vague opacity which is seen in the posterior side of the lateral film, and that indicates that this is again posterior segment of the lower lobe involved. Now we come to the different kind of X-rays. Here you see the spine is not having curvature. Rather it is straight or forward curvature. There is no normal kyphosis. So this is called as straight back syndrome, in which you will see heart is enlarged. This is the apparent enlargement of the heart and should not be reported, because on the PA film you see the direction of the ribs had changed. It has become oblique downwards. Another case, where you see a soft opacity on the left lateral chest wall, that is some soft tissue mass on the chest wall like epidermoid or something. But if you see carefully, there is a mass here, calcified mass. This is calcified gallbladder. So seeing whole of the film all around the image area is more important. You can appreciate probably. Pleural effusion looks like this. I had taken a picture of the massive pleural effusion. Sometimes there are small effusion where the costophrenic angle gets blunted. In case of pleural effusion, the lung collapses, so trachea remains in the center. But when massive effusion collects, it may shift to the other side. When the whole of the chest is full of effusion, it will start shifting things to the other side. But lung collapses in the volume, so intercostal space is little increased. Not much, but little increased. Here is another picture where you can see the collapsed lung and pneumothorax. There are no lung markings here, and lung markings are there on the left side. Here is a picture which shows mediastinum is wide. Mediastinum is not that thin as it should have been, and the patient is only 16 years. So problem is there. We can predict that this is something wrong with the lymph nodes. And when a CT was done, you can see all around anterior to the great vessels, there are lymph nodes, and large lymph nodes all around. And there was infiltration in the liver also. So that is because of the lymphoma. I hope that this much I could cover, and time is not permitting me. So I'll finish here with the kind permission of you. Thank you very much.
Thank you, Dr. Saxena. I think it is such a topic which can go on for a whole day. So, but because the basic idea of our Gangaram CME has been to give the overview of whatever is happening around us in a shortest format and time. So now we will start with the our next session, that is primarily a cardiology session, and I'll ask Dr. Ashish Jain to be on the dais. Dr. Kavita Tyagi, if she's here. Meanwhile, I can ask Dr. Anurag Yadav. बुला ले इनको. मैडम तब तक आप सेशन चेयर कर लो मेरे ख्याल से, जो कम हो रहे हैं. डॉक्टर आशीष जैन. आशीष जैन बाहर है, उसको बुलाओ यार. डॉक्टर आशीष जैन, ये बाहर आवाज जा रही है कि नहीं? इस स्ट्रक्चर में बाहर जाके आवाज लगा दे आशीष जैन. Have you given your talk? Okay. So you come on the chair and whenever Dr. Kavita Tyagi and Ashwin Mehta will, huh? बुलाओ ना यार. आउटसाइड है. हाँ बुला लो. एक आप एक डॉक्टर अनुराग यादव वहां पे लगा. यहाँ पे प्रोग्राम ला के रखो ना. ये प्रोग्राम. So now I request Dr. Ashwini Mehta, the renowned cardiologist of Sir Gangaram Hospital, to take this session forward.
Thank you so much.
And after 10 minutes, 15 minutes, we'll have the another hall is starting. You can choose wherever you want to sit.
A very good morning to all the delegates and all my colleagues who are there from Gangaram Hospital. I'd like to straight away start the session today without wasting much time, as per instructions of our very esteemed faculty. And today we have a feast of, cardiology and the cardiology related certain issues which are of interest to all of us, and more so, to our day-to-day practice. So the first talk is going to be given by Dr. Ashish Jain, and he's going to talk about the clinical practice guidelines for dyslipidemia management in India. So I'd like to request Dr. Ashish to take the stage, and we have very short and crisp sessions, just 10 minutes each. So we'd like you to finish just in 10 minutes.
Thank you, sir. Good morning, everyone. So today I will speak on the clinical practical guidelines for management of dyslipidemia. These guidelines are recently published by Cardiology Society of India just 1 month back. And the proud moment for us is that the chief author of, or the principal author of these guidelines is our chairperson, Dr. JPS Sahni, and the co-author is Dr. Ashwini Mehta, who is here only. So for the management of cardiovascular or other diseases, normally we are following all the European and the American guidelines. So why there is need of Indian guidelines, especially for management of dyslipidemia? The answer is here because we developed the coronary artery disease 10 years earlier, and more than 50% of patients are less than 50 years and more than 20% are less than 40 years. We are having high risk factor at young age for atherosclerotic diseases, hypertension, diabetes, tobacco, metabolic syndrome also. The central obesity, the prevalence is 40% in India. When we compare to the Western or global population, it is just 20 to 25%. We are having high incidence of atherogenic dyslipidemia, that is high triglyceride, low HDL, and high amount of small dense LDL. There is a study, Eureka study called, the prevalence is 41% in the India, while Western population is just 20%. And the genetic causes also, the familial hypercholesterolemia is present in more than 15% of patients who present with the young CAD, while Western population is just 10%. And high amount of LPA also, the prevalence of high LPA, the level of LPA more than 50 is present, 25% in the whole general population, 35% in the patient who are having coronary artery disease, and more than 40% in patient who are having familial hypercholesterolemia. Apart from that, a sedentary lifestyle along with unhealthy cooking and dietary patterns, being a vegetarian because we are doing high consumption of carbohydrate diets. So that's why there is a need of separate lipid guidelines for our country. And this is the recent paper in the Lancet by ICMR on epidemiology of dyslipidemia in the India. And this is the study of more than 1 lakh population. On what they found, that the prevalence of dyslipidemia in our country is 81.2%. If we see the hypertension, the prevalence of hypertension in our country is just 35%, diabetes is just 11%, but when we see for the dyslipidemia, the prevalence is 81%. And the definition they used is the standard NCEP definition: if the LDL level more than 130, triglyceride more than 150, and the HDL level less than 140. And what they found that if we see the hypercholesterolemia, it is more prevalent in the northern part of India, Rajasthan, Haryana, Punjab, Chandigarh, and the north, and in the south, the Goa and the Kerala. While we are seeing for the hypertriglyceridemia, it is almost uniformly present all over the India with very little rural or urban difference. Similarly, for low amount of HDL cholesterol, it is also uniformly present in all over India, while high LDL, again, it is more prevalent in the northern part of India and the Kerala and Goa. So the message is that the low HDL and high triglyceride is uniformly prevalent in all across the India, while high amount of LDL is more prevalent in the northern part of India. And after treating the LDL since last 25 years, we know that high is bad, average is not good, lower is better. And after the outcome of Fourier, that is use of PCSK9, we know that even lower is even better. And after ODC outcome, we know that lowest is best, especially for the LDL. So today I will discuss just brief in these CSI guidelines. So whenever any patient who came to us with the deranged lipid profile, we have to classify patient into the 5 categories. So I'll normally before these guidelines, we were following the European guidelines. So I will discuss what new in these guidelines. So first category is the extremely high risk that is not mentioned in the European guidelines. They have mentioned just if any patient who present of ASCVD present with recurrent vascular event in next 2 years, the LDL target is less than 40. And that was also class 2B recommendation. But here they strongly recommend that LDL should be less than 40. And in all other American and European guidelines, the primary goal is just to control the LDL. But these guidelines mention that our co-primary goal should be to control the non-HDL also. And what is non-HDL? It is very easy to calculate. Total cholesterol minus HDL is non-HDL. So we have to control LDL also and non-HDL also. So the new in these guidelines is that they have mentioned patients who are having ASCVD plus heterozygous familial hypercholesterolemia and elevated LPA. The lipid goal is LDL should be less than 40 and non-HDL should be less than 70. So this is new mentioned in these guidelines. And when I'm coming to the third category, that is high risk category, the European guidelines mentioned that if the blood pressure is more than 180 by 110, then the LDL level should be less than 70. But these guidelines mention that any patient who is having hypertension, there is no clear-cut cutoff for that. If any patient blood pressure more than 140 by 90, having one or more risk factor or any other target organ damage, in such patient, the LDL should be less than 70 and the non-HDL should be less than 100. So this is new in these guidelines. And the third thing is patient who are low risk, like patient who are having no risk factor. The European guidelines are saying that LDL should be less than 115. But for Indian population, these guidelines mention that LDL should be less than 100 and non-HDL should be less than 130. And for our country, we are not having any type of risk calculator like European and American countries. So we have to look for the risk factor: diabetes, hypertension, central obesity, psychosocial stress, lack of physical inactivity, smoking. So these are the risk factors. So how to manage the patient of dyslipidemia in the acute coronary syndrome? So for acute coronary syndrome, we have to do non-fasting lipid profile within 24 hours. There is no need to do fasting lipid profile because it doesn't change the LDL and the HDL level, just only triglyceride level. They were elevated by just 27 milligram per DL. So there is no need to wait for the fasting. So in such patient, the message of guidelines is that we have to hit hard and hit early. So we have to start with the maximum dose of statin plus ezetimibe. So European guidelines recommend that we have to start with just maximum dose of statin, but these guidelines are saying in patient who presented with acute coronary syndrome, we have to add ezetimibe also. So we have to start with either 40 mg rosuvastatin plus 80 atorva and plus ezetimibe 10 mg OD. And then we repeat the lipid profile at 4 weeks. Patient of ACS are definitely very high risk. Our target is LDL should be less than 55 and HDL should be less than 8, non-HDL should be less than 85. So we repeat lipid at the 4 weeks. If still the LDL is more than 55, then we have to add the bempedoic acid. So this is something new. We can add bempedoic acid even at the 8 weeks if your lipid goals are not achieved. And despite that, if your LDL is still more than 55, then we can think about the PCSK9 inhibitor or inclisiran. And these guidelines mention that especially elderly patient whose age is more than 75 years and the CKD patient with the stage 3 to 5, we start with the moderate dose of statin, 40 atorvastatin and 20 rosuvastatin plus ezetimibe. So these guidelines enforces the use of combination therapy, especially for acute coronary syndrome. Similarly, for the stable angina patient, we know that stable angina, the annual mortality is very low, just 2%. So in such patient, we have to start with moderate dose statin like rosuvastatin 20 mg and the atorvastatin 40 mg. We repeat lipid at 4 weeks. If the LDL is more than 55, then we have to add ezetimibe at the 8 weeks. If the lipid is not controlled at the 8 weeks, then we have to intensify the statin. Now there is a question why we are not starting the high dose of statin at first. The reason is that if you are increasing the dose of statin from 20 rosuva to 40 or 40 atorva to 80, the reduction in lipid is just 6 to 8%. But if you are adding the ezetimibe, the reduction is more 10 to 15%. The side effects like statin associated muscle symptom, they are more common with the high dose of statin, and the compliance of patient is better because now we are having a single pill also, that is combination of ezetimibe plus this also. So these are something new. And for triglyceridemia, these guidelines mention that we have to, patient whose triglyceride are more than 150, our target to achieve the non-HDL also, just by lifestyle modification. We have to look for the other secondary causes, diabetes, hypothyroidism and other things. And if the triglyceride is controlled, then okay. And the lifestyle modification are same. We have to reduce the intake of carbohydrate, alcohol, abstinence, tobacco, increase physical activity. But if the triglyceride are between 150 to 499, then for prevention of atherosclerosis or patient who are having risk factor like diabetes, then our target to control the non-HDL by using statin, non-statin drugs. And if patient is having ASCVD, then definitely we can add the icosapentaenol ethyl acid, omega-3 fatty acid can be used. So the question is, normally when patient to present with the triglyceride 350, we directly start with the fibrates. But fibrates is having no role here. We have to start with the fibrate if the triglyceride is more than 500, just for prevention of pancreatitis, because there is no benefit in the cardiovascular mortality, especially we are using the fibrate. So along with fibrate, these guidelines also mentioned the addition of saroglitazar. There is a PPAR alpha inhibitor. This is a new drug that is not also mentioned in the European guidelines. And for heterozygous familial hypercholesterolemia, we know any young patient to present with the acute coronary syndrome or coronary artery disease, we applied a Dutch lipid criteria. If the score is more than 6, it is a FH. And again, our target is less than 55. And we have to start with the maximum statin plus ezetimibe. If not controlled, then we have to add the bempedoic acid and then PCSK9. The message is that if we diagnose a patient of heterozygous FH, then our target not only to diagnose a patient, but we have to do the cascade or genetic screening, because we are diagnosing a family that is risk of developing coronary artery disease at early age. And if the patient who are carrier of the FH means if the adult LDL is more than 160 or the children it is more than 150, then we can start with low to moderate dose of statin. So the message is our guidelines are not much different from European guidelines, and we believe that along with LDL we have to control the non-HDL also. Early use of lipid lowering therapy, combination of statin plus ezetimibe, rather than only high intestine therapy alone will achieve the goal in most of patients. FH is common in the young MI patient, more than 15%, and the control of LDL and non-HDL, we know earlier is the better, lower is the better, longer is the better, and together is the better. We have to use combination of statin and ezetimibe. Thank you very much.
Yeah. Thank you, Ashish, for the wonderful talk. So the message is very clear that hit hard and hit early. Get the cholesterol level down very, very low, and don't be afraid if you see cholesterol levels of LDL, say 20, 30. So there is a tendency to stop statins, reduce statins. Don't do that, because these are lucky people who are going to be having maximum benefits. Today, we have evidence that whatever level is the LDL cholesterol, even if it's 20, 30, it's not going to create any problem, even 10. So the message is very clear, which he has given. Hit it hard, hit it early, and to achieve this, you need to use high-dose statins, mainly with combination. If there is any question, we can quickly take one question. No, it's not rare if you use high-dose statins. You know, there is a lot of evidence from various studies where the cholesterol level has reached in 10s and 15s and even less than 10. So they have been studied for a very long time, and there are mutations which are present in normal population also, Mendelian mutations. Studies have shown people who have 10, 15, they suffer from no problems. And even in the studies, like he talked about the 4-year study, where the cholesterol level really dropped down with PCSK9 and combination, there was no issues which were reported. The evidence is that when you get the cholesterol down, less than 33 also, the curves still are reduced. There's an additional benefit. So that is the point. No, that is not because of lipid. That is because of sudden cardiac death. That is not related to lipids. So the message is very clear. Lower is better, and it is absolutely safe. Yeah, Dr. Ashish will answer this.
Yes, we have to control the LDL, because all the guidelines are saying the primary goal is to control the LDL also. But these guidelines are saying along with LDL, we have to control the non-HDL also. For Indian population, they mentioned even in a healthy individual, our LDL level should be less than 100 and non-HDL level should be less than 130.
The focus is LDL only of all guidelines. Today, the evidence exists. ASCVD, atherosclerotic cardiovascular disease, is related to LDL. That's the molecule we have to look at. Quickly, Ashish,
there is no role of ecosprin right now. There are all 3 trials, ASCENT trial,
for
ASPIRIN
primary
trial.
prevention.
They have clearly shown that aspirin is not at all beneficial for primary prevention. Especially there is some subgroup analysis they are saying, especially in the old age patient, because they are having peripheral arterial disease and the carotid disease, in which patient you can consider the ecosprin. But for in point of the cardiovascular disease, for primary prevention, there is no role of aspirin. You have to control the LDL and non-HDL level by using statins only.
No, that is not now. The evidence has come overwhelmingly in favor. I think for the sake of time, we quickly move forward. And we have, thank you Ashish, he is a brilliant young cardiologist, the latest addition to our Gangaram cardiology family. And we also have another brilliant cardiologist, Dr. Kavita Tyagi, who is going to talk about chest pain. How do we approach chest pain? There is a dilemma in all of us. How do we take care of patients who have chest pain? So she is going to shed some light on it.
Thank you, sir. A very good morning, everyone. And so chest pain is the commonest issue we face day in and day out. One of the most common reasons that people seek medical care. But history taking remains most important as far as our approach to chest pain is concerned. So we can see in this figure that the quality of the pain, the type of pain patient describes will lead us to think of probability of ischemia. So if we see this, if the chest pain is central, it is pressurizing, it is squeezing in nature, it is heaviness, it is tightness, it goes more in favor of ischemic chest pain. But if it is sharp, fleeting, shifting, pluritic, positional, it goes very less in favor of angina or ischemic chest pain. So history taking remains most important as far as approach to chest pain is concerned. Now, if we see this in all age group of people, starting from 18 years up to more than 80 years, non-specific chest pain remains most important cause of chest pain. However, we have to understand other causes of chest pain also. So we have to rule out ischemic origin of chest pain. Now, so after history taking, after we understand that this pain could be ischemic or non-ischemic, what is next? Next remains ECG, which is central to the evaluation of stable angina in office setting to ensure that ACS is not missed. Early recognition of STEMI obviously improves outcome. So regardless of the setting, an ECG should be obtained and interpreted within 10 minutes of patient arrival. Troponin is most sensitive test for diagnosing acute myocardial injury, and in conjunction with other essential clinical data, say history examination, ECG, its measurement is necessary to implement appropriate therapy. Delayed transfer to the hospital for determination of troponin or other diagnostic testing beyond the ECG in the office setting can be detrimental and should be avoided. So how we approach patient comes to the chest pain, we take proper history. Then we do physical examination and we do ECG. And ECG not only diagnoses STEMI elevation, but there are so many other things which ECG can diagnose, say diffuse ST elevation consistent with pericarditis, ST depression with new TAV inversions. It could be non-ST elevation MI, we have to follow non-ST elevation guidelines. It could be non-diagnostic or normal ECG, which will guide us to repeat ECG if symptoms persist or change or if troponin is positive. Or we should do for lead V7, V9 for posterior MI to see. Or we can pick up any new arrhythmias, then we have to follow the specific arrhythmia guidelines. So after history taking, ECG is the next thing which is important. When ECG is non-diagnostic, it should be compared with previous ECG if available. A normal or unchanged ECG is reasonably useful but not sufficient to rule out ACS. So decision making should not be based solely on a single normal or non-diagnostic ECG. LVH, left middle branch blocks, LV pacing, ventricular pacing may mask signs of ischemia or injury. Up to 6% of patients with evolving ACS are discharged from emergency department with a normal ECG. In patients where the initial ECG is normal or is without ST elevation, hyperacute T waves, left middle branch block or ST depression, serial ECG should be performed and management should be guided by new ECG changes or other diagnostic testing. The timing for repeat ECG should also be guided by symptoms, especially if chest pain recurs or a change in clinical condition develops. So we follow our patient like this. If patient has high risk of major CAD event, it could be ACS, and then we will plan for invasive angiography. If patient is high risk, then we will plan, depending on its patient's risk, we plan for some anatomical or functional testing. Low risk, we may defer testing or we may do repeat ECG or coronary angiography, CT coronary angiography scans. And patients who are asymptomatic, there is no testing required. So these are the consideration we take into account when we evaluate chest pain. So we take account pre-test likelihood of CAD also. In case it is low likelihood, no testing is necessary. If it is intermediate and people who are younger than 65 or less obstructive CAD you are suspecting, then coronary CT angiography should be favored. If intermediate high risk and people are older than 65% or more obstructive CAD you are suspecting, depending on the history or maybe ECG findings, then stress testing can be favored. So the features which favor use of CT coronary angiography to rule out obstructive CAD and to detect non-obstructive CAD. It is high quality imaging and expert interpretation routinely available, and people of less than 65 years, likelihood of obstructive CAD is less, so we can rule it out, and prior functional study is inconclusive. In these cases also we should do CT coronary angiography. The features which favor stress imaging, ischemia guided management, high quality imaging expert interpretation routinely available, age more than 65%, and if CCTEG is inconclusive. So stress testing information, if patient is capable of exercise, we should do exercise test, stress echocardiography, SPECT MPI, or pharmacological stress depending on patient's clinical profile. So acute chest pain, yes, history physical examination, ECG. Potential cardiac cause, is it STEMI? We follow STEMI guidelines. We have to immediately transfer patient either to the STEMI capable center, or if STEMI capable center is far from the patient and you have diagnosed STEMI, then at least thrombolytic therapy. If it is not STEMI, then evaluate based on suspected etiology using patient's centric algorithm. Say STEMI elevation, acute aortic syndromes, we can find out, sometimes pulmonary embolism, acute myopericarditis, and valvular heart disease. So, now take home messages for the evaluation and diagnosis of chest pain. Chest pain means more than pain in the chest. Pain, pressure, tightness, or discomfort in the chest, shoulders, arm, neck, back, upper abdomen, or jaw, as well as shortness of breath and fatigue should all be considered anginal equivalents. High sensitivity troponins preferred. High sensitivity cardiac troponins are preferred standard for establishing a biomarker diagnosis of acute MI, allowing for more acute detection and exclusion of myocardial injury. Early care of acute symptoms. Patients with acute chest pain or chest pain equivalent symptoms should seek medical care immediately. Although most patients will not have cardiac cause, the evaluation of all patients should focus on early identification or exclusion of life-threatening causes, STEMI and arrhythmias. Share the decision making. Clinically stable patients presenting with chest pain should be included in decision making. Information about risk of adverse events, radiation exposure, cost, and alternative options should be provided to the person discussant. Testing not needed routinely for low-risk patients. For patients with acute or stable chest pain determined to be low-risk, urgent diagnostic testing for suspected CAD is not required. Clinical decision pathways for chest pain in emergency department and outpatient should be routinely done. Chest pain is the dominant and most frequent symptom for both men and women, ultimately diagnosed with acute coronary syndrome. Women may be more likely to present with accompanying symptoms such as nausea and shortness of breath. So for females, we have to consider these symptoms very seriously. Identify patients most likely to benefit from further testing. Patients with acute or stable chest pain who are at intermediate risk or intermediate to high pre-test risk of obstructive CAD will benefit the most from cardiac imaging and testing. Non-cardiac word is in and atypical word is out now. Non-cardiac should be used if heart disease is not suspected. Atypical is the misleading descriptor of chest pain and its use is discouraged. Structured risk assessment should be used for patients presenting with acute or stable chest pain. Risk for CAD and adverse events should be estimated using evidence-based diagnostic protocol. So take home message for the evaluation diagnosis of chest pain. We follow these words. C for chest pain. Chest pain means more than pain in the chest, and we have to evaluate the quality of chest pain as I described in my first slide. Then second is we go for high sensitivity troponin. We go for early care, especially for STEMI. It is we should not miss any STEMI. Either we should transfer it to STEMI capable centers or we should thrombolize the patient at the earliest. Share decision, we have to inform patient and family about everything. Then testing not routinely required for low risk patients. Pathways, we have to use clinical decision pathways like low probability, intermediate probability, and high probability. Then women may be more likely to present with accompanying symptoms. We have to take that into account. Then we have to identify patients most likely to benefit from further testing. Then non-cardiac is in and atypical is out. We don't have to use this word atypical. And our approach has to be structured risk assessment. Thank you.
Thank you, Dr. Kavita, for a very lucid presentation. Can we have any questions if they're there?
Sir, if I have clinic, I have diagnosed STEMI with ECG. Sometimes it is out of position with the patient. What should I give at the clinic before transferring to the?
So you should load a patient with the aspirin 325 mg and clopidogrel 600 mg, preferably, and atorvastatin 80 mg. If patient is having pain, then you can think of giving some painkiller also, but injection pantoprazole and injection MSET should be given. Minimum these 4 or 5 medications should be given.
You mentioned ECG 10 minutes after arrival. Do your ambulances not have an ambulatory ECG?
मैंने मीटिंग में हूँ अभी थोड़ी देर में बात कॉन्फ्रेंस में
But your patient has to reach an ambulance for that, no? If patient is coming from home to your clinic.
Sending an ambulance. Number two, you mentioned timing of ECG. Don't you do continuous monitoring in your ICU?
No. In our ICU and CCU, we do continuous monitoring. Here we are talking about the patients who approach our clinic, who reach our clinics with the chest pain. So any patient comes to us with the chest pain, at least ECG should be done within 10 minutes of patient arrival.
Yeah, can you send me on WhatsApp? Yeah.
Madam, we are staying in Delhi where the traffic is.
Just send me on WhatsApp, I'll call you back.
Coming from say 25 kilometers, and you diagnose that this is definitely going to be MI. What should be done in the way the patient may expect?
Sir, that is why I told you that thrombolysis is also a accepted therapy. And if we think that patient is going to take far more time, we are staying away from the STEMI capable center, then we should not be afraid of thrombolizing the patient.
No, but I think what he means is sitting in the clinic, if he sees a patient of MI and he wants to send to a hospital. So that's what he wants. So he wants to know that before sending the patient, what he should be giving to the patient.
So that the loading dose is to be given.
Yeah. So what is the loading dose? I think he wants clarity on it.
So we give Disprin 325 mg. And
One full tablet,
one
complete
full tablet of
325.
Disprin 325 dispersible, and clopidogrel 600 mg, and atorvastatin high dose, that is 80 mg we give. These 3 tablets should be given.
Thank you so much, Dr. Kavita, for a wonderful presentation. And thank you. And I think now I'd like to call Dr. Elvin Daniel, who is our cardiac anesthetist. And I think we are going a little late, so I would request Dr. Daniel to quickly complete it. And he's going to talk about the drug-induced syncope in general population and how it is managed. I think he's loading the slides. I'll request another speaker. Madam, if you're ready. I'll request Dr. Anurag Yadav, who works very, very closely with us, and every day we get enlightened by, the CT angiography, which she does. And this is the new modality, and it's rapidly taking over. So I'd like to request Dr. Anurag Yadav to talk about CT angiography, when, how, and what.
Hi, good morning. I'll be talking about CT coronary angiography. All of us want to order it, but then the question always arises, when do we order it? When do we order a CT coronary angiography, and when do we order an invasive coronary angiography? So we have to see whether the study is appropriate for the patient. That means that the expected incremental information that we are going to get from the study should be better than the negative consequences of the study. So we go by the recommendations of the American Heart Association. We have the level 1, the level 2 recommendations when a CT coronary angiography is suggested. First is the level 1 recommendation: patients who have had a prior CABG, presenting with acute chest pain but not an acute coronary syndrome, patients with suspected acute aortic syndromes, pulmonary embolism, and then the patients who are stable, intermediate risk patients who have inconclusive or mildly abnormal ECG or a stress test, symptomatic patients who have a known non-obstructive CAD, but to determine what is the atherosclerotic plaque burden and the progression to obstructive CAD, that is how they are progressing, and to guide therapy. Or patients who have intermediate risk, but the stress test is negative, but the clinical suspicion of CAD is very high. And patients who have a suspected acute pericarditis. And patients with chronic or stable coronary artery disease, we incorporate CT coronary angiography along with or without a non-invasive testing for stratifying them into low, intermediate, and high-risk candidates. And patients who have already had a stent or a CABG, if those patients present with change in symptoms or functional capacity, it is suggested that you undergo a CT coronary angiography. So what are the advantages? It is non-invasive. There is a 3D reconstruction. We do not need any difficult vascular access. Patients who are already on anticoagulants do not need to stop their therapy. we can see extracardiac symptoms, structures, which may be the cause of chest pain. And the patient does not need any particular preparation for the therapeutic process, because once we diagnose the patient, then he can be fully counseled and then taken up for stenting or CABG, and it saves time in a busy setup like ours for cardiac catheterization only. So how do we perform it? It is mostly the patients will ask us, or they will ask the referring physician, how the CT coronary angiography. It is just as simple as a CT chest done. We need a serum creatinine report. We need the patient to be 4 hours fasting, but well hydrated. We give medicines like beta blockers or calcium channel blockers to reduce and stabilize the heart rate. And we may need to give an SA nodal blocker and anxiolytic. And patient has to practice breath holding for 7 to 8 seconds. This is just the preparation required. We advise the patient to not have smoking or do smoking or alcohol or any vigorous exercise before that, because it leads to cardiac stimulation and it is difficult to control the heart rate after that. The scans can be done retrospectively or prospectively, that is, these are all ECG gated. Retrospectively, these are very technical things, but we can see that retrospectively the radiation dose is about 5 to 15 millisieverts. But if we do a prospective scan, that is, we do it only in 175% of the cardiac cycle, the scans are just as good and the radiation dose can be reduced to less than 3 millisieverts. So these are the kind of techniques we prefer now, so that we get closer and closer to cardiac catheterization techniques. So what do we do? Now this is the most important thing. If we have prepared the patient well, the interpretation of the scan is very easy. We look for the normal anatomy, we identify the left main, the left anterior descending circumflex, the right coronary artery, the circulation, whether it is a dominant, which is the dominant circulation, whether it is a right dominant, left dominant, and co-dominant. So depending upon the dominance of the circulation, the importance of the stenotic lesion in the different segments of the coronary arteries changes. The types of plaques we see are non-calcified, partially calcified, low attenuation, and calcified. So we have to classify the kind of plaques that we are seeing. And then we have all the talks about the vulnerable plaques, which are the low attenuation plaques with a remodeling index of more than 1.1, a napkin ring sign. That is, there is a hyperdense kind of a rim outside the plaque, which we can see. And the interpretation, like mostly everybody will say, how does it score over a catheter angiography? Like, is it as good or is it not? So we would say that it has a sensitivity and specificity of almost 95 to 97%. And in patients with CABG also, this specificity is almost 100%. But in patients who have stenting, the sensitivity is slightly lower because of the blooming and the beam hardening artifacts. Then when do we ask for a calcium score? Calcium score is typically quantified as the Agatston score, which we all are aware of. It is the sum of the attenuation of the calcium and multiplied by the area of the calcified lesions. So if you have a report which says a calcium score of 0, that means that the patient is at a very low risk of coronary artery disease in the future also. And a calcium score of 1 to 100 is mildly increased, 1 to 100 to 300 is moderate, and more than that is severe. So if the plaques are calcified, it becomes difficult to interpret the scans because the calcium is also bright and the contrast is also bright. So if a plaque is more than 70% calcified, sometimes it becomes difficult for us to categorically state that amount of the severity of the lesion. So when do we ask the patient to rescan? Say if the patient is low risk according to the calcium score that we have seen, we will advise that the patient can undergo a repeat calcium score after 5 to 7 years, intermediate risk after 3 to 5 years, and high risk after 3 years. So is a 0 calcium, say now if there is a patient who is about 40 years old and the calcium score is 40, is 0, that has a different interpretation vis-a-vis if there is a 70-year-old man and he has a calcium score of 0. So it is like fine wine. If you are older and you are at a higher risk, but you have a calcium score of 0, it is better than a patient who is younger. That means your risk of coronary artery disease is lower. And on statin therapy, we had a lot of talk about statin therapy. When the statin therapy is initiated, we do a baseline calcium score, and this increases. The plaques become stable after after statin therapy, and they become less high-risk plaques over there. They stabilize. The plaque signature in men versus women is different. Men have larger lipid cores. They have greater calcification and higher calcium scores. They have thicker fibrous caps, and they have more obstructive disease vis-a-vis women. We give a CADRAT score with it depending upon whether the stenosis is minimal, moderate, severe, and whether it involves the left main artery, and then whether they are focal or they can be diffuse, or they can be a total occlusion, which we can see. So to recapitulate, when we see the scan, we need to know these 5 things: whether the scan is normal or abnormal, the stenosis is less than 50% or more than 50%, is the left main coronary artery involved or not involved, is the stenosis focal or is it diffuse, and if it is focal, is the plaque vulnerable or not vulnerable. In addition to it, we also have something called the epicardial fat volume, which we can use as an independent risk factor to see the atherosclerotic burden of the patient.
Madam, just a request to hurry up a bit.
Yeah, sorry.
Yeah, just hurry up a bit.
The stents and bypass, we can see whether there is any occlusion of the stents, or there is any peristent stenosis which has developed, or there can be an extraluminal migration of the stent. And in the grafts, we have the arterial and the venous grafts. We can see the radial and the Lima grafts in these patients, or the venous grafts. We can evaluate patients, young patients presenting with chest pain for coronary artery disease, for coronary artery anomalies like a single coronary artery, anomalous origin of the coronary artery from an opposite sinus with a malignant cause, or those with anomalous origin of the arteries from the pulmonary artery, a coronary cameral fistula, coronary bronchial fistulas, and so on. So cardiac CT is also recommended, as we saw in the recommendations, for a triple rule out, that is aortic dissections and pulmonary embolism, and at the same time to evaluate the pericardium or aortic aneurysms. Then we have the FFR CT, which is a CT with the FFR, in which the computational flow dynamics can actually say what is the gradient across stenosis and whether it needs any stenting or therapy. So the take-home message is patients who present with non-cardiac or cardiac chest pain or mimics of angina equivalent, as Dr. Kavita told us, low to intermediate probability of CAD or non-obstructive CAD, to evaluate the risk, the progression, and to guide therapy, patients post-CABG and post-stenting, and suspected coronary anomalies in young adults, and patients for triple rule out in the setting of acute coronary syndrome. Thank you.
Thank you so much, Dr. Anurag. That was a wonderful presentation. And we are now learning more and more and using more and more of CT angiography. Earlier, we were doing a lot of invasive in most of the patients. But today, what technology has done, if there is a suspicion, there is a technology available for you to look into the coronary arteries and be sure. And she talked about another very interesting thing, the triple scan. When you're in doubt, the patient has got chest pain, breathlessness, you're not sure, you get the triple scan done, you rule out 3 things. The 3 big killers: dissection of aorta, pulmonary embolism, and coronary artery disease. So wonderful presentation. Any question, if it is there, we can quickly take 1 or 2 questions.
Role of CT angio in the cardiac checkup.
Yeah. Madam, please.
See, in patients with low to intermediate Framingham risk score, we advise that they get a CT coronary angiography, one to see if it is the baseline, and also to see if we establish that the disease is non-obstructive, that is less than 50%, and then as a follow-up, to see what is the progression, and also to guide the therapy. Like we can say that, okay, this is the character of the plaque, so the cardiologist can decide what therapy can be instituted for the patient.
Yeah, so I think what you really want to know is that if you're doing an sort of a checkup, executive health checkup, without any evidence of disease or something. So many places now it is a part of executive health checkup because it gives an additional information. But what Madam is trying to say is that patients who are at a little higher risk, say patients who are aged more than 50 years, 45 years, having risk factors, they are the ones who should be undergoing. And definitely it should be a part of the preliminary checkup. In the various our cardiac association guidelines, they do say now that you can do a CT to pick up the coronary artery disease rather than doing a treadmill test, which can be erroneous. Any other questions, sir?
What is the percentage of false negative reporting? Is it because of the machine taking the scan or because of radiologist reporting?
See, it is the machine has a role to play. The higher the strength of the machine, like if it is a better machine, it is easier to pick up the stenosis. And it is not to pick up the stenosis, but to be able to see the type of plaque that we can see over there. And if the plaque is very heavily calcified, as I told you, the calcium is also bright and the contrast is also bright. Then to differentiate the amount of stenosis, the degree of stenosis becomes difficult. And of course, the radiologist has a role to play. No, it is not a difficult question because I'm telling you, everybody who just qualifies into doing a MD radiology or a DNB radiology, it would be difficult. I have been practicing it for the last 20 years, and I would definitely say that my expertise in the subject is much better because we do get reports from outside, and they are reported differently. So we do have to report them again.
Yes, in fact, I'd like to share that it's what has been our journey. You know, we've been using CT angiograms for a pretty long time. And now I can very confidently say that in the last couple of years, the level of reporting what they have achieved is very, very close to the gold standard, which is the angiogram which we do. And this is just because they have been doing it so meticulously over the years. So thank you so much. It was a wonderful talk. I'd like to invite Dr. Elvin Daniel, who is our cardiac anesthetist, and he's going to talk about the drug-induced syncope in general population. Elvin, if you could be very brief because we are running short of time.
Yeah. Good morning, everybody, and thank you, Sir Gangaram Hospital CME, for this opportunity. The topic for my discussion today is syncope, drug-induced syncope, orthostatic, and its management. How we define it? Syncope is a sudden loss of consciousness and postural tone caused by transient decrease in cerebral blood flow. It is associated with spontaneous recovery. Syncope can occur suddenly without warning or may be preceded by a predome of pre-syncope, including lightheadedness, dizziness, but not true vertigo, nausea, a feeling of warmth, diaphoresis, and blurred or tunnel vision. What is the incidence according to Framingham study? It is 3% in male and 3.5% in women's. According to the United States data, 1 to 2 million patients are evaluated for syncope annually, and 3 to 5% of emergency visits department are for syncope. 1 to 6% of urgent hospital admissions are for syncope. This is what we are facing today. Causes of syncope are cardiovascular, due to vascular system, due to cerebral autonomic system. So why we need to identify syncope? For the prognostic and therapeutic reason, it is important to distinguish syncope from other causes of transient loss of consciousness, which include seizures, psychogenic seizures, hypoglycemia, pharmacological agents, or trauma. In one study, syncope has been misdiagnosed as seizure in 38% of patients who continue to have episodes despite adequate anticonvulsant therapy. So what is the mechanism? Under normal circumstances, there's when you stand up from a lying down position, the musculature system, the venous system, the autonomic nervous system, the renin, aldosterone, angiotensin system comes into play. The principal stress imposed when standing is produced by gravity displacing venous blood downward to a level below the heart. Although the renin, aldosterone, angiotensin system regulates long-term blood pressure response to upright posture, the autonomic nervous system provides the majority of the short and medium tone response to posture. In the supine individual, approximately 1/4 of the blood volume is in the thorax. On standing, there is a gravity-mediated displacement of between 300 to 800, some study says 500 to 1000 ml of blood to both the dependent and mesenteric areas. Approximately 50% of this displacement occurs within first few seconds of standing, resulting in a drop in venous return to the heart and a mean fall in stroke volume of approximately 40%. In the normal subject, accommodation to this change in posture is less than 1 minute. So, the normal mechanism during standing, the lower limb muscles contract, which are known as palm muscles. The venous system increases the venous return to the heart, and as a result, there is a slight increase in heart rate of 10 to 15 beats per minute, a minimal change in systolic blood pressure, and a 10 mmHg increase in diastolic blood pressure. So this is what happens when you stand up from a lying down position. So these are the mechanism which comes up to play and to normalize your blood pressure. This is the same thing. So types of syncope, it could be neurogenic, neurocardiogenic, which is known as vasovagal, which is the most commonest type. Situational, the fear of things, blood, needle, is a situational type. Postural or orthostatic, also known as postural hypotension. Cardiac, neurological, and postural orthostatic tachycardia syndrome, and idiopathic. According to the study, a brief discussion about the types of syncope. The postural syncope or orthostatic hypotension. Certain medications and dehydration can lead to this condition, and you define it as a drop in systolic blood pressure of 20 mmHg or a drop in diastolic blood pressure of 10 mmHg or an absolute value of BP of less than 90 mmHg. A cardiac syncope, any condition which predisposed to low cardiac output, any condition which predisposed to cardiac arrhythmias. You can be having an underlying obstructive disorders like aortic stenosis, which in conjunction with arrhythmia will lead to cardiac syncope. Postural orthostatic tachycardia syndrome. In this, there is an increase in heart rate of 30 beats per minute. It's more common in autoimmune conditions and in women's. So, coming to the drugs that cause orthostatic hypotension, there are we can't leave out any drug which doesn't cause. From all the cardiac drugs, nitrates, alpha blockers, beta blockers, diuretics and calcium antagonists, antidepressants, antipsychotics, benzodiazepines, trazodone and opioids. Coming to the nitrates, they cause vasodilatation, which decrease venous return, and most commonly used in chronic angina pectoris. The nitrates are known to increase the risk of hypotensive syncope and falls in older patients, regardless of drug dosage. Beta blockers, again, they are negative inotropic and chronotropic effects, and data from the Irish longitudinal study of aging demonstrate that monotherapy with beta blocker is associated with an increased risk of orthostatic hypotension during all phases of standing. A higher incidence of orthostatic hypotension has been reported for mixed alpha and beta blockers like carvedilol, particularly after the first dose. Clonidine is an alpha-2 agonist, and again it affects the vasomotor centers in the brainstem, which induce a decrease of sympathetic tone and norepinephrine plasma levels. Calcium channel blockers, it's conflicting. The dihydropyridines are considered to be safe, whereas hydropyridines are considered to be little associated with orthostatic hypotensions. Because of time, I'm not going into details. Calcium channel and the ACE inhibitors, they are protective, but you see the first dose effect in these medications. When the patient start these medications, he might experience the hypotension during standing. Diuretics are the main cause of orthostatic hypotension. They increase urine excretion of sodium and predispose to volume depletions. Loop diuretics increases the venous capacitance, thus reducing venous return and cardiac output. Electrolyte imbalance, and loop diuretics seems to be more prone than thiazide diuretics to cause volume depletions. Data on potassium sparing molecules like spironolactone is little scary. Drug acting on central nervous system like tricyclic antidepressant occurs in 10 to 50% of treated patients, vasodilating effect deriving alpha adrenergic receptor blockade. Orthostatic hypotension risk varies among single molecule according to their affinity for alpha receptors. There are alpha 1A, alpha 1B, and alpha 1D. So the alpha 1A and D are safe, whereas B causes orthostatic hypotension. Serotonin reuptake inhibitors, a vasodilating effect has been seen for fluoxetine, sertraline, and citalopram, mediated by inhibition of calcium channels and calcium-elicited vasoconstriction. And antipsychotic drugs like clonazepam, and quintiapine shows the higher risk. Yes, sir. Management of orthostatic hypotension, you have to investigate the patient thoroughly for anemia, which causes decreased volume in the body and can lead to hypotension. Blood pressure monitoring, electrolyte imbalance like sodium and hypomagnesemia, EKG, which is important, and Holter monitoring if single ECG cannot predict, 24 hours Holter monitoring, echocardiography, and a tilt table test. What is a tilt table test? You are lying in a position, supine position, being monitored, connected to a monitor, and the table is tilted up to 70 degrees, and you see the changes in your vitals. So non-pharmacological treatment mostly the non-pharmacological treatment predominates. The removal of the drug or change of the drug can help the patient. If not, then we have to go for the few available treatments. The non-pharmacological treatment is liberalization of sodium consumption, liberalization of water intake, 2.5 liters per day, sleeping with head of the bed raised, physical activity with recumbent exercise, stationary bicycle, rowing, or swimming, physical counter maneuvers like standing up slowly, leg crossing, buttock clenching, abdominal binders, and waist-high compression stockings. Medical management considered in severe form of orthostatic hypotension. And few drugs are midodrine, which is an alpha-1 agonist, which increases the peripheral vascular resistance, reduction of venous pooling, and increases the blood pressure. The dose could be 2.5 to 5 milligram in the initial phase and can be tolerated up to 30 milligram per day. Deroxydopa, a synthetic norepinephrine prodrug, and it is converted into norepinephrine. The dose is 100 milligram to 600 milligram as tolerated, and it is applicable in neurogenic orthostatic hypotension. Fluoxetine is a synthetic mineralocorticoid.
We've been told to
finish it. Yeah. So the take-home message, the goal of syncope work is to answer, is it really syncope, cerebral hypoperfusion? What is the underlying cause? Is it life-threatening? And the history is the single most important test for determining the mechanism of syncope, followed by a directed effect to exclude the life-threatening causes. Thank you.
Thank you so much, Dr. Alvin. It was a wonderful talk. And if we can have a question quickly, yes.
Congratulations, you covered it very comprehensively.
Thank you, sir.
Having clinical significance, I want to share most common cause in 50 plus population of syncope is medical treatment of prostate.
Yes.
So that is a practical point I wanted to share rather than pharmacokinetics.
Very, very true. In fact, that is one of the commonest cause which we come across in our day-to-day practice. Yeah. Any other question? No, liberalize wants that...
Fluid intake 2.5 liters.
No, he said that salt to be taken more.
More. Not 3 to 5 grams.
Many of the persons regarding ayurvedic and Western circulation, they are taking more of water. And I have seen patients suffering from hyponatremia.
Very true. Very true. Dilutional hyponatremia because they pass a lot of urine and the sodium also goes out. That's a very known fact. And in fact, I have found out many patients who come to us, with recurrent hyponatremia, this to be the cause. And you very nicely and rightly pointed it out. Thank you so much.
I would like to...
Yes. Yeah, I think after the session you can ask Alvin.
Now I would like to invite Dr. Ashwini Mehta to talk on reducing the risk of coronary artery disease, the present perspective. This is the final talk in this session.
Well, thank you so much. We've had a very nice talk. And, we had another colleague of ours who was supposed to come here and he got stuck in some emergency. And he was supposed to give a talk on congestive heart failure, 4 pillars of congestive heart failure. So, I'll just briefly tell you that how the therapy for heart failure has evolved. If you look at the current scenario, heart failure, if untreated, carries worst prognosis, even less life expectancy than many of the malignancies. So much so that if a patient has been diagnosed to be heart failure and is not being treated, then this person is most likely to die, not treated appropriately. 50% chance of death in a year, and by 5 years, the mortality rates are very, very high. But if you treat them, the mortality rates really improve, and one great change which has happened is evolution of the 4 pillars of therapy. You all remember, we were taught that beta blockers should not be given in heart failure. Now it has turned the whole way around. They are the drugs for heart failure. You have to give other drugs like the MRAs and something known as the RAS blockers. RAS blockers are the drugs which block the renin-angiotensin system, and it could be ACE inhibitors, ARBs or ARNI, any one of this. And I'm sure you are now aware of what is ARNI. Then the third group which has come up, interestingly, is the SGLT2 inhibitors. The drugs used for diabetes, and they were found that if you give this drug, even in non-diabetics, the heart failure improves. This is the another group. The 4th pillar is the MRA, mineraloreceptor antagonist. We've been using over the years, aldactone. So all these 4 pillars of treatment are very, very important. And we've been fortunate that in our hospital, we have been part of international research, and these drugs have come based on trials. ARNI came based on paradigm heart failure, and we were the principal investigator. In fact, I had the opportunity to be one of them. And also for the SGLT2 inhibitors like the Emperor studies. So, remember 4 pillars. Whenever you see heart failure, you give diuretic. That's fine. In acute situation, you need to give. But also need to give 4 pillars: beta blockers, RAS blockers, MRAs, and also SGLT2 inhibitors. Now, for the sake of time, I quickly come to my talk, and it is about reducing the risk of coronary artery disease. What is the present perspective? So I'll just tell you the epidemiology in very brief. Last century, you have seen in 1900s, there was an epidemic in the West, 60s, 70s, US, UK, Europe, Canada. They saw a very high incidence of coronary artery disease, and it's been going down there. And what is happening now in our part of the world, developing countries, middle income countries, it's been rising, and India is on the cusp now. So why it happens? Because changes in the lifestyle. That is the biggest problem. And what is the magnitude? Magnitude is huge. So every 34 seconds, a person dies in US of heart attack, and in India, it is estimated every 10 seconds. So that is the magnitude. Every 3 minutes, 17 seconds, a person dies in US of stroke. Then estimated in India, every 1 minute, a person dies of stroke. So you can imagine the magnitude of problem. We know that it is the biggest killer, and one of the very big surveys showed that more than cancers, it is the cardiovascular death that is the major driver. And it mimics high blood pressure and high cholesterol. If you see here, the red thing in the first graph, cardiovascular diseases. And similarly, the areas where BP is high, cholesterol is high, people have more heart attacks and strokes. So you need to take care. The evidence is very clear. This graph was also shown by one of my colleagues, that how hypercholesterolemia and triglyceridemia is rising in India. We also have very high levels of dyslipidemia. Whatever we say, high triglycerides, high LDL, low HDL, but it's very high. So number of studies have been done, 2 big studies, InterHeart and InterStroke. And now they looked at various causes, that when a person gets an MI, what could be the causes? A very nice study. India was also part of it. So if you look at the risk, you clearly see there are certain things which have a very high risk. First, smoking if you see, diabetes if you see, hypertension, central body obesity, psychosocial factors for the first time studied showed increased risk. Now in this study, in the inter-heart study, something very interesting was also part of this study. And they said that if a person is consuming more amount of fruits and vegetables, what happens? And they found that if a person takes more fruits and vegetables, the incidence of heart attack comes down significantly. First study to show. So that's what we all should do. Exercise has a role. Alcohol has a role. More role with stroke than with coronary artery disease. Now, one of the graph shows here ApoB and ApoA1. What is this? This is dyslipidemia. In other words, high LDL, low HDL. Cardiac causes itself can lead to more strokes. So these are the common causes which cause myocardial infarction. This executive clinical summary which we have published primarily from Gangaram Hospital, taking views of cardiologists all over the country, is the latest which is there. The risk assessment has already been discussed. So what I like to point out here is smoking cessation, weight loss, stress management, promoting physical activity, changing the dietary pattern can really help. These are the lifestyle changes which should be done. So what are the take-home messages? I'll briefly summarize. The most important way to prevent heart failure, atrial fibrillation, CAD is to improve the lifestyle. For all of us sitting here, it should be a team-based approach. We shouldn't hesitate to incorporate views of dietitians, incorporate views of our other specialists like endocrinologists, lipidologists. And any person more than 40 years, we should calculate a 10-year risk. And if this risk is high, then we should be treating them aggressively. And if the LDL is high, bring it down. That is one single thing that can really reduce the risk along with the lifestyle changes. Healthy diet, which means more of fruits and vegetables, more of whole grains, doing away with trans fats. What are the trans fats? Trans fats are the commonly fats which are generated when you heat the oils at a very high temperature. For example, the halwais when they cook, or whatever we eat, namkeens, or the chips, they are taken at a very high level. This generates trans fats and this can induce atherosclerosis. It should be avoided. Central body obesity again is very important. And then physical exercise, 150 minutes per week for moderate intensity is important for all of us. Whatever one likes should be doing. If we promote these, the risk can go down. Treat diabetes aggressively and use good drugs. I talked about SGLT2 inhibitors. There are today drugs which have shown if you treat for diabetes with these drugs, the risk of heart disease goes down. What are those drugs? SGLT2 inhibitors, GLP-1 RAs, so we should be using them. Advise patient to quit smoking. Aspirin has no role for primary prevention, failed, but for secondary prevention you can give. And statins should be given to all patients who are at a risk more than 40 years of age if they have diabetes or if they have any other significant risk factors. Non-pharmacological interventions and treatment is required for patients for blood pressure, and the goal I'm talking here is 130/80. Bring everyone's blood pressure down by 130/80. If you just reduce by 10, the risk of heart disease goes down by half. So that is the benefit which is there. With stroke, it is even more. Controlling blood pressure is very important. Many times during interventions, when we see patients, on the table we realize the BP is very high. And we think, oh, this man has come for the third time for intervention. And his cholesterol has not been bad. And we realize that this person is probably unaware of the risk of blood pressure. Believe me, one single thing which can save us is controlling blood pressure along with lipids. So remember this. This is another picture I wanted to show. Dr. Anurag has very nicely summarized. Use the available technology. When in doubt, use technology. Use CT. See the arteries. Be sure what is there. Today we have all this technology available. In Delhi, I think there are more than 50 centers where you can do the CT scans. Make sure it is done. Your patients are safe. rather than feeling sorry later. Then about cholesterol, lot of myths. Social media is a killer. One article published estimated that worldwide 16 million people are dying extra because of not taking care of cholesterol, because of the impact of social media. What comes on television, what comes on Facebook, what comes on WhatsApp is determining our choices. People don't go by facts. And the biggest myth is that cholesterol is not linked to heart disease. And so many other day, we keep on getting messages on WhatsApp, circulated mindlessly, creating so much of problems. Regarding statins, lots of myths are there. They cause this, that, and that. I'll not go in detail. But statins are the wonder drug, the single most drug which has shown to increase the human lifespan, much more than advances in any other field, even oncology and all that combined. Single drug, maximum impact on the lifespan. So for cholesterol, we now also have something beyond statins. My colleague talked about ezetimibe, wonderful drug. We have bempedoic acid, another drug. Now we have another very interesting drug, inclisiran. And we are at Gangaram Hospital doing trials for this. This is a wonderful way probably we'll be treating in future the patients with high cholesterol, just 2 injections in a year, and the cholesterol level really goes down. And I think this is the future. Thank you so much for your kind attention.
Thank you so much for a lucid talk, Dr. Mehta. Any questions?
No, madam, not at all. I distinctly remember, just a couple of years back, when we did not had much evidence regarding the high cholesterol, and say about 2 decades back, the evidence and the recommendations were that give baby aspirin to everyone to prevent heart attacks, and that was there. Number of studies have addressed that in elderly population, in middle-aged population, patients who have diabetes, and each of the trial has failed because if you look at the incidence of GI bleed, it is more than the benefit. So that is the reason it should not be given.
How much of statin can be given to diabetic patient? Non-hypertensive.
Now there is one very interesting trial which was done by the name CARD study. Now in this study, they looked at patients who had diabetes and who had normal or a low cholesterol. Patients don't have high, normal or a low cholesterol, and they gave them statins. And by giving them statins, the incidence of heart attacks, strokes came down. So you can imagine that with diabetes, even in patients with normal or a low cholesterol, you get benefits. So whatever dose you start, and today we are talking of good dosages. Gone are the days of 5 milligrams of rosuvastatin, 10 of atorvastatin. We need to hit it hard, need to hit it strongly, and need to hit it right in the beginning. So give these drugs right in the beginning. So whatever dose, maybe just start with 10 milligrams of rosuvastatin or 20 milligrams of atorvastatin, but do start.
You can try to 10 or 20.
Yes, then subsequently you can.
I want to ask you 2 questions. One is, should studies be taken throughout life?
The evidence today is clearly in favor of lifelong treatment.
In winter, we have a tendency to eat a lot of sweets, like gravy.
Now, this is something very interesting, and I am asked repeatedly in various forums. Now, the evidence today is that if you take carbohydrate, what happens to the carbohydrate? It is converted into fats in the liver, and that also contributes to cholesterol. So that does play a role. And interestingly, if you take the various kind of fats, certain fats, especially the unsaturated fats or saturated fats, certain amount of fats might not get converted to cholesterol, but the carbohydrate is converted to cholesterol. So the evidence is do not take lot of carbohydrates. In fact, this single change is thought to be the driver of atherosclerotic cardiovascular disease in the last 2 centuries. The sugar came about just about 2 centuries back, the discovery of sugar. And in the countries where it was introduced, first came diabetes, and then after about 50 to 75 years came coronary artery disease. So there is a direct correlation. with sugar. This is a wonderful question, and there is a lot of debate about statins. The biggest debate is regarding the body pains and muscular side effects. Now, if you really look, there have been studies which have compared with placebo. There is something known as a nocebo effect. It is opposite of placebo. If you give some drug to a patient which doesn't has anything, a tablet, that gives positive effect. But if you give something and the patient is thinking that he'll get side effects, he gets side effects. So they did number of studies and they found that statins and placebo cause same amount of body aches. So, but some patients in reality have body aches. So how to treat that? So number of pathways have been discovered, described. We are still learning. Take care of vitamin D. Try and give the coenzyme Q. Give statins which do not act on muscles, like pitavastatin in patients who are intolerant. Use combination of other drugs, like I talked about, bempedoic acid and ezetimibe, with statins, or they can even be given without statins. That's the way to treat intolerant. Both the statins are good. They have their own advantages. Rosuvastatin is more potent than the atorvastatin. No, it's not like that, ma'am. That's a myth. Well, I'd like to thank all of you for a very active participation. And with this, we'd like to close this session and hand it over to Dr. Harbanslal. He'll take it forward.
I'll invite Dr. Anil Balla for the next session. He is the Secretary General of Board of Management, Sir Gangaram Hospital, and Senior Consultant and Chairman of Nephrology Department. So he will be taking this session forward. Thank you.
Thank you for organizing such a wonderful academic meeting. May I invite Dr. Anurag Gupta, Senior Consultant from Department of Nephrology, Sir Gangaram Hospital, and Dr. Anurag Yadav to co-chair with me. So the first, we have 7 thoughts, and each speaker will be having 8 minutes for the presentation and 2 minutes for the discussion. So first thought will be, this is mainly actually nephrology, dialysis and transplant session. Plus, in addition, we have some surgical sessions also in this session for about 1 hour and 15 minutes. So Dr. Vinant Bhargav, he is a senior consultant in the Department of Nephrology, Sir Gangaram Hospital. He is going to deliver his talk on a very, very important and relevant topic to all the primary care physicians. That is how to slow down the progression of chronic kidney disease. We all know that diabetes and hypertension are the 2 common causes of chronic kidney disease, and you are the ones who are dealing with these patients at the initial stage before they come to nephrologist. So Dr. Vinant Bhargav, please.
Thank you very much, sir, and I welcome you all to this early morning session of nephrology. And what I'm going to try to talk to you about is about a very common disease and very dreaded disease, which is chronic kidney disease. And I'll try to take you down the lane of what we've been able to do to slow the progression of chronic kidney disease in the past few decades. Before that, we have to understand what chronic kidney disease is all about. So basically, you have to diagnose chronic kidney disease in your patients if you're looking at your patients who have at least 3 months or more of abnormalities in kidney structure or function. And kidney structure or function will obviously, if there's an abnormality in that, will lead to albuminuria or presence of some amount of urinary sediments. Also, you will see some tubular disorders in the form of phosphorus or calcium disorders. And you can confirm this with using the histology or the renal biopsy. And the most important thing is to also look at the size of the kidney and the architecture of the kidney using an ultrasound. So in a nutshell, if you have a patient who has a decreased eGFR of 60 or less over 3 months or more, then you will diagnose these patients as chronic kidney disease. And depending on the GFR, this is the kind of classification that you will do for your patients. It's important to know the classification because you will be able to predict what's the timeline course of these patients towards progressing towards end-stage renal disease and finally dialysis or maybe transplantation. And the reason we're discussing CKD today is because it's a major health problem all over the world. It's a drain on the economics of the country, and we have more diabetic population coming up over the last few decades, and so you have an upsurge of CKD. And if you look at that figure over there, that huge figure of 115 million people were detected to have CKD. CKD would mean an eGFR of 60 or less over 3 months or more in a census which was done in 2017 and published so. It is important for us that when we diagnose CKD in our patients, we should identify what are the risk factors in these patients, because that's where you'll know whether your intervention is going to work or not. And if you look at the second column here, I think that's the column where you have to look at. That is the initiation factors: diabetes, hypertension, presence of urinary tract infections, urinary stones, as well as drug toxicity. So these are things that you can actually work on your patients, prevent exposure to maybe drugs, better control of diabetes, better control of hypertension, early identification of systemic disorders, treat UTIs, and also manage stone disease right in the beginning. However, if these patients progress further, you still not give up, slowing down the progression of CKD, but however, you do understand the fact that if you have increasing proteinuria in your patients, or you can't control your blood pressure, then you're heading into trouble for the patient. And why are we looking at all of that? Because of the fact, when you look at the right table over there, you see that the cardiovascular mortality is much higher as compared to the all-cause mortality when you have highly albuminuric patients who have an advanced stage of CKD that is at a lower eGFR. That is the lowest possible GFR with highest possible proteinuria is going to predict higher cardiovascular mortality in your patients. So it's always best to have a good plan in your mind when you see your patient with CKD. And today what we're going to do is we are going to discuss only about how to slow down this progression. You have numerous amount of data now which is available over the past 5 to 6 decades, but this is a small pictorial which I thought I'll share with you, which says that what is important is blood pressure control. And blood pressure control is not because I or you say, it's because of large trials. For example, the SPRINT trial, which had a large number of population in which they studied and they defined what is the blood pressure goal in patients who have CKD or who don't have CKD, and how you would slow down the progression of CKD. Apart from that, how would you control the blood pressure would be obviously to use the best drug, which is the RAS inhibition, and the RAS inhibition itself, apart from control of blood pressure, slows down the eGFR decline by its own mechanisms. And obviously it is a glycemic control, and now we have so many studies now on glycemic control, and this is the EPIC trial, which is the DCCT or the EDIC trial, which was done several years back, which showed very clearly that if you have target a lower HbA1c in your patients, you would reduce the progression from microalbuminuria to macroalbuminuria. And now you have two molecules, which is the SGLT2 inhibitors, and we'll be talking a little bit about Finrenon, which have been shown to have renoprotective as well as cardioprotective roles in the patients. We have molecules such as GLP-1 receptor agonists. The data is still not very robust, but there seems to be emerging data which says that it is responsible for reducing the risk of the composite kidney outcomes, that is presence of proteinuria, increasing proteinuria, and also slowing down the decline in GFR. Apart from that, the most important and dreaded complication of CKD is acidosis. So if you would treat the acidosis, there seems to be some nice data which says that you could slow down the progression of GFR, apart from obviously restricting your protein, which we will discuss about, and which is a very important concept because I think that has to be taken care of a lot. And the last is obviously weight loss. So when you have a patient who's obese, you have an injury to the glomerulus, which is called as a hyperfiltration injury, which promotes more proteinuria in these patients. And obviously we understand that proteinuria is not just associated with renal morbidity, it is also associated with cardiovascular mortality. So this is a small table which will guide us to what are the blood pressure goals in our patients in the subset of CKD patients. So you should aim for a BP of less than 140/90 in patients who do not have albuminuria, and even lesser, that is less than 130/80 in patients who have albuminuria. And this comes from a very large trial, which is the HALT CKD study, which looked at more than 6,000 patients and have defined this kind of a goal. And they have also seen that using RAS inhibitors, that is renin-angiotensin system inhibitors, were helpful in these patients. So how much amount of protein would you want to give to your patients so that you can reduce the decline of GFR? This is a small pictorial here. The common notion is that when you find a patient on CKD, you would tell him, "Bhai, apna protein band kar do." Just stop the protein. So by the time the patients come to us, we find most of our patients have severe degree of malnourishment or protein energy wasting, and that's where these patients are more predisposed to getting microinflammation disorders because of the fact that they keep on getting infected because of lower protein in their body or lower serum albumin. So this says very clearly over here that if you are stage 1 to 3, you would give about 0.6 to 0.7 grams per kg per day. And as you progress further, you can restrict to 0.5 to 0.6, even go as low as 0.3 grams per kg per day if you assist these kind of patients using alpha keto analogs. And in stage 5, or patients on dialysis, you will see that the amount of protein intake increases to 1.3 grams per day, and even higher so in patients who are on peritoneal dialysis as compared to hemodialysis. So how it does is, how the low protein diet helps you is that what it does is it reduces the glomerular filtration injury to your patients, decreases proteinuria, and obviously decreases the uremic toxins because that's where they come from the protein itself. So you have a patient who has better compensated disease and he has lesser uremic symptoms as compared to the other population who does not restrict the protein. But there is a risk when you restrict protein. If you restrict too much, especially in the vegetarian population that we have, you could give rise to even worse clinical outcomes in the form of protein energy wasting, a lot of inflammation, catabolism in your patient, and repeated infections in your patients, which would obviously give rise to more incidences of AKI, secondary to infections. Apart from that, use of bicarbonate supplementation is a good idea in our patients because you could use these to retard the progression of ESRD. There are several trials, I'll not go through them, which have shown that RAS inhibition has consistently shown to reduce the decline of eGFR over a period of time. And this concept over here is very important because you have to look at your patients who come to you with AKI, because if you reduce the incidence of AKI, or if you identify AKI earlier, you can reduce the progression to CKD on its own self. 2 words about the use of SGLT2 inhibitor, which have very consistently shown that they have very favorable renal outcomes in your patients from these 2 trials, that is the CREDENCE, which has from a time plot analysis have shown that you can increase the time to dialysis in your patients by up to 10 to 15 years using different molecules from different studies. A word about Findralon, which is also known as the non-mineralocorticoid receptor antagonist, which has anti-inflammatory effect. It causes less of fibrosis in your patients, which is obviously backed with some kind of evidence, which has again shown that CKD progression as well as cardiovascular events were lower in patients who were put on Findralon. There's a very extensive data on the newer emerging therapies, but I don't think we can go through all of this because short of time. In the end, I would only say it is important for us to identify the cardiometabolic risk in our patients because that seems to be a very, very important pathogenetic retarding factor, and you should try to add SGLT2 inhibitor and maybe use an MR antagonist in your patients, apart from intensive control of blood pressure and blood sugar in your patients. Thank you very much.
Any question from the hall? Yeah.
In a patient who is on all these medicines which decrease the proteinuria in patients of CKD3, not in the stage 4, has been put on aldosterone because of resistant hypertension. That is, PP not control, maximal dose of 3 dose anti-hypertension, including diabetic. Now the patient, because of albuminuria, we want to start Findralon in such patients. How will we deal with the aldosterone, which is being given solely for the control of BP, which was not under control without the use of aldosterone? Because 2 mineralocorticoid antagonists cannot be used. So what is your view on that?
So that's what I want to ask you, that what is going on in your mind when you're thinking of using 2 aldosterone receptor antagonists?
I'm just saying, if I replace it with the Findralon, proteinuria will come down, but it is not a very good agent for blood pressure control. Patient BP will shoot up. So how do we balance?
So you don't have to balance. You just have to clinically decide what is best for your patient. If your patient is doing very well on aldosterone, why would you want to go on to fenrenon? Because there seems to be no head-on trial between using eplerenone or spironolactone versus, because both of these agents are known to reduce proteinuria. Both of these agents are antifibrotic. The only advantage of fenrenon is that lesser chances of hyperkalemia in these patients, and obviously hypertension control is not as good as. So you have to balance and see what you want from your patient. You want to control more of hypertension, you control more of proteinuria, but you would definitely not want to combine both.
Thank you.
As we age, the creatine level goes up. So is that called CKD?
No, sir. So there is a very good chart which you can see on your Google, which is called age-matched renogram, or age-matched EGFR matching to your age. So as you age, obviously all your body organs are aging too. So you can match your age with the GFR and see that you're probably not CKD. So CKD definition has fallacies in itself, but to overcome the fallacies, we do have normograms depending on even your size of the body. Depending on the size of your body, you can match your GFR to that. There are people who are very tall, the people who are very short. Now they can't have the people who are very, very obese, people who are muscular. So there's a lot of variation in the population, and you do have correction factors for all these available.
Answer to your aldosterone, it's as good as fenrenon. Only thing is the side effect is more with the aldosterone as compared to the fenrenon, because the selective and aldosterone is non-selective. So definitely aldosterone is the chief. Yeah.
Yeah, lesser sexual side effects. Yeah.
Yeah. Yes. Yes. So if patient is doing well on that cheaper drug, why we want to shift to a more costlier drug?
Thank you, Dr. Vinand. I will request you to please join the dais. And now I will request Dr. Anurag Gupta, a senior consultant from Department of Nephrology, Sir Dandaram Hospital, to deliver his talk on online hemodiafiltration. This is apart from conventional hemodialysis. This is the latest breakthrough in the field of hemodialysis, and we actually thought, while planning the talk, that all of you should know what is online hemodiafiltration. Dr. Anurag, please.
Yeah, thank you, sir. Good afternoon and good morning to everyone. The topic is this. First, the concept of hemodialysis came in 19th century, and father of dialysis was Thomas Graham. If you go through the history, these were the dialyzer initially we used, the kill dialyzer, and see the size of the dialysis machine. And Dr. Chugh, who is father of Indian nephrology from PGI Chandigarh and teacher of Dr. A.K. Bhalla sir also, see the machine, what we was using initially. So what is, first we have to know what is dialysis. What does it do? It removes the waste products, it corrects the acidosis, and it removes the excess fluid from the body. Mechanism is diffusive clearance and ultrafiltration. Diffusion is what? Movement of solute from one area to higher concentration gradient to lower concentration gradient. And usually the dialysate, you have seen the dialysis going on, the dialysate and the blood, they are flowing in opposite direction to provide the maximum diffusive gradient. And convection is, there is, along with the fluid, the solute is moved. But, okay, we have dialysis. Why we need this online hemodiafiltration? Because from last 30 years, there was not improvement in morbidity and mortality. So, what does it do? Why we need it? Definitely, it improves anemia, removal of the middle molecules like beta-2 microglobulin, decrease intradialytic hypotension, enhance uremic toxin removals, reduce inflammation, which will increase your survival, decrease hospitalization. So it is a combination of diffusive and convective clearance, and HD plus hemofiltration constitute the hemodiafiltration. So what we needed? RO system, high flux dilator membrane, and good vascular access with a blood flow 350 to 400 ml per minute. See,
This is, we treat the tap water with pre-treatment treatment with carbon filters, reverse osmosis, sterilization, ultra filters. Then ultra pure water is entering in the dialyzer post dilution, and pre we do where we need a heparin free. This is the machine which is called 5008. The various parameters comes on the machine, the BP, what is your ultrafiltration goal, what is you remove, what you do. So why? Phosphorus is a big challenge in hemodialysis. So better removal of the phosphorus, better removal of the middle molecules like free leptins and beta-2 microglobulin. Studies have shown better cardiovascular stability, better less hospitalization, better quality of life, and they have shown better survival also with HDF, and this has been proved in the largest recent trial which shows the better cardiovascular outcome and better survival. We are using this from last 10 years. We have 25 such machines at our center, and over around maximum patients are on HDF, and the cost is little bit high, but at a greater benefits. I will show you, we have done a study in 60 patients, and out of this 30 patients were on HDF, and they have better blood pressure control, better inflammation control, better IL-6 levels, better IL-1, better albumin, and the better phosphorus control. The patient are on HDF, and the albumin level was also better. So to conclude, it is basically a form of hemodialysis, but with more refinement. The online HDF may be superior to conventional low flux hemodialysis in terms of better inflammation, improves in malnourishment, better anemia control, less requirement of EPO dose, better phosphorus control, long-term outcomes with low associated morbidity and mortality. And so HDF is associated with better clinical outcome, and the recent trial has shown this, it is beneficial. Let's provide more benefit to our patients with this technique, and thank you very much.
Thank you, Dr. Anurag, for alluding and telling us about online hemodiafiltration. I can open the house to questions, if any.
Same. It's same. Important in cardiovascular unstable patients, the machine is itself measuring the blood pressure, each and everything, and that will give the alarm, and each and everything will be settled. Only thing is little bit cost is high, but the thing is the lot of benefits in the form of better phosphorus control, better quality of life, better anemia control. So the patients are doing well, and survival is, as shown in the trial, is better. 5,500 per session.
So I think the bottom line is that the patients are choosing this, as Dr. Anurag has said, that most of our patients are now on HDF. So if the patients are mostly on HDF, we presume that irrespective of the findings that we have, our patients are finding more benefit with this kind of a modality. So with this, if there are no more questions, I'd like to thank Dr. Anurag for giving such a nice talk and telling us about a new kind of a modality. And I would like to invite...
Sorry, what? Yes, it's shown the survival benefit. Yes. The recent trials have shown, this is the largest trial of around 700 patients. The survival advantage was there in this trial. Now I invite our Chairman, Department of Nephrology. He is Padam Shri and is also Joint Secretary in the management. Secretary in the management.
Thank you, Dr. Anurag and Chairperson, Co-Chairperson, and good morning to all of you. Actually, this talk was to be delivered by Dr. Ashwini Gupta, but only half an hour back I got a call that he is not well and he will not be able to come. So I am replacing him for this talk. So we all know about kidney transplantation, which is a established modality of choice for end-stage renal disease. But first kidney transplant was done in 1955 at Boston. And after that, kidney transplant was a established modality of choice for managing end-stage kidney disease. But when we were doing our nephrology training, at that time it was clearly mentioned in absolute contraindication. First thing was ABO incompatibility. So it was an absolute contraindication because the moment you will do transplant, the kidney will be rejected on the table. But it is not so now. And our center, Dandaram Hospital, was pioneer in India to start ABO incompatible kidney transplantation as early as 2012. So I think it is really satisfying for us that we have been able to establish this modality in our country. Kidney transplant offers much better survival advantage as compared to dialysis in end-stage kidney disease. But there is always a difference between supply and demand. And waiting lists are very long, and because the survival on dialysis is not comparable to transplant, and morbidity and mortality is much higher in patients who are living on dialysis only. Though even in diseased kidney transplant, the survival of living donors transplant is much better than diseased donor transplants. And of course, ABO incompatibility and HLA incompatibility, these are the major limitations when we do live donor kidney transplant. Just to have an idea of how big is the magnitude of problem, about 2 lakh new patients are added every year. And only about 8 to 10% are on maintenance hemodialysis. About 2 to 4% patients are on peritoneal dialysis, that is continuous ambulatory peritoneal dialysis. Again, this procedure we were pioneering starting at our center, Dandaram Hospital, as early as 1989. So we were the first to start CAPD in India. And so far, only about 10 to 12,000 kidney transplants are done in our country in a year. So you can yourself imagine what is happening to rest of the patients and how every year the patients are being added to the pool. So there is a shortage of transplant. Only 1/3 of the actually donors, only 2/3 of the donors are compatible, but 1/3, almost 35% of the donors are rejected because of ABO incompatibility. And we all know that O is about 40%, and A is about 45%, B is 10%, and AB is 5%. And the problem comes where we have the O, although swap transplant again is a possibility, but sometimes the swap transplant also is not possible. Now, just an idea to have blood group antigens. So, in a blood group A, if patient is having blood group A, then that patient will be having anti-B antibodies in the plasma. And there will be A antigen in the RBC. And in B group, we have anti-A antibodies, that is isoagglutinin antibodies in the plasma, and B antigen in RBCs. In group AB, we will have no antibodies in the plasma, and we will have both A and B antigens in the RBCs. And in group O, we will have both anti-A and anti-B antibodies, and none in the RBCs. Now, if we do ABO incompatible kidney transplantation, immediately the complement activation will occur. It will lead on to inflammation, endothelial damage, and ultimately platelets get activated and we get thrombosis, and it leads on to thrombotic microangiopathy and hyperacute rejection. So that's why ABO incompatible kidney transplant cannot be done routinely. So now how it became possible? So we will discuss further that how this transplant became possible. Now, other things which we have started before we started ABO incompatible, we had a spouse transplant. We were the first to start. Even then, emotionally related donors like father-in-law, mother-in-law, then other brother-in-laws, sister-in-laws, so even uncles and aunt from the family. So that was the extended family donors. Then we were the first to start paired exchange donor, where we have A and B and other pair has B and A. So we can have the swap donation. That is called pair donation or swap donation. So that was a much easier way to do transplants rather than going for ABO incompatible kidney transplantation when we didn't have this facility. However, that problem comes in when we have O group, because in O group we don't have that choice. So, and cross-match positive again, we have a problem. So where how to accept these donors for kidney transplantation. So then the idea came of ABO incompatible kidney transplantation. So actually most of the studies were done from Japan. Then we had some centers from US also. So then there were a set protocols to desensitize these patients, recipients for doing ABO incompatible kidney transplantations. And the various procedures involved were use of plasma exchange, then selective immunoabsorbed columns, IVIG and rituximab. The protocol at our center, which we developed ourselves, was that we started immunosuppression on day 15 instead of normal transplant where we do it -2 days. So we started with tacrolimus and MMF, and we gave rituximab 200 milligram. Initially, when we did first transplant, we used 500 milligram of rituximab. However, over a period of time, with our experience, we have now realized that that much dose is not required, and infectious complications are much more if we use higher dose. Then plasma exchange and IVIG are done depending upon the titer. How much is the isoagglutinin titers or IgM, IgG titers? So that titer will decide which procedure to do for desensitization. So plasma exchange centers exchanges sessions can be none, or it can be as high as 5, 6, 7, 8. IVIG we use usually 5 to 10 gram at the end of plasma exchange. And if the titers are very high, usually more than 1:256, then we prefer to use immunoabsorbent columns. Immunoabsorbent columns are there where these columns just bind these isoagglutinins. So these columns, we were the first to use these columns in our country as early as 2012. Then salumedrol or methylprednisolone is used on the day of transplant, and after that the immunosuppression continues lifelong. The desirable titer for anti-AB antibodies should be ideally should be less than 1:8. However, now more and more centers are liberal and are using up to 1:32 titer also. As the daily monitoring of titers is done prior to transplant. And after the transplant, we usually do initially for 1 week, we do daily monitoring of titers, but after that, usually it is not required. A word about rituximab use. Earlier, when the ABO incompatible transplant was started, at that time they were doing splenectomy to do B-cell depletion, but now that has been done. It is a sort of medical splenectomy. So with it, this drug inhibits B-cell proliferation and it induces cellular apoptosis through binding of complement. So its effect comes as early as 72 hours, and even a one injection effect can last for almost 1 year. So it is a very, very potent immunosuppressive agent. So most of the now studies, and even in our own experience also, we are using 100 to 200 milligrams single dose. In addition, because we are patients are slightly higher immunosuppressed as compared to normal routine transplants, we made it a routine to vaccinate against pneumococcal influenza vaccines and hepatitis vaccine before transplant. And anti-A, anti-B, baseline titer is done in every patient. And the gel method is used now. Earlier we were using tube method. This blood bank consultants, they are actually doing this titer at our center, and it is now quite standardized. So as I mentioned, the target, IgG is more important for ABO incompatible kidney transplantation. However, IgM titer, if we can bring it to less than 116, that is desirable. But most important is IgG titer. This is the plasma exchange where we have a plasma filter, and through that the plasma is exchanged, and usually the replacement fluid can be either albumin 20% or it can be plasma. Then we have double filtration plasma pheresis, which is done in the blood bank. And this is a immunoadsorption filters, where we have the column carbohydrate columns which absorb the isoagglutinins. The main advantage is that usually we do not remove the other beneficial parts of plasma, like fibrinogen and coagulation factors. So that is the advantage. The disadvantage is that these are very costly. Almost 3 lakh rupees is for one filter. The immunosuppression is standard, and post-operatively, usually for 7 days we monitor these titer, and after that it is not required. And once the patient is discharged, after that most of the time the course is right and normal, compatible transplant patient. This is our first patient we did in 2012. And this, fortunately, this patient is still having the normal creatinine 1.09. We have done 406 ABO incompatible kidney transplantations so far, out of 6,000 total at our center. And titer up to 1:1024 maximum titer has been accepted. And majority of the patients we used plasmapheresis. Survival is slightly lower than the compatible transplants. And this is a study from American Society of Nephrology journal, which shows that there is a slight difference in survival as well as increased infections in ABO incompatible kidney transplants, although it is now a quite accepted modality of treatment. So to conclude, ABO incompatible kidney transplant demonstrates acceptable long-term survival, patient and graft survival. Desensitization protocol is simple. However, it increases the cost of therapy and some increase in infections also. Monitoring of titer beyond 3 months is usually not required. Thank you.
Any question from the audience?
Microphenolate. It will come to around 12 lakh. And a normal transplant will cost around 9 lakh. Depends upon if there is any complication, otherwise 10 to 12 days. Yes, otherwise tacrolimus, MMF, prednisolone is exactly the same. Only initial is we start minus 15 days and we use in addition rituximab. Plus desensitization protocols, either plasma exchange or a filter. Yes, incidence of antibody-mediated rejections, ABMRs, it actually are higher in ABO incompatible kidney transplantation as compared to compatible. And if they stutter, sometimes it can be very, very fulminant course, and most of the time we lose the graft. So that is a serious complication of ABO incompatible kidney transplantation. Because we don't have eculizumab available here. If we have eculizumab, then eculizumab is the drug of choice for this kind of, actually it is a TMA, thrombotic microangiopathy. So that responds beautifully to eculizumab. Same, tacrolimus, MMF, and prednisolone. Yes, and depending upon the course, and maybe after a few years, we might reduce the dose of tacrolimus, or in some patients even stop tacrolimus. And in some patients, you may, if patient is not tolerating MMF, you may have to shift to azathioprine. So then later on, maintenance dose can be only azathioprine and prednisolone.
What is the experience of complications and survival after this?
Slightly higher than compatible. Infections, in our setting, definitely infections are more. We see all kind of fungal infections, viral infections, and candida, mucormycosis. Yes. No, lifelong. Steroid-free immunosuppression people are doing, but mostly they are being done for ABO compatible, not for ABO incompatible. Our experience also has that we have more infections, but usually 5 milligram.
Can it be offered to pediatric population?
Yes. Only thing is that pediatric patients, they have more active immune system as compared to adults. So that's why you have to have a higher immunosuppression in pediatric population. Thank you. May I invite Dr. Vaibhav Tiwari, Senior Consultant from Dandaram Hospital, to deliver his talk on cadaver renal transplantation, the basics you should know. His main area of interest actually is now he is focusing on cadaver kidney transplantation, not only diseased brain dead patients, but also a totally new area, that is after cardiac death. DCD donors. So I will request him to also briefly touch DCDs also. Dr. Vaibhav Tiwari, please.
Thank you, sir. So what you have seen on your screen is a WhatsApp message on my society group. And everywhere, yeah. That's right. I'm pretty sure you must be coming across with these kind of message very often. And this is exactly how the kidneys are not transplanted in a brain dead patient. So, good morning, everyone. I'm Dr. Vaibhav Tiwari, and I'll be briefing you about disease donor renal transplantation. So, to put in the perspective, India is definitely making a progress. In 2012, the donation rate of disease donor was around 0.16, and 10 years down the lane, we have reached to around 0.52, almost 3 times, but definitely we are way behind the developed nation, that is around 100 times way behind the developed nation. And if you look deeper into the progress, it's all the South Indian states that have made progress. If you look, Karnataka, Tamil Nadu, they are the main flag bearers. If you look, UP, the population of 30 crores, last year they have transplanted only 1 kidney transplant. In Delhi, things are picking up now. Now, current scenario in India, what we need, as Dr. Bhalla has also told, we need around 1.5 to 2 lakhs kidney transplantation. And currently, what we are doing is around 7 to 10,000 kidney transplant. And 90% of those is living donor and 10% is disease donor. And what we are losing out is around 1.5 lakhs people who die in road traffic accident. Those are a big pool of donors, excluding the donors who have massive CVAs and all. So why the numbers are so low? Because the cultural and religious belief, there are misconception that once the patient has donation, the body will be disfigured. Lack of awareness and education, mistrust in the healthcare system. They think if they agree for the donation, the death will be premature declared, or there'll be organ misuse of the organs. There's a bureaucracy hurdles. There is no streamlined procedures. Definitely there are infrastructure and resource limitations. So there are a number of factors which count in. Now, how is the government doing it? So government had made various organizations. On top of thing is the NOTO, that is National Organ and Tissue Transplant Organization. Below that is ROTOs, that is Regional Organ Organization. 5 ROTOs are there, and each state have their SOTO, that is State Organ and Tissue Transplantation. So these all agencies coordinate among each other to coordinate the allocation of the graft, to maintain the list of the recipient, to create awareness. Now, I'll be coming on the basics of disease donor transplant. The first one is the brainstem, and it is the most predominant what we are looking forward. And second one is the donation after cardiac death or donation after the circulatory failure, which we have to pick up once we are sufficient in brainstem death. So, brainstem death is basically scientifically defined as incapacity to breathe spontaneously and incapacity to remain conscious. The brainstem is the connection between the brain and the rest of the body. Once it's dead, the patient is declared dead. This is the time when you declare the brainstem, is the time when you write the time of death in the death certificate. So, brainstem death is the largest pool source of transplantable organs, and it is a bedside diagnosis. You don't need any sophisticated investigation to do it. What you have to follow is a 3 steps UK code, which includes some preconditions, exclusion, and bedside test. The identification of donor in a brainstem death, the patient has to always be in the ICU. He should be in a deeply comatose state. He should be on a ventilator, and there should be an evidence of intracranial event. Now, who can be the potential donors? All the patients who have a massive intracranial bleed or hemorrhage or road traffic accident which involves brain are the source of potential donors. Where you should suspect a brainstem death, as I've told, the patient should be in ICU with a deep coma, and you should know the cause of the coma. The cause of the coma has to be very clear before declaration of brainstem. Now, there are certain preconditions which you have to fulfill before declaring the patient as brainstem death. The coma has to last for at least 6 hours. There should not be any abnormal posturing. There should not be any epileptic movement. There should not be spontaneous respiratory movement. And there should be all the brainstem reflexes should be absent. The exclusion criteria, patient should, absence of coma, child below 3 years of age, coma where you have patient has received neurodepressant drugs, primary hypothermia, severe hypometabolic syndrome or shock, or any respiratory arrest requiring relaxant or neuromuscular agent, and when the diagnosis of the coma is not clear. There are certain brainstem effects which we have to do. There are certain, this is the most important, the apnea test which we have to do. I'm not going into detail of this. Now, as I've told, the brainstem death is essentially a bedside diagnosis, and once the patient is declared brainstem, it is that you have declared the patient as dead. Now, who can certify the brainstem death? First, you require a neurologist, neurosurgeon, or an intensivist. Second one is a doctor nominated by the appropriate authority. Third is the doctor who's treating the patient, and fourth is the medical superintendent of the hospital. Now, all these, once you have done all the tests have to repeat once again after 6 to 24 hours before the first set of tests. Counseling, the doctor who is in charge, the neurologist, neurosurgeon, or intensivist has to explain the patient about the brainstem. And the most important is you don't need to counsel the patient regarding organ donation while you're telling the patient about brainstem. You have to decouple it. You have to give some time to the family to understand, to accept that only then you should counsel the patient regarding the organ donation. Consent has to be taken. Even if the patient is a registered donor, you have to take the consent of the family for organ donation. Now, who are the eligible recipients in terms of kidney transplant? Patients who are on dialysis for at least 3 months, and patients need to be enlisted through a hospital on the NOTO website. These are the eligible patients who can take part in the recipient list. Allocation principle, the kidneys goes within the city, and this is done by the SOTO or the NOTO. If there is no eligible donor, then the kidneys go to the other city. If there is no eligible donor recipient in the other cities, then the kidneys go to the other states. The blood group O goes to blood group O. If there is no eligible donor, then it goes to A and then B and finally to AB. And similarly, AB blood group kidneys goes only to AB. Hospital, if the patient has been declared brainstem death in a government hospital, the kidneys goes to a government hospital. If the patient declared dead in a private hospital, the kidneys goes to a private hospital. The algorithm, what you have to do is, first you have to match the blood group, then you have to check the urgent list priority where you have certain patient on the urgent list. If there is none, then the next priority list is the patient who require multiple organ transplant. If there is no patient in the multiple organ transplant, then the kidney goes to the patient who needs a kidney alone. So finally, I think it's high time we need to put efforts to create awareness about these things, because from our point of view, that these organ disease donors are the biggest pool of organ, and we can make the life of the patients who are ASRD much better with this kind of pool. And this is the news which is there in today's morning newspaper, where 2 organ dead donors have given around 7 organs in AIIMS and Safdarjung. Thank you.
Any question from the hall?
Yes, ma'am. What we are doing is we are creating awareness. We are putting up posters whenever the patient is in the ICU. We are telling them if the patient is in a sick condition, we are already, we have to sensitize the patient before the condition arrives when you have to declare the patient. So the main point is patients should be sensitized. The relatives of the patient have to be sensitized about it, because it's very difficult to break the news about brainstem death and ask them for a donation. So what we are doing, we are creating awareness through media, and the posters are there so that more and more people should be aware about it. Yeah. Yeah, we have to. That is the this thing. That is the law of this is the law. But yeah, the relatives of your have to give the permission before. Without their permission, we can't take the organ. The closest relative, who is, if the wife is their wife, then father, mother, then brother, sister. It's all in the law.
Thank you, Dr. Our next speaker is Dr. B.B. Agarwal. He is chairman of Department of Surgery and member of Board of Management, Gangaram Hospital. And one more thing is, he's only Indian awarded with Honorable Fellowship of American Super Specialty GI Surgical Society. The topic of Dr. B.B. Agarwal is gut microbiota, role in maximizing clinical outcomes. Over to you, sir.
Good morning, everybody, and welcome to Gangaram family. I think Gangaram exists because of your trust, faith, and prayers for our society's well-being. Thank you very much for coming on this winter morning. And I'm very grateful for this opportunity to Dr. Harbans Lal and the team which organized CME, and to have Professor Bhalla, Professor Anurag, and Professor Vinant on dais when I'm speaking is a personal blessing, because they are the givers of life to our family, having had a transplant in our family. So thank you very much. Whatever I'll speak from our published literature, level 1 evidence, or at least level 2 evidence, with more than 1,000 citations. So greetings once again. These are the citations. So since morning we've been listening to super specialty, cardiology, nephrology, and talking about how can we improve life of our patients or improve the clinical outcomes. And one thing that came to my mind, that disease is nothing but it's a change from physiology to pathology, and healing is nothing but a change from pathology to physiology. It happens gradually. What is common to all of these? Science knows now, particularly from transplant related studies in West and now at Gangaram, that cytokines are the molecules which are responsible for creation of a condition from health to disease and reversal of disease to health. So that is clinical outcome. Cytokines, as we know from corona experience, we all became aware, they can be pro-inflammatory, they can be anti-inflammatory, and they are definitely modulating the immunity in our body. So disease is when pro-inflammatory cytokines predominant over anti-inflammatory cytokines. And forgive me, I am a surgeon and I'm not talking a surgical topic, but it is my area of interest. So positive outcomes will be possible when anti-inflammatory cytokines somehow take over the pro-inflammatory cytokines, and we as clinicians, can we do something about it? Can we increase our immunity and decrease inflammation? Because science already tells us that more the inflammation, more the immunosuppression. For surgeons, post-operative surgical patient is an immunocompromised patient. So what can we do about it? Inflammatory pathways in clinical recovery or convalescence are driven by our inflammatory, anti and pro both, our immunity in the body, and our thinking also, neurohumoral pathways. Most of the cytokine studies have been done on patients based mental state. Last week, Nature had a publication that cytokines define our personality and social behavior also. So our entire life, disease and health, involves a play between cytokines, our various cells, especially CD56, CD19 cells, which are part of natural killer cells, which can even kill the cancer in the body. So if we can inverse the inflammation, we can enhance the immunity, and we can improve the clinical outcome. Now, how is this inflammation driven or started in the body? We knew from our college student days that inflammation can be triggered by pathogens, it can be triggered by non-pathogenic microbials, and it can be triggered when we can't identify any pathogen or microbials. So in absence of these factors, it is known as sterile inflammation, studied most in kidney transplant patients in rejection physiology. So our body has toll-like receptors. Toll is a German word which translates to fantastic. A Nobel Prize was given to the person who discovered these. These are receptors which identify molecules or patterns. So these are pattern recognizing receptors found on lymphocytes, and they can sense whether the insult is pathogenic or it's a non-pathogenic microbial, or it is in absence of these. So if it is pathogenic microbial receptor getting activated, is it PAMP? If it is microbial, which is non-pathogenic, it is MAMS, as in transplant rejection. Or if it is nothing is there, it is DAMP, danger associated. So if we are worried, anxious, and fearful about our current or future condition, when we are patient, how will we recover? Then there are danger molecules in our body which are sensed by these lymphocytes with pattern recognizing receptors, and these are known as alarmins or danger molecules or danger signals. So how can we do that? So being a surgeon, I had an interest because I had done a diploma in yoga when I was third year MBBS Maulana Azad, and I had a firm belief that lifestyle change has caused a lot of problem. So we started in our PG thesis program studying the effect of yoga on these molecules, and we found that all these pro-inflammatory cytokines were much lower post-operatively in patients who had been given 3 to 6 weeks of pre-operative prehabilitation yoga, call it physiotherapy, exercise, whatever. So it's basically modulating the body's immunity and response to immunity. It was published in highest impact journal internationally and covered by American media in a big way. From yoga, we went to whether turmeric, haldi helps in this. So we published again that in the topmost journal of laparoscopic surgery, and then we went on to say that normal conception that Indian spices are not good in hemorrhoids or piles, we found there was no association in a double-blind randomized controlled trial published in the same surgical endoscopy journal. And coming to microbiota, what are the natural sites where these microbiota reside in our body? Umbilicus or belly button is the most common site, and it has been considered holy not only in Indian civilization but also by Leonardo da Vinci. So surgeons should never touch umbilicus. We as laparoscopic surgeons became very glamorized by hiding our scars in the umbilicus. So we published in surgical endoscopy, never disturb the umbilicus, stay away from it. Then we studied effect of perioperative music when the patient was already anesthetized. We found the same response in IL-6 CRP and tumor necrosis factor and CD56 marker natural killer cells. And it was published, and I was invited to speak about it at American Congress of Surgeons in America, and it was published in Journal of American College of Surgeons. So how is this important? This led to our thinking that there is something in our civilizational coexistence belief that we exist because of each other. The plants are necessary, rivers are necessary, the soil is necessary, the diet we have, the kitchen practice is necessary. This universal connectedness taught us, why not do a study on post-operative inflammation, sterile inflammation with probiotics. How are probiotics defined by WHO? They define it as a microorganism which, if given in sufficient dose, imparts a beneficial effect on the health of the patient. Now, the facts are very surprising. You know, what I'm standing here, only 10% of my cells are human cells. 90% is a bacteria or microbiota living with me in my body or on my body. And the software which drives our body, the DNA or RNA, 99% is the organisms living inside or on our body. Only 1% is what has been given to me by my birth by my parents. So there has to be something designed for that. Time is limited, so I'll show what is already level 1 evidence that these microorganisms living inside or on our body communicate with our brain and other parts of the physiology through very defined molecules which cross across gut, which go beyond gut. The most defined pathway is trimethylamine and nitric oxide pathway, short chain fatty acids, primary and secondary bile acids, and there are various hormones, even leptin, which is important in kidney transplant. And this microbiota comes from our mother, and if we change it, it is it's non-physiological. We in surgery have a lot of level 1 evidence to show they decrease the complications, alleviate pain, and decrease paralytic ileus. And we all know antibiotic-induced diarrhea we treat for a long time. And now the evidence is coming, level 1, again, that anastomotic leaks are better and not less if you give this. We are already practicing fecal microbiota transplant, but what is the ideal fecal microbiota? We do not know apart from mother, because it is as individual as our thumbprint. So maybe someday we will manufacture or synthesize something from an African tribe, which will be the golden pill for many diseases. Harvard already has a vagina on chip model in which they showed that these microorganisms in vagina prevent UTI and PID, and best source of those was found to be curd, and curd bath in Indian civilization was already known. So as I said, it is individual like a thumbprint, comes from mother, comes from our kitchen practices like setting curd without putting it in a freezer or a temperature control model, hugging plants, science says hugging cattle, and now we have Cowdling Day in Canada, America celebrated, that it has been found cattle, whether it is cow or something, is a good source of microbiota. So this is one of the invited editorials in the same topmost journal, published 2008. Then when I said we should be imagination-driven engineers, we should innovate, we should understand molecular science, we should respect our culture, civilization, we should understand embryology and genetics, whether we are surgeons or physicians. We should use technology, including imaging, to our best benefit and proceed with engineering of all these Imagineers. And it is also common sense. It is said by Emerson that society is always taken by surprise with common sense. So thank you very much. We are all physicians. We earn little bit of money, kvachid some friendship, kvachid mitra, some dharma, kvachid dharma. Kuch profession mein yash milta hai, kvachid yash. If we don't get anything, we get to experiment on human bodies. Karam bhyase kvachid asham chikitsa nasti nisfala. Physician profession never goes useless. So I have been recognized for these by American, European societies and Indians away from our profession. Thank you very much for that. The platform remains Gangaram. My primary responsibility is to train my replacement better than me. Thank you.
Thank you, sir. Any question from the hall?
Meditation as well. So meditation is known to lower stress and hike up the immunity.
Thank you very much for asking this question and giving me some additional time. I think we have to understand yoga. Yoga is not meditation, not asana. Yoga has been defined by many people. Most common we know is Patanjali. And he said yoga is yam, niyam, ahar, pratyahar, asan, dharana, dhyan, samadhi, pranayam. For the fools, for common population, to attract them, teach them physical postures. To lesser fools, teach them breath exercises, breathing, pranayam. To who understand yam niyam, what to do, what not to do. Ahar, pratyahar, what to eat, not to eat. Dharana, how do you think? You don't think of harming somebody even in your thoughts. That is best yoga. For masses, to attract them, asana. For intellectuals, educated degree holders, meditation and pranayam. Otherwise, your kitchen and your mother and your family and society is enough. Yam, niyam, ahar, pratyahar. What to eat, what not to eat. Like I gave an example of curd, and another, Dr. Ashwani said trans fats. Our cooking was based upon boiling everything, adding spices, and then in last, add a dollop of makhan or ghee. So don't cook your spices, first put oil, then spices, make a gravy. That creates trans fats. Boil your vegetables, add spices when at boiling point of water, because curcumin in turmeric gets denatured after boiling point. So does many other antioxidant. And then when you're eating, put a lot of ghee. Thank you, sir. And as Dr. Bhalla says, fermented products in our kitchen, achar, pickles, they are very good source of microbiota. So thank you very much.
Thank you, sir. Thank you, Professor Agarwal, for such a moving discussion. And with this, we move on and change our focus towards vascular endovascular surgery. And for this, we have a senior consultant, Dr. Nikhil Chaudhary, who's working in the Department of Vascular and Endovascular Surgery. And he will be talking to us about the endovascular management of aortic aneurysms. Over to you, Dr. Nikhil.
So, thank you, chairpersons, for the opportunity, and I am very grateful to them. And good morning to everyone here. So, after very interesting and thought-provoking talk by Dr. Agarwal, I will be talking more of a macro things rather than micro, because surgeons mainly are focused on macro things. So, speaking about I will speaking about aortic aneurysms. So, broadly, they are thoracic aortic aneurysms or abdominal aortic aneurysms. And in the simple language, that can be a saccular aneurysm, which is on bulging on one side of the artery, or it can be a uniform bulging, which is fusiform aneurysm. So fusiform aneurysm is most common, and we have different criteria for intervention and as well as definition for aortic aneurysm. So for thoracic aorta, generally 1.5 times the normal artery is considered aneurysmal, and in abdominal aorta, more than 3 centimeter is aneurysmal aorta, and this diameter should be measured on preferably on CT scan, and that is also CT angiography preferably. If patient's creatinine is high or renal function is deranged, then we can also use non-contrast CT. Then Society for Vascular Surgery recommends repair for all patients of acceptable perioperative risk with an abdominal aortic aneurysm size more than 5 centimeter, and in all patients with saccular and symptomatic aneurysm. What does the symptoms mean is abdominal pain, because that can be a marker for rupture of aneurysm and a content leak. So these are very important criteria. And between 3 centimeter to 5 centimeter diameter, we have to have a 6 monthly surveillance over the growth of the aneurysm size. So goal of repair is obviously to prevent rupture, and decision is based on associated risk of treatment, risk of aneurysm rupture, patient's life expectancy, and patient's preference. Open repair generally consists of opening up of sac and replacing aorta with prosthetic bypass graft. This was the only treatment available in 1950s to 2000, and subsequently endovascular aneurysm repair picked up, where motive behind the endovascular treatment is that we have to completely exclude the aneurysmal sac and line the aorta from healthy area to healthy area, achieve good seal, and protect branches of aorta. So this is a small video demonstrating what is endovascular aortic aneurysm repair. So we have to pass a guide wire, and device is placed over the guide wire, and we have to position device protecting the renal arteries, and we have to deploy the device. So it is basically a covered stent graft, which is formed by a polyester material and reinforced by nitinol. So these are the renal arteries, and this is bifurcated aortic graft device, and from other limb we have to put an extension in contralateral iliac artery. So this is just to give an idea what is exactly endovascular aneurysm repair, and there is a top cap which is being deployed near the renal artery to prevent the migration of the stent graft, and this is the overlap zone to prevent endoleak. So what are the pros of EVAR? So it provides better quality of life. It is very minimally invasive, less blood loss, no abdominal incision, no general anesthesia required in most of the cases, it being done in local anesthesia or spinal anesthesia, less pain, decreased length of hospital stay, and shorter recovery. But there are cons also. They are more expensive initially, and then high quality imaging is required because this requires very dedicated cath lab. Then possible graft movement may be there due to growth or rupture of aortic aneurysm. Then we require follow-up studies, and we have possible to have a delayed rupture. which patient we select for endovascular and which patient we select for open repair? Generally, young patients with and connective tissue disorder patient and hostile anatomy patients, we prefer open repair. And older patient and patient with multiple comorbidities and prior aortic or abdominal surgery, endovascular option is always better. And in clinical practice, mostly we see these kind of patients. So endovascular devices are also evolved from initially traditional models were two-piece devices, and now they are moving towards a unibody design. So this is just a case which we have done for illustrations. So as it is a very old gentleman, 75-year-old male, post PTCA, hypertensive, chronic smoker with borderline kidney functions. So he was mostly aortic aneurysms are diagnosed incidentally because patient undergo ultrasound scan for some other abdominal complaints and incidentally get diagnosed with aortic aneurysm. So for planning, CT angiography is very important investigation, and we have to see on axial imaging. So here we can see neck of aneurysm, and as we go ahead, we can see a huge abnormally dilated aorta filled with contrast, and we have to then measure the diameter in axial way. So this is again three-dimensional reconstruction of the same patient. So as you can see, there is a challenge that there is a very angulated neck of the aorta, and only advantage is there is long length, so we can easily deploy our stent below renal artery. So every patient we have to plan. Planning is very important in any surgery, and especially in endovascular repair. So for planning, we have advanced and sophisticated softwares where we can get a longitudinal view in angulated anatomy also, and then we can also measure the length, as well as we have to measure the neck diameter, where we have to deploy a proximal part, then distal landing zone in common iliac artery. Then we have to see each detail, that how much is the length from proximal landing zone to distal landing zone, extension limb length, everything, approach, everything has to be planned before surgery. And this is a 3D reconstruction model that how, after planning, how the patient will have picture of EVAR repair. So this is now actual image that how it looks after deployment. So this is the deployed stent, and we are removing delivery system, and this is the angiography. So for patients with raised creatinine, we initially start with CO2 angiogram, which helps to reduce the contrast burden over the patient. And post-operative course, obviously, it is a minimally invasive procedure. So still we observe patient for 1 day in ICU, and blood transfusion is required for this case. Drain removed on day 2, and no post-operative complication was noted, and he was discharged on day 2. So there are different this is one other case. So different case has different challenges. So in this case, the challenge was narrowed iliac artery. So in EVAR, we have to deliver our big delivery system, which is around 18 French to 22 French across the iliac artery. This is just a diagrammatic representation of thoracic aortic aneurysm, and this is a post-deployment pictures. And as you can see, there is complete exclusion of sac. So treatment of EVAR has been evolved from EVAR to chimney EVAR, then fenestrated EVAR, and now recent is the percutaneous EVAR, where there are no suture to the patient. Patient is pain-free, and we have special arteriotomy closure devices. And for suprarenal aortic aneurysms, then there are many other options like hybrid EVAR, chimney, sandwich. So I'm not going into detail of each. I'm just showing you the pictures that how we manage these complex cases at our hospital. So this is chimney EVAR. So these are the images of actual cases which we have done. This is sandwich technique, where we have to overlap entire aorta if there is extensive aneurysm involving thoracic aorta and abdominal aorta. So these are actual images that how stent grafts are placed to protect the branches of aorta. And this is surgeon modified endograft, where we make fenestration on table and reinforce it. And this is custom-made device, which is not available generally in India, but this is also a possibility. Then I am not going into details of complication, but most important complication is endoleak. Other surveillance technologies are ultrasound color Doppler, contrast enhanced ultrasound, and CT angiography. So endoleak type 1 and type 3 requires urgent intervention. And we have a study where we have compared open repair with endovascular repair, and we have found
can you
that,
summarize?
Yes, sir. Yes, and we found that early mortality rate is better in endovascular. So, to summarize, screening programs are not yet established in India, but we need one. Current guidelines suggest endovascular aortic aneurysm repair is the treatment of choice unless patient is young with no other associated risk factors. Number of centers are increasing now with optimization of cost factor, and recent advances in the field of vascular surgery are reached to a stage that EVAR will be soon a daycare procedure and patient can walk home next day. Thank you.
Thank you, Nikhil. Due to the shortage of time, we'll take the question later on.
Okay.
Now I will invite our next speaker, Dr. Vinod Kumar Singh, Senior Consultant in Department of Critical Care, and he is also a member of Board of Management. His topic is high flow nasal cannula oxygen therapy as an emerging option for acute respiratory failure in adults. Over to you, sir.
Thank you, Dr. Anurag, for a nice introduction. So what I'm going to talk about is what changes has occurred in the last couple of years in the management of the acute respiratory failure, particularly non-invasive support. So we know that patient, mostly those who are of acute respiratory failure, the first line treatment is oxygen therapy. But many patients who has got a severe respiratory failure, they fail to oxygen therapy and they eventually going for the invasive mechanical ventilation, intubation and mechanical ventilation. So HFNC or high flow nasal cannula has emerged as one of the options to manage such patients. So what I'm going to talk about, some of the principles, cases and the current uses and evidences. You know that high flow nasal cannula acts by a triad of humidity and high FiO2 and a PEEP and increases the end respiratory lung volumes and alveolar recruitment. And it also has got an increasing role in providing the respiratory support, particularly, as I told, those who are failing on the conventional oxygen therapy. And these are the very simple equipments. You can see that we have a most important thing which is called a flow generator. It generates a very high flow. Then you have a humidifier. Then you have a heated cannula. And also you have a you can see here that the cannula is getting attached to the nasal area and this machine is working. So it can be used in any acute care area, ICU or even the ward. The principle of working is also very simple. The gas is warm and humidified and it produces comfort to the patient and it provides flow up to the 50 to 60 liters per minute, and also you have FiO2 up to 100%. It provides also PEEP up to 6 centimeters of water and also has an effect on the washout of the dead space. That way how it works. And if you look at how the clinical improvement in the patient is based on the two things. One is that comfort provided by the humidification. But more important is the high flow. The high flow has got impact on the expiration, which provided a PEEP to the patient. On inspiration, it provided the peak flow, which helps the patient to improve the alveolar recruitment. It improves the PO2 and PaCO2 and also decreases the work of breathing, leading to improving the gas exchange of the patient. Now we'll have a case of a 52-year-old diabetic male, 1 week history of fever and dry cough, breathing difficulty and desaturation up to 70% on room air. The patient was admitted in the emergency isolation, SARS-CoV-2 positive, and the patient has got a bilateral severe COVID pneumonia. As usual, the patient was put on oxygen, but there was no response to the oxygen. And this is the X-ray, which can see that the patient has got a severe bilateral pneumonia due to COVID-2. What we did, the patient was put on prone position. This is awake proning on the high flow nasal cannula, and the patient responded well to the high flow nasal cannula oxygen therapy, and gradually patient was weaned off and patient was getting shifted to the ward. The second thing again, this patient who has quite difficult patient who has a massive neck swelling, difficulty in intubating, there is no mouth opening, plus the patient aspirated and went into respiratory failure. Again, we put a high flow nasal cannula for the respiratory support, and then we did an intubation by the bronchoscope, and the patient was also got tracheostomy after getting the endotracheal intubation. So the goals of non-invasive respiratory support is to maintain the adequate oxygenation, provide enough ventilatory support, ensure that the patient is protecting the airway and the patient trajectory is improving, and that's all goals are met by the high flow nasal cannula. And if you look at the present option, we have to manage the patient who has got a respiratory problem and respiratory failure. We'll have an oxygen supplement by the mask. We call it conventional oxygen. We have a high flow nasal cannula. We have a CPAP. We have a BiPAP. And if you look how you choose the respiratory support is that depending upon how the severity of the respiratory failure. Its severity can be a very mild to a very severe form of respiratory failure, and then you choose according. You can go a conventional oxygen, you can go for a high flow, you can go for non-invasive ventilation, you can go for invasive ventilation, you can go for invasive ventilation plus ECMO. So present the changes has occurred in the management and selecting the devices which is going to support your respiratory patient. And as an intensive and acute care physician, a timely transition from therapy is very, very important, and recognition and prediction of failure is also important, and you should escalate or de-escalate according to the requirement of the patient, of the need for the patient. Now, where to start? Mostly it is started in the high dependency unit. If the PO2 FiO2 ratio has gone to less than 300, saturation has gone to less than 93% on the 5 liter of oxygen, or the patient has getting a saturation of less than 94% and 40% of FiO2. Start with a low flow, starting with the 30 liter per minute, and we can gradually increase to the 60 liter per minute, depending upon how the patient is tolerating the flow. And the target is to maintain the saturation about 93-94%, and you maintain the humidity. And this is also always should be started in HDU and ICU because these patients are high risk of failure also, and delayed intubation can be prevented. Now, if the patient is maintaining on the high flow nasal cannula, then how to proceed further? You can reduce the FiO2, you can reduce the flow according to the improvement of the patient. And how do you monitor those patients? We call it a ROX score. This is very simple. You check out the SpO2 of the patient and divide it with the FiO2, and then it's divided by the respiratory rate. For example, if the patient saturation is 88% on the oxygen FiO2 of 0.7 and respiratory rate is 28, then the ROX score is 4.48. And what is the importance? Importance is that if the ROX score is somewhere more than 5, your patient is going to have a successful weaning on the high flow nasal cannula. But if the ROX score has gone less than 3.85 or it has gone less than 3, then the possibility of failure of high flow nasal cannula is very high. That's how you monitor the patient who is on high flow nasal cannula. The first evidence, the landmark trial, came in the 2015, I think, and then they compared the 3 non-invasive strategy, high flow nasal oxygen, non-invasive ventilation, and standard oxygen. And they found that although intubation rate was not different, but a better survival in those patients who has got a high flow nasal cannula. And the mortality was just 12% with high flow nasal cannula if you compare with the 28% with the non-invasive ventilation and 23% with the oxygen. This is called a Florali trial, and which has a landmark study in the management of acute hypoxemic respiratory failure particularly. Again, COVID time also has shown that those patients who are on high flow nasal cannula has a less chance of going on mechanical ventilation and intubation. This is one of the studies which has shown that if you put a patient of COVID-19 on high flow nasal cannula with moderate to severe respiratory failure, the chances of intubation are less. Now, the third thing is that many ICU patients who get extubated, and there are some patients who get re-intubated. In those patients who has got a re-intubation, low risk of re-intubation, again the chances are less. So to take home message is that alternative means of respiratory support for critically ill patient, that is a alternative means, and more effective than conventional oxygen therapy in improving the oxygenation. The patient most likely to benefit from high flow nasal oxygen, mild to moderate respiratory failure, and Compared to a standard technique, HFNO or high flow nasal is safe and may help to avoid the limiting the hypoxemia during invasive diagnostic procedure. Thank you very much.
Thank you, sir.
Thank you, Dr. Anuballa, for conducting the session in a very orderly manner. And now I'll invite Dr. B.K. Rao, our ex-chairman, Board of Trust, Sir Gangaram Hospital Board of Management, to chair the session, and Dr. Kumar Singh to chair the session, and Dr. Satish Agarwal, if he is here. Yeah, please. Dr. Rao. So please. Dr. B.K. Rao. So I request the speaker to stick to the time of 8 minutes. You are running nearly 10 minutes late. So I request this session to finish on time.
Good afternoon. We start the next session, and we know we are running late, so we straight go into the session. And we invite our first speaker, Dr. Sudhir Kallan, the chairman of the Department of Minimally Access Surgery. He'll be speaking on approach to childhood and adolescent obesity.
Thank you, sir. This is a topic which is very close to my heart. On one hand, we are talking about young India which has 60% of population less than 30 years of age. We are talking about an 8% economic growth. But are we not focusing on good health of our children? I think it is very, very important that we focus on good health as well. There is a direct link between obesity and mortality. The moment the BMI goes above 35, the risk of death, actually I'm not mincing my word, death goes up. So we have to do something about obesity, because the consequences of obesity are multifold. From the head to stroke to respiratory disorders, heart diseases, gallstones, a lot of malignancies. There are so many things which can happen because of obesity. And if you see the prevalence of obesity all over India, more in North India, but almost catching up with the whole of India, the high incidence. And we did a survey, Gangaram, we did a survey of schools around our area, not only government school, private schools also. And we found that a 30% incidence of obesity was there. And this is before COVID. So I think after COVID, the incidence has gone up more. And these are some of the children which used to come out to our clinic in our OPD in Gangaram Hospital. And you can see they're all our children in the neighborhood, in our families, who are definitely overweight and obese and will become morbidly obese. So if we don't, these are children we used to see in America and Germany and other places. And this is the kind of obesity we have started seeing in our own country. And this is really, really worrisome. So the vicious cycle of obesity actually starts from childhood. A young, healthy child, because he is not moving around, he's sitting in front of the computer, becomes obese. And then he stops, because he becomes obese, he stops moving around less, he stops climbing stairs, he uses vehicles to go to the market, and he becomes moderately obese, and then becomes a severely obese child, and ultimately becomes an obese adult, harboring a lot of comorbidities, which we are going to discuss. So this is a very important study which we did in our own hospital. Dr. Latika Balla, who heads our adolescent obesity, this thing we did it, and we found that 30% of the school-going children in and around Gangaram Hospital were overweight. And 10% of all the newly diagnosed diabetic patients were children. So, we went and surveyed the schools, we went to the canteens and see what cooking they are done. And we were so surprised that oil was reheated, trans fats were being used, the school authority was not aware. They were not aware, but fortunately they were quick to rectify it. And I'm quite sure and very happy that with the help of our group, they help to modify good eating practices in the canteens. So multitude of factors responsible: lifestyle, we all know, wrong choices of food, sedentary, children are not running around, physical activities is less, they are eating high glycemic food, which is available through the Zomatos and the other things easily. And we used to think that these chubby children are very nice and very healthy, but all these chubby children are going to become unhealthy, obese adults. And now there is a very important as compared to a Asian Indian obese and a Caucasian obese, because in our country, all the Asian population, BMI, the metabolic syndrome happens at a lower BMI. So we have insulin resistance is higher, incidence of type 2 diabetes is higher, and these have to be addressed earlier. So the metabolic syndrome, about 1/3 of the overweight children are going to have metabolic syndrome, and we have found that they have insulin resistance, they have hyperinsulinemia, and the incidence of type 2 diabetes is very high, and along with type 2 diabetes, dyslipidemias are high, and obesity is actually a pro-inflammatory syndrome. So there is a high level of CRP if you monitor them, and that pro-inflammatory state is going to affect every organ of the body. It's like a termite which is going to eat into a body and affect every organ. So please, let's address obesity more seriously. And also there is a plethora of problems that are happening to the fertile age group of women: PCOD, infertility, dysmenorias, and all these things are all related to the pro-inflammatory state of obesity. Now, how to approach this is a symposium today, and I think the first thing is school health, good public awareness, early recognition, lifestyle modifications, and the morbidly obese child who is not undergoing help with anything needs some. So we started an initiative called Let Us Fight the Fat. This is an initiative of IMAS Gangaram Hospital, where we are trying to monitor and try to help the people who are obese. Defining obesity: adults, we all know any BMI above 25 is overweight, and anything above 30 is obese. But in children, 85 centile and above is overweight, and 95 centile and above is obese. So the monitoring of the BMI has become compulsory now, along with the other monitoring the pediatricians do. And ICMR has, this is a very simple chart, but very clearly defines what should be our weight goals. So for an obese child from 6 to 11 years, weight loss of 0.5 kg per month is good enough. And for an adolescent child, 12 to 18 years, if we target half to 1 kg weight loss per week, then we are going to achieve our target. So treatment options: no rocket science, good dietary management, increase physical activity, prevent sedentary behaviors. Some pharmacotherapy is available for the adolescent age group, and if nothing else, pediatric surgery. So these are the initiatives we have done at Gangaram Hospital. We invited all the school principals, we invited some celebrities, and we discussed about good eating habits and how the children should be encouraged to run around and go into the fields, and some marks should be given to children who are physically healthy, not only focus only on A+ and other things. And we keep on doing some social media campaigns also through FM, through LinkedIn, through Instagrams, to create awareness about obesity. And community intervention programs. A lot of these NGOs like Prerna, Chetna, they are doing a lot of work in creating awareness. The children, we are through some skates, some school approaches, we are trying to tell them that they should run around, they should, do some physical activities, and, we teach them healthy recipes. So this is a chart actually which says first target is to decrease the total calories. So total calories have to be decreased. If we decrease the 3,500 calories in a month total, then we can lose 1 pound of weight. So apart from that, we have to, the quality of those calories is also important. How we have to distribute in terms of carbohydrates, fats, proteins. So that awareness has to be created. And when nothing everything works, then we have to talk about bariatric surgery. So briefly touching about bariatric surgery, this is the only solution when you are morbidly obese and you have 40-50 kg weight and you have a lot of diabetes and other comorbidities. Bariatric surgery helps. But there are some existing guidelines for adolescent and childhood obesity. And this is first, BMI should be more than 40. They should have some comorbidities. At least they have tried 6 to 12 months to lose weight but not help. The skeletal maturity should have been, so we have to very monitor the skeletal maturity, and only the children who have achieved skeletal maturity have to be undergoing, and they must understand that bariatric surgery can produce some nutritional deficiencies. So the compliance, weight regain, sexual development, everything has to be. So bariatric surgery should not be sold as a quick fix solution, because obesity is a lifestyle disorder, and unless we change the lifestyle, nothing is going to work. So compliance of the patient is very important. Weight regain is a reality, and they have to think that unless they do lifestyle modification, the briefly about the plethora of surgeries available, I think the only surgical solution to children is sleeve gastrectomy, in which we just bring down the volume of the stomach, and with the help of sleeve gastrectomy we can bring down the hunger hormone ghrelin, brings down the appetite, brings down the intake, brings down the calories. And these are some experiences at Gangaram Hospital. These young children who became so healthy and beautiful after they have lost weight, and you can quickly see how there's a transition in their lives. They have lost 50-60 kg, become healthy, have lost their diabetes and become healthy. So some clinical support of 2 decades of Gangaram Hospital, we found that the resolution of diabetes, hypertension, obstructive sleep apnea happened.
Please conclude.
Yes. Diabetes got cured, weight got, and C-peptide, insulin resistance, all of them responded to weight loss. Gut hormones, ghrelin, GLP-1, all became better after this thing. The quality of life index improved. And lastly, the slide which says that a team member, a lot of people are involved in the treatment of obesity, and without help we cannot achieve anything. And this is the reversal we have to do from obese to normal children have to be achieved. Thank you.
Thank you, Dr. Sudhir, for bringing out the, the what we call as the next epidemic of obesity. Yeah. So I think his talk was quite clear, and anybody who has questions, we are running late of time. I'm sure you can catch up with him in the lunch time. So we move on to the next talk with Dr. Neeraj Jain. Dr. Neeraj is the Senior Consultant, Department of Rheumatology.
Good morning, everyone.
So he'll be talking on the low backache, Dr. Neeraj.
Yeah, thank you, chairpersons, and good morning, everyone. So today I will be talking on low back pain, a rheumatologist perspective. So to be very honest, we only share around 3 to 5% of all low back pain. But why it is important in evaluation is really worth the exercise. So if I ask just everyone in the audience, in the last 100 patients, how many you have seen? Maybe 50% or more, maybe 40%, 10 to 20%, or less than 10%. Yes, what is low back pain? Low back pain is a musculoskeletal pain or stiffness of lower back and lumbar spine. So acute is less than 6 weeks, subacute is 6 weeks to 3 months, and chronic is more than 3 months. So before we move on to an inflammatory back pain, we have to see we have to rule out what are the non-inflammatory causes. So if patient is systemically unwell, maybe it's some other cause, non-mechanical pains, hip joint signs, abdominal pulsations, maybe they just present with low back pain, and you keep evaluating for an ankylosing spondylitis or causes like that. So always look for radicular pain or neurogenic claudications like leg pain, sensory loss, reduced reflexes. Always see for bilateral buttock, thigh or leg pain, which is quite unusual with ankylosing spondylitis. And what are the risk factors? Individual risk factors like age, physical fitness, weakness of back, abdominal muscle wasting, smoking, obesity, as Dr. Kallan was mentioning, they can present with low back pain. Psychosocial causes like stress, a lot of fibromyalgia patients, they just present with back pain. And a lot of occupational hazards, which is like prolonged sitting, like IT people, BPO people, they may present with back pain. And these, what are the red flag signs before you move on to any evaluation? Look for cauda equina, fractures, infections, malignancies should be ruled out. And what are the differential diagnoses of mechanical back pain? Most common is lumbosacral muscle strains, lumbar spondylosis, disc herniation, etc. I won't go into detail. So this is what is ankylosing spondylitis if not treated. This is the picture which we used to see many years back. But if you treat and catch hold of ankylosing spondylitis early, believe me and trust me, you won't be seeing that patient who is landing up with a very stooped posture. So ankylosing spondylitis is a prototype of all axial spondyloarthropathy, but it is a group of diseases which ankylosing spondylitis is main, then reactive arthritis, inflammatory bowel disease, psoriatic arthritis, and Reiter syndrome, which we used to call as, in which urethra was also involved. So this is, there is what are like low back pain is normally goes unnoticed. There is a very unacceptably long delay, maybe of 8 to 11 years. Even in UK, they have missed it for almost 5 to 7 years, and inflammatory back pain. So the longer the diagnosis is delayed, the worse the functional outcomes. So this is very important. And 5% of patients, all presenting to general practitioners with chronic back pain, will have ankylosing spondylitis. So 95% will have a mechanical back pain or some other cause, and only less than 3 to 5% will be having an inflammatory back pain. So reaching a diagnosis, as in all parts of medicine, history is very important. Then comes examination, and only investigation builds up to only 5% of the causes of the evaluation. So this is the classification criteria. We rheumatologists have this habit of following all these classification criteria as given by EULAR ACR criteria. So any diagnosis for ankylosing spondylitis involves two arms. One is sacroiliitis and one is HLA-B27. So if you have sacroiliitis on imaging or an HLA-B27, then only you proceed further. So the inflammatory back pain basically will present with low back pain, and duration will be of more than 3 months. Age of onset will be less than 45 years, and it will localize to the back in serious modes of onset, and morning stiffness will be around more than 30 minutes. And it will be like, patient will typically say कि डॉक्टर साहब 4 बजे से 6 के 7 के बीच में ना कमर में दर्द होता है और ये बहुत करवट बदलते हैं. So nocturnal pain, early morning pain, young age, more than 3 months, look for inflammatory back pain. And these people have a very good improvement with all the NSAIDs. So that is also a very good sign. And absence of rheumatoid factor and rheumatoid nodule is very important. They may present with peripheral arthritis. So inflammatory back pain, sacroiliitis with or without spondylitis is very common. Always look for enthesitis. They may just present with enthesitis, and they have a lot of different entities along with ankylosing spondylitis. You can have a skin involvement, nail involvement, peripheral joints, family history, bowel disease, and they may be proceeding with a lot of preceding infection. Then you can have reactive arthritis. So this is a very good pictorial in which HLA patient may present with uveitis, psoriasis, spondylitis, colitis, sacroiliitis, and a lot of peripheral arthritis. So how do you evaluate? First, the most common investigation and most commonly ordered investigation in general practice is HLA-B27. Plus, please trust me, don't order HLA-B27 every patient of low back pain. It has to be an inflammatory back pain. So HLA-B27 is which is a very commonly present but not in all patients, and it does not appear to be a sole mediator in the development of this disease. So, but yes, HLA-B27 positive patients, they are more prevalent in white, and they have high frequency of uveitis, cardiac involvement, and hip joint involvement, and younger age at onset of inflammatory back pain, and they have more severe radiographic progression. That is the importance of HLA-B27. So, but definitely prevalence and disease association varies. It is not a diagnostic test. It is not a diagnostic test. So, all HLA-B27 doesn't meet ankylosing spondylitis. It supports the diagnosis of ankylosing spondylitis. And also, once you order HLA-B27, please mention PCR method. If you don't write HLA-B27 PCR method, common rule is to do by a flow cytometry, which can be a less sensitive method. So, when to ask? Asymmetrical oligoarthritis, strong family history, uveitis, non-mechanical back pain, and when to act when the disease manifests. Just don't treat HLA-B27. When to wait? Most of the time it is asymptomatic. And do you need to repeat it? Absolutely not. Don't repeat HLA-B27. Don't repeat rheumatoid factor, any other test. And the second test, which is very important, second evaluation, which is very important, is sacroiliitis on imaging. X-ray, you can have a grade 1 to grade 4 sacroiliitis. I won't go into detail. So this is a very common picture. If you don't treat, this is bamboo spine. And it's like very disheartening to see patients who come with bamboo spine, because this is one of the most commonly treatable disease nowadays with a lot of invent of anti-TNF therapy. And also, if you see ankylosing spondylitis and if you don't find sacroiliitis on X-ray, don't say कि आपको disease नहीं है, because they may be in a non-radiographic stage. Here comes the role of MRI to pick up early ankylosing spondylitis by bone marrow edema, erosions, inflammatory lesions. If you see the corner signs, the white one, this is the inflammatory lesions. And then they can also present with, if they come late, they may present with syndesmophyte ankylosis. So the classification criteria is back pain, anyone less than 45 years, more than 3 months, sacroiliitis or HLA-B27, and then the diagnosis is made. How do you treat? Treat them with NSAIDs. Physiotherapy, this is the cornerstone of therapy. Sulfasalazine methotrexate is mainly only for peripheral arthritis, not for axial variety. And now we have a lot of biologics, etanercept, infliximab, adalimumab, golimumab, and certolizumab. I won't go into the detail of that. When to start anti-TNF therapy? High disease activity. If you fail conventional DMARDs and very high ESR or very high CRP. Misconception, the last slide. Don't think it is rare. Don't think it is just a male disease. And commonest cause of sacroiliitis is TB. No, it's not. So you evaluate for ankylosing spondylitis. Raised ESR, CRP are essential for diagnosis. And normal X-ray does not exclude the diagnosis of ankylosing spondylitis. And so in last slide, Chronic back pain, less than 45 years, ask 3 questions. Both-sided buttock pain, improvement by movement, psoriasis. If more than 2 positive, refer to rheumatologist. If less than 2 positive, determine HLA-B27. If positive, then refer to rheumatologist. Thank you so much.
Thank you. Yes, thank you so much. So now I'll invite Dr. Satish Agarwal. And Dr. Satish Agarwal is Senior Consultant and Chair of the Pediatric Surgery Department. He's also Member Board of Management. And he's going to talk about the testicular pain and swelling in children, how not to miss an emergency. Dr. Agarwal. Thank you, Dr. Vinod. So this topic is a very simple topic, but very often misdiagnosed, rather misdiagnosed as an inflammatory infective condition and therefore treated by antibiotics. And my aim today is only to derive home one scenario where you please, as soon as you see such a child, refer rather than start making a diagnosis. So, at the outset, take this message. If you have any child, small or older child, 5 years or 15 years, 18 years, if he comes with an acute onset testicular scrotal unilateral pain, all of a sudden, without any pre-existing illness, without any trauma, then please consider, is it testicular torsion? And the best answer to this question will be given in the casualty of a big hospital where pediatric surgery department is housed. So now let us look at the differential diagnosis of acute scrotum. As I have highlighted here, 85% 85 out of 100 will have either the torsion of the testis or torsion of the appendix of testis, which is a small structure at the top of the testis, but manifests exactly in the same way. Acute onset scrotal pain, unilateral redness, edema, pain. Only 15% will have other diagnoses, of which epididymitis and orchitis will be only a minority. But unfortunately, most of these patients, when they are seen by local doctors, is diagnosed as epididymitis or orchitis, and benefit of doubt is given by administering antibiotics and anti-inflammatory. The pain subsides a little bit. Again, as pain goes again, change antibiotic, 5 days are elapsed, and by that time the testis is gone. So remember, the most common diagnosis is still testicular torsion. So epididymitis and orchitis is a definite diagnosis, but the scenario is very different. So when do you consider? So if the child has a known structural problem of the urinary tract, like posterior urethral valves, vesicoureteric reflux, urethral dysplasia, prune belly syndrome, or if the child has a recurrent history of urinary tract infections with fever, and he has a recurrent history of this testicular swelling with fever. Now mind it, acute testicular pain because of torsion does not have fever. So inflammatory condition like UTI, etc., the child will have recurrent symptoms and with fever. And he has a pre-existing urological disorders. In absence of this, epididymitis does not occur, full stop. So there is often a fight between diagnosing and decision making. And very often we keep on diagnosing without deciding, because decision at that given time is of paramount importance if you want not to lose the testis. So this is the repetition. 80 to 90% of adolescent boys, the testicular pain is caused by torsion of the testis. So high an incidence. Now clinical features, everybody knows, unilateral swelling, pain, swelling and edema. And when there is testicular torsion,
they usually have pain referred to the umbilicus because the root value is T10. And they often have vomiting soon after the onset of pain. And they often find it difficult to walk by the next morning. Now, imaging. 2 imagings are almost always done. When we see these children after 5 days, they've had umpteen numbers of ultrasounds and a nuclear scan. Let me tell you point blank, they serve no purpose in decision making. Decision making is clinical. We have seen patients who have come with ultrasound diagnosis saying testicular vascularity is good, and yet they had torsion. And why it happens is because with testicular inflammation, the surrounding skin becomes inflamed, and the ultrasonologist picks up that vascularity of the skin and reports it as testicular vascularity. And therefore, it's a very big mistake. But this happens every day. Therefore, please do not rely on investigations. So this 6-year-old boy came with 2 days history of swelling and pain in the left scrotum, no primary pre-existing symptoms, no trauma, and pain is worsening on antibiotics. So when we explore the scrotum 3 days later, look what we find. The testis is all black, gone. While the same scenario, when the child was referred to us within few hours, we could still detort the testis and save this testis. So this is the difference. If the child comes early, we can save the testis within 6 hours. And mind you, I am willing to come at 12 o'clock in the midnight, 2 o'clock in the midnight to save a testis. And we have done that any number of days, any number of times. It is such a fire-grade emergency. Gangaram emergency is open 24/7. Pediatric surgery team is available 24/7. Whenever you see such a child, please refer to Gangaram casualty or any other casualty where a pediatric surgeon is available, and he or she will come in the night and sort this testis out. And this is a typical contralateral effect also. If one testis is gone, you must fix the other testis because the anatomical abnormality which makes them taut exists on both sides. So as a rule of thumb, if one testis is lost or fixed because of torsion, the other one must also be fixed in the same sitting. So take home message, torsion is way more common than epididymo-orchitis. Spending time in investigation takes away the golden hours in which the surgeon could have saved the testis. If the testis is detwisted within 6 hours, it will survive. But if presents after 6 hours, you will have to remove the testis. And opposite side must also be fixed. And now an appeal, ladies and gentlemen. If you see a child with acute onset testicular pain, please refer to casualty and ask for pediatric surgical team to assess. Please do not waste time in making a diagnosis by fancy investigations, Doppler and renal scans and radionuclide scans. Take a decision to refer to a pediatric surgeon. Don't diagnose, decide. And instruct him to be fasting because he will require emergency exploration. Even if they are not fasting, our anesthetists are very skilled. They will do a crash induction because testis is very important. And do not make an empirical diagnosis of epididymo-orchitis. Thank you so much.
Thank you, sir. Thank you for a very nice presentation and giving the importance of the clinical recognition and early management of the testicular pain and swelling. Very nice talk, sir. But for the interest of the time, we'll not take any question at this stage. If time permit, at the end of session, we'll go for the questions.
So the next talk is by Dr. Veronica Arora, and she'll be speaking on genetics in clinical practice. Dr. Veronica Arora is a senior consultant in the Institute of Medical Genetics at Sir Gangaram Hospital, and this department is doing great work as far as the modern day genetics is concerned. Dr. Veronica, please.
Thank you, respected chairpersons, for the kind introduction. Good morning, esteemed colleagues and fellow practitioners. Today, I've been given this task of speaking on this really exciting topic of integration of genetics into clinical practice. So we start by discussing what is the scope of genetics. So everything that is varied amongst us, any differences that exist among our height, complexion, intelligence are genetic. So during pregnancy, we can prevent genetic disorders because the burden of birth defects is very high. We all know about the commonest genetic disorder called Down syndrome. Recurrent pregnancy losses can be treated by immunotherapy and genetic interventions. Also, genetics is involved in couples who are planning pregnancy. Infertility, about 20% of infertile couples have a genetic cause, either in male or female. Also, genetic disorders are those which present with global developmental delay, autism spectrum disorder, familial blindness, deafness, learning difficulties, short stature, intellectual disability, seizures, and muscle-related problems. Also, one myth that exists about genetic disorders is that they present only in adults, but that's only in children, but that's not true. So in adults, we have familial cancers, Parkinson's disease, Huntington's disease, familial hypercholesterolemia, and autosomal dominant polycystic kidney diseases, and the list is endless. So genetics present at every stage of life, and there are lots of myths to be busted about genetic disorders, the first being that they are always inherited. So we see a family in which one child has some sort of intellectual disability, so of course they are not always inherited. There are new mutations that occur during the embryogenesis and cell division. Genetic disorders are always rare. Individually, maybe yes, but collectively, they are not a rare group of genetic disorders. As Sudhir sir just spoke about childhood obesity, a significant proportion of childhood obesity is also syndromic and may be due to genetic causes. And now we have targeted treatment for the same. They are unfortunately not always visible, and they can be now cured by some sort of therapies. So when we talk about a cell, in the cell we have nucleus, and in the nucleus we have chromosomes. Each of us have 23 pairs of chromosomes on which there are located genes. Genetic disorders can be caused by chromosomal or gene-related abnormalities. We can have testing to prevent genetic disorders starting directly from a couple state, when a couple presents to us with the need to have a pregnancy, or at the stage of newborn with a family history, or finally we can also have some pharmacogenomic testing where we have certain drugs whose side effects or adverse drug related reactions are much more severe because of the presence of a genetic mutation, what is known as a pharmacogenetic testing. So the genetic testing starts from predictive testing for a disease to the preclinical testing to the clinical phase. So mutations in disease called genetic disorders. Mutations are variations that occur in the genome. One of the first described was the severe combined immunodeficiency. So the whole genome is like a big library of lots of information, and now we have been equipped with this excellent and exciting technology called CRISPR-Cas editing, where we can go find a mutation and then replace it with a functional gene. So presence of these disorders and these treatments should now make us aware for treatments and so on. So these are a list of disorders for which we already have genetic therapies, and this is something all the physicians should be aware of. Common disorders like thalassemia and hemophilia or immunodeficiency, HIV also we have therapy for. Another disorder, not a disorder, actually a very common multifactorial inheritance is a hypertension. Now there has been a recent paper in NEGM which describes a genetic therapy for hypertension, once in a month injection. So I'm sure a lot of people who are hypertensive will be willing to take the same. So when do you suspect a genetic etiology? First, of course, is presence of a family history. Whenever there is a disorder, we tend to ask if other family members are affected, and more than one affected family member gives a clue for a genetic disorder. Second is involvement of more than one organ system or inappropriate behavior, some difference in the face known as facial dysmorphism. And of course, presence of syndromic epilepsy, regression, abnormal body odor, etc. So now there are other myths that having a genetic disorder means disabled. That is not true at all. There are many genetic disorders like obesity, like polycystic renal diseases, G6PD deficiency, Gilbert syndrome, which when identified will help us in treatment and management, but they are not disabling. So the therapies can be at the level of gene, at the level of RNA, or at the level of protein. One such disorder for which we are giving gene therapy at our own center is spinomuscular atrophy. It is one of the commoner genetic disorder in which the child is a floppy child, hypotonic child, and this disorder is caused by deletion of this SMN1 gene we can see here. So the genes, there are 3 types of therapy. We are doing all of this at our hospital. So this gene therapy is called Zolgensma. It's extremely expensive, but we are giving to the patients under compassionate basis. So I'll just show a video of a baby. So this is a baby who was completely hypotonic, could not move even her hands, but after approximately 6 months of Zolgensma, she was able to sit on her own and even eat on her own. I understand that some of us may think that we don't have long-term trials and these therapy cost around 16 crores, but for a parent, this means a lot. So then we have that no genetic disorder is treatable and they are always predictable. That is completely untrue. It is worthwhile to do testing for the same. Another disorder for which recently a treatment has been approved is acute intermittent porphyria. So now we have an RNA-based therapy for porphyria. This is also a 3-monthly injection and it gives great results. Coming to renal disorders and genetics, so genetics does exist in all the medical spheres. So this is just one I would be talking about. This was a patient who was referred with chronic kidney disease with ultrasound suggestive of polycystic kidney disease. So on doing the testing, we found a mutation in the PKD1 gene and they were just up for transplant in the next month. So now the implication of this is that he was to get the kidney from his own mother who was also carrying this variant. So if the mother and the patient would have died if this transplant occurred, so we can understand and help in donor selections once we have done these testing. Of course, we can prevent the disease to go to the next generation, and we have a group of drugs called tolvaptans which act better on genetic kidney disease. Finally, due to lack of time, I'll just sum up that now we have treatments. This is an NEGM article called Zilebesiran, which is for hypertension. The first FDA-approved therapy for sickle cell disease, thalassemia, and the list is ongoing. In cancer, also, we do genetic testing so as to be able to offer the prophylactic mastectomy as was done by the celebrity Angelina Jolie. Finally, the benefit of genetic testing really lies in the fact that we can identify these disorders on time and we can help the family as a cascade to benefit from them, and finally to be able to treat and prevent this disorder from going to the next generation. So think genetic, and there is so much more to what meets the eye. Thank you.
Thank you, Dr. Veronica, for a very nice presentation and to enlighten us regarding the what is future of the genetics disorder for the general population as well for the medical fraternity also. Thanks very much, and we'll take the question at the end of the session. So,
thank you. After this lucid talk, I invite Dr. Ekta Lal. She'll be talking of evaluation of red eye. I have known Ekta from the school days. She had been an outstanding student and now she's an outstanding consultant. So Ekta, on to you.
A very good afternoon to our esteemed colleagues, and thank you, sir, for that kind personal introduction. Today, I will be talking about something that we all see, all of us will encounter this sometime in our practice, a very important topic of what do we do when we encounter a patient with red eye. So, we are going to begin this talk by talking about the causes of red eye. I have divided these into patients who present to us with visual loss and or severe pain. Now, these are the conditions which need an urgent ophthalmology referral. So if a patient of red eye has associated vision loss or associated severe pain, and these conditions include infectious keratitis, which is nothing but infection of the cornea, anterior uveitis, which is an autoimmune disorder, acute angle closure glaucoma is an absolute ophthalmic emergency where the intraocular pressure of the eye is very high, and these patients can even present with headache and vomiting. And scleritis, where again we have an underlying autoimmune disease, and they can present with red eye and acute pain. If we don't have any visual loss and there is no pain whatsoever, then we are probably looking at a case of subconjunctival hemorrhage, and these patients would either have hypertension, history of trauma, or might be on blood thinners, and this condition is self-resolving. It's like having a bruise in the eye. All we need to do is reassure this patient and it completely goes away, gets absorbed in the next 3 weeks. Then we have the patients who have a red eye without loss of vision, but they might have mild pain or discomfort. Now, this group of disorder is what we are going to be discussing in detail today. And this consists of right from episcleritis to dry eye group of disorders, to conjunctivitis, which a lot of us will clinically see in our practice. And if the patient is associated with red eye and itching, that's a hallmark symptom of allergic conjunctivitis. So let's look at these diseases a little bit more in detail. So these patients of episcleritis present to us with very mild discomfort or irritation. They usually do not have intense pain. There is no discharge. They will not complain of stickiness of the eyes, and the eye is relatively quiet. There is no papillary or follicular reaction. Usually it is self-resolving, but a few cases might require topical NSAIDs or topical steroids. And if episcleritis is recurrent, we might need to look for an underlying autoimmune disease. Now, dry eye group of disorders is extremely common. About 50% of the patients would have dry eye group of disorders. And these patients are typically older in age group. They present to us along with red eye. There'll be symptoms of grittiness, irritation, pricking, or burning sensation. And because of the dryness, the tear film breaks up. They can also complain of intermittent blurring of vision, which becomes better when they blink. Not just old, but recently, even the younger patients might have dry eye because a lot of screen time is being spent by the younger lot as well. So this is something we need to keep in mind. Now, dry eye evaluation is a complex topic, and these photos that we see just give us a clue about severe dry eye patients. These are pictures with patients who have Sjogren syndrome secondary to rheumatoid arthritis. So I would just like to share a small clip here. If we look at the tear film and look at the corneal involvement over here, we understand the severity of dry eye. So the management typically depends on what is the reason, what is the type of dry eye, and the severity of the disease. Another group of disorder which can cause dryness is meibomitis and blepharitis, which means involvement of the lid margin. The meibomian glands, as we can see here in this picture, they actually secrete a kind of a lipid layer which prevents evaporation of the tears. So this group of disorders causes evaporative dry eye, which means our tears are getting evaporated faster than they should. So it is important that we take a look at the lid margin, and these patients can be misdiagnosed if we don't take a look at the lid margin. This is a very interesting case that I would like to share here. This is a 4-year-old boy who was being treated as allergic conjunctivitis for a long time since he complained of itching and redness, which was on and off. And when we examined him, he actually had pediculosis. So we can also have involvement of the eyelashes. We can have demodex and pediculosis in the eyelashes and even eyebrows. So this is something that we need to remember, that blepharitis is the technical term for this, can have various causes. Then we have the conjunctivitis group of disorders, and here the patient typically complains of irritation and foreign body sensation more than pain. If the one question that we need to ask is, are your eyelids sticking in the morning when you wake up? And if the answer is yes, then we are probably looking at infectious conjunctivitis. They can have associated lid edema, and typically they have one eye involvement followed by the other. And we will have certain signs that we can elicit on examination, like follicular reaction. Another important clue that this patient has viral conjunctivitis is preocular lymph node involvement and also associated viral upper respiratory tract infection and fever. So if a patient who has preauricular lymph node palpable with associated upper respiratory tract infection complains of redness, stickiness of the eyes, we are probably looking at viral conjunctivitis, and it is usually self-resolving because it's not a bacterial infection, and all we need to do is give supportive therapy in forms of cold compresses and lubricants. So there are some cases of viral conjunctivitis which can involve the cornea, and these patients will complain of visual loss and discomfort, and these require an ophthalmology referral. Then we have bacterial conjunctivitis, where patients will have a lot of purulent discharge, intense congestion and stickiness, and these are the patients who require topical antibiotics. Then if a patient presents to us with symptoms of redness and itching, then we are probably looking at allergic conjunctivitis, which is extremely common and must not be missed because they can have severe sequelae if we don't treat them on time. So these patients can also have discharge, but it is more serous in nature rather than thick and sticky discharge that we see in infectious conjunctivitis. And they have, if we avert the upper lid and see, they will have these kind of papillae on the tarsal conjunctiva. These are patients that you can identify. They will come to your clinic with other symptoms of allergy as well, like allergic rhinitis or bronchial asthma. And there can be spectrum of allergic conjunctivitis. So typically everyone feels that allergic conjunctivitis is a very mild disease and it cannot cause any issues in the eye. But actually that is not true. It can range from seasonal allergic conjunctivitis, which is a mild disorder, to very severe disorders like vernal keratoconjunctivitis or spring catarrh as it's commonly caused, which can actually lead to vision loss also if not treated on time. So to summarize, I would just like to end with this one slide. If we have a patient of red eye with mild irritation, then how do we know what to do and what all treatment can we as physicians start? So if a patient with red eye complains to us with burning and ocular irritation, then we are probably looking at dry eye. If this is a young patient who has excessive screen time and otherwise the symptoms are intermittent and not very severe, lubricants can easily be started and they are very safe to use. Severe forms of dry eye associated with Sjogren's syndrome or other disorders would require management by an ophthalmologist in terms of even topical or oral systemic immunomodulation and surgical options as well. Viral conjunctivitis is self-resolving until and unless patient has loss of vision. Bacterial conjunctivitis requires installation of topical antibiotics. Mild allergies can be self-resolving. Cold compresses and lubricants can be prescribed easily, but patients who consist of recurrent episodes of itching in the eye must be treated on time because they again would require topical anti-allergics and even topical steroids, as well as few cases which are very, very severe can require even oral steroids and surgical management. I hope this helped in clearing up a few doubts about red eye. Thank you, everyone. Thank you.
Thank you, Dr. Lal, for a very, very clear and very crisp and very informative talk. Thank you so much. And let me now invite Dr. Ruma Satvik to answer a very pertinent question. What is the right age to start a family? Dr. Ruma, please.
Good afternoon, everyone, and good afternoon, chairpersons. As an IVF practitioner, I often encounter two kinds of women. The first is the larger proportion of women that I encounter, and these are women who are unable to conceive, quite distressed with that prospect. And the second kind are women who are trying to buy time between their professions and having a baby, and also distressed at having to face the prospect of why do they need to go through a procedure at the prime of their reproductive lives. So sure enough, we find that the facts actually favor their distress is not misplaced, that the number of IVF conceived babies out of all babies are going up with time across continents, Africa, be it Europe, be it America. And although we don't have figures from India because there is no central database, and we are likely to have one after the ART Act 2021 was passed, you can see that 4% of all childbirths in Australia are because of an IVF conception. And that's a huge figure, 1 out of 25 kids. For India, a rough ballpark estimate might be at 1 in 500 and likely to go up in the coming years. So what is really causing this increase and this push towards an increase in IVF conceptions globally? And this is largely because you can see that the median age at which women are choosing to have their first babies has gone up globally. So these are the first box gives figures for what is happening in England. So over a woman or women who were born in the 1940s and 50s were more likely to have their first childbirth by 21, but their daughters born in mid-70s were more likely to have their first childbirth by age 31. And the cohort born in 1990 have entered their 30s with half of them being childless. For India, the figures are at 17 and 23 currently, which is the median age, which means that half the women will still choose conception after 23. Doesn't sound like much, and it actually augurs well for a country like India. And what are the factors that are pushing these ages up and changed in reproductive behaviors? And one of the biggest factor here is women's education. We know that 2 crore women in India enroll in postgraduate courses. And that's a huge figure. It accounts to really about 40%, 45% of total people who enroll in higher education. Great for women's liberation. Urbanization is also pushing women to have their births later because of a need to have a job and poor job opportunities in rural area, which means that families and men and women migrate to cities, and that means they need to have a job, and that job means later pushed and deferred parenthood. And exposure to mass media is the third reason why parenthood is being deferred. So while this is being deferred, it comes at a cost. And the trade-off here is a drop and decline in fertility. So great for women's liberation, but what it is also doing is that half the women at 40 years will find them unable to have a baby. And these figures for women at 35 to 39 are at 15%. So this is perhaps the result of lowered ovarian reserve as one ages. The ovaries, ovaries shrink, their function declines. And one way to assess ovarian volume or ovarian reserve is AMH, as this graph depicts, that the peak is at 20 and thereafter it starts to decline significantly, reaching to near zero values at 45. So it does not just reduce fertility, but age increases the risk of miscarriage, so much so that at age 40, half the conceptions will be lost to miscarriage. So there are other effects of having babies at a later age, and these are hypertensive disorders, other medical risks that the woman would have accumulated as she ages, preterm deliveries, operative deliveries, and an increased risk of congenital anomalies. Where does that leave us? That we also understand that women who are having their births later are women who are financially stable, perhaps more emotionally mature, have more responsible health behavior. And how then do we balance this need where biology is saying you have early babies and their needs to have their jobs are saying it's all right, keep deferring your childbearing. So the question that we are trying to answer is in this slide is till age 30, it is acceptable for women to defer their parenthood. And about 95% of women will still remain fertile till age 30. Between ages 30 and 35, the risk of infertility is at 10%. You decide whether you want to have a child at 31 or 32 based on certain red flags. By age 35, you definitely choose either one, childbearing if you have a partner, or fertility preservation if you don't have a partner. What are these red flags? Can we identify them early on and advise them accordingly? The red flags are, and one of them remains maternal history of menopause. So if a lady's mother has had menopause at or before 40 and she's wanting to defer fertility, childbearing, she is one lady who should be advised not to. Menstrual cycle shortening or irregularity is another reason that you want to test her further and advise accordingly. Endometriosis, surgeries for endometriosis, any other surgery happened in the pelvis, prior pelvic radiotherapy, chemotherapy, those are points that should alert one to testing further. And the test done is AMH, where when this is found to be less than 1.2, one definitely advises women against deferred parenthood. So just try and balance this against what is happening to men. What happens to men as they age? And this graph pretty much tells it as it is. So while women, if at 20, their fertility is at their highest, and so with passage of time, you can see by 30, just after 30, how fertility begins to decline in women. And they have reached half their fertility levels by age 35. As opposed to men who at 30 have similar fertility rates and will continue to have the similar fertility rates, they reach half their fertility levels at age 50. So while men have this broad period, 20 years, in which to make their lives, women perhaps for them, by 35, they have to start pressing the panic button. So IVF, as one tends to feel that maybe it will compensate, IVF also has age-related results. So for women above 42, the results are dismal at less than 5%. And for women above 40, the results will be at less than 10%. So what is the take home of this talk? It's a very small and a simple talk, but largely what we are trying to say that despite advancements in our reproductive behavior, in technology, in, post the Industrial Revolution and how it has hit us, what we haven't been able to change is female reproductive physiology. Which is why biology continues to trump all these changes. And I hope that there will be a day when we can change that, when we can increase that gap between when they start trying and how much time they have. But till then, it is awareness of this grim fact that will trump ignorance and perhaps allow more women to have children at the right age. Thank you.
Thank you, Dr. Uma, for very nice and balanced presentation regarding these things. And we'll take the questions if the time permits after the session. Thank you.
Now, for the last speaker of the day or the session, we invite Dr. Madhvi Chandra to talk about mammography and ultrasound in daily practice. Madhvi is a senior consultant in the Department of Radiology with expertise in mammography. Madhvi.
Good afternoon. Thank you so much for having me here, and thank you for being here to listen to me. Thank you, chairpersons. A lot of patients will be coming to you in the OPD with breast-related problems. And what do? How do you refer them? So the first group that come may be asymptomatic. So are we going to do no breast imaging for asymptomatic women? Actually, over the age of 40, all women deserve a mammogram once a year, because the main aim of breast imaging is to pick up small cancers and pick them up at a time when they can be treated very easily. So look at this mammogram. This is a 66-year-old woman who has come in for a screening mammogram, and first look, it all looks normal. This is a normal 2D mammogram. Now, what a 3D mammogram does is it reconstructs thin slices through the breast and shows us a lot of things which are not visible on routine 2D mammography. So when we look at the 3D slices, we see this very tiny, irregular, speculated high-density mass, which is easily localized because tomosynthesis also shows us where it is located in the breast, which is 2 o'clock middle third, and we find it on ultrasound. And this is actually a 4 mm cancer. It's almost so tiny that this patient has a great prognosis. She's been operated now. This was 1 year ago. She was node negative, and she's doing brilliantly. So this is the idea of breast imaging, that even for asymptomatic women over a certain age, you must order mammograms once a year. Then the patients who come in with different types of clinical problems. Amongst those may be breast pain, there may be nipple changes, there may be skin changes, there can be nipple discharge, or there could be lumps in the breast and axilla. And the main things that we use, the main modalities that we use to evaluate these things, these symptoms are ultrasound, mammography, and mammography with digital breast tomosynthesis, which is 3D mammography. MR, etc. are used very rarely. So now breast pain is normally not a sign of breast cancer, and in the younger patient where it's cyclical, that is, it varies with the menstrual cycle and is diffuse all over the breast, you don't need to order any imaging. You are the cardinal people there, and all you need to do is reassure the patient and say that, we'll just watch you for a bit. But over 40, you do need to order a regular mammogram. Now, in diffuse cyclical breast pain, you may just get general tissue like this with some cysts, etc. That's fibrocystic changes, and you only need to treat the patient clinically if at all you image. But look at, in some patients, like this 28-year-old had focal left breast pain that was persistent. Now, she's very young, and she went for ultrasounds. She had 2 ultrasounds at clinics outside, and both were reported as normal. But when she came to us, what did we see? We saw that, there was hypoechoic tissue along the ducts, and there were also these white specks that you see. I'm sorry, I'm losing the pointer here. So these white specks that we saw look like microcalcifications. So she was 28, but we took her to a mammography. And we did a mammogram, and what did we find? We found these malignant microcalcifications all over the breast. So when you have a patient with suspicious findings on ultrasound and your radiologist tells you that a mammography is required, please listen and go ahead and do that mammogram. On the 3D, we also found a breast mass. And this was invasive ductal carcinoma in this young 28-year-old patient, because in our country now we are getting a lot of young breast cancer. Age is no protection against having breast cancer. Now, this is a 55-year-old patient who had breast pain for 20 years. External mammogram was reported as negative or had breast cysts. But when she came to us, we did a 3D, and we found this architectural distortion and on doing an ultrasound of that area, we found non-mass findings, which is the lower frames there, which show the Doppler, the colorful, the vessels there. And we biopsied that area because we found it on ultrasound. So that's a cheap biopsy, easier than mammography, easier than an MR-guided biopsy. And we found this invasive carcinoma, which would have been missed otherwise. Palpable masses are commonly cysts, and most palpable masses are benign, but they can also be complex cystic masses or solid masses, some of which are benign, some are malignant. Now, under the age of 30, you do only an ultrasound usually, unless suspicious findings. Over 30, always add a mammogram. Never go only for an ultrasound or you will miss cancers. Now, like I said, a lot of palpable masses are cysts. They can be simple, which is just thin and anechoic, or they can have debris within them, but the ones with solid masses within the cysts are to worry about. Now, this is a breast cyst in a male patient. Now, there's just debris, but in males, you should not have any kind of cyst because male breasts don't have lobules which form cysts. So this on excision was again a cancer. So always beware a breast cyst in a male patient. Then this is a lady with a very large, sharply defined mass. On this, mammography doesn't give us a lot except that there's a large mass, but ultrasound opens up the inside of it and shows us a mass which has multiple papillary lesions, and this was a benign papillary mass. But this is another large, sharply defined mass. This has suspicious calcium, and so this was malignant. This was an invasive papillary carcinoma. Then you can have phylloides tumors, which are again cystic and solid. So ultrasound and mammography have to work together. Coming to solid masses, the commonest are bilateral, oval, hypoechoic, circumscribed masses, fibroadenomas, but not every oval circumscribed mass is a fibroadenoma. Like this one turned out to be malignant. When we added mammography, you see that there's skin thickening there. There's a margin that's bad. So this is a malignancy. This was again a medullary carcinoma. And what happens if on ultrasound you see something that looks typically malignant? Is that it? Do you just go to biopsy? No. Because when you do a mammo, you see that there's also calcification here. So the breast is involved far more than the basic mass that you saw. And this is not a patient in which you can just operate the mass, do a breast conservation, you will have to go to mastectomy. So adding a mammogram is very important. Similarly, in males, this was a patient with a breast lump, misdiagnosed as a cancer. FNAs showed atypia, so they referred for a mammo. We said it's just, tissue arranged centrally around the nipples in a flame-shaped distribution. This is gynecomastia, but they insisted on doing a biopsy. So even in males, mammography is far more sensitive than ultrasound. Coming to the last section, which is nipple discharge, I may go half a minute over. Bear with me. So physiological nipple discharge is bilateral from multiple duct orifices, and it's non-spontaneous. The patient will tell you she expresses the discharge. You can ignore that safely. White, green, or yellow, that's safe nipple discharge. Pathological nipple discharge is unilateral from one orifice. It can be clear or blood-tinged. Worry about those. So in physiological, under 40, no imaging. Over 40, you can do a mammogram with or without a DBT and an ultrasound. And pathological, you will always image. You may use ultrasound, MRI, or mammography. This is a patient with Paget's disease. So the nipple shows erosion, that is the cancer growing out, but the mammo shows you much more disease inside. And similarly on ultrasound, and we biopsy this, and MR is great for Paget's, and then you can have central benign papillomas. You can have central malignant papillomas like this one. So nipple discharge needs imaging. The take-home points. Mammography gives you a global overview, which ultrasound cannot, because with a small probe, we are covering a lot of tissue. So it can be your friend and help in not missing breast cancer. So if your radiologist says, please do a mammogram, please don't worry about radiation, please don't worry about the patient saying that there's breast pain in mammography, you must order that mammogram because mammography has a very low level of radiation, unlike what everyone is worried about. Ultrasound alone is not adequate in many situations, but with mammography, it will tell you what's inside the masses that you're seeing on mammography, and it helps you in doing cheap biopsies, reasonable biopsies, which is very important in our country, where there's no insurance and cost is a concern for patients. And so mammography and ultrasound walk hand in hand. You cannot do one only. And in our country, there's an increasing percentage of young breast cancer. Almost 40% of our breast cancers happen under the age of 40. So please don't hesitate in ordering imaging. You must assume that young patient can also have breast cancer, and always get the patients imaged completely for good clinical outcomes. Thank you.
Thank you, Dr. Madhavi, for a very, very informative talk, very clear pictures. So with this talk, we conclude this session. We had very interesting talks. I'm sure all of you will go enriched with much more knowledge from this session. So thank you very much.
Thank you, Dr. Rao and Dr. Vinod and Dr. Satish for wonderfully conducting this session and finishing on time. And now I'll invite Dr. S.P. Beota and Dr. Harsh Johri on this stage for chairing this session. And these two people have really served the Gangaram Hospital in a various capacity in the management board and in trust board. And probably for last 40 years, I've been seeing them, the way they have contributed to the development of the hospital and maintaining the ethos. And Dr. Johri has already started outreach program for the patients, giving them services at the home, which is doing really wonderfully well. So please come on the stage. And Dr. P.K. Jain is here. He is from the anesthesia department and primarily runs the pain clinic in Sir Gangaram Hospital. So Dr. P.K. Jain over here.
Well, good afternoon, ladies and gentlemen, and welcome to this pre-lunch session. Very important session, I'm sure. It's going to be very, very informative. And on this, and the first speaker for the day, Dr. Ambrish Sadvik. He's a senior consultant in Department of Vascular Surgery. He's going to talk on intervention for stroke prevention. Well, Dr. Ambrish.
Thank you. Good afternoon, chairpersons and colleagues and seniors. What you're seeing on the screen here is a critical stenosis. It's an angiogram of the carotids, and you're seeing a critical stenosis in the internal carotid, which is the cause for stroke. Perhaps the greatest tragedy that can befall a living human is to suffer a stroke. The tragedy is not just the loss of function and the loss of autonomy, but it's also the loss of dignity, and that one becomes the object of pity. And one must remember that, I think the video is not playing. One must remember that this isn't necessarily an affliction that afflicts the elderly. It can afflict individuals in the prime of their life as well. As you can see here, this is a young man who's had a craniotomy post a stroke. Stroke is the fourth leading cause of death in the developed world. 3 times as many women will die from stroke as from breast cancer. 80% of stroke is ischemic, and 40% of this is due to a plaque in the internal carotid artery in the neck. And stroke due to the carotid plaque is not because of hypoperfusion, it's because of embolism. Why that happens was explained to us by this gentleman, Dan Bernoulli, who propounded Bernoulli's theorem. He said that when you've got flowing fluid or flowing blood and it encounters a very tight narrowing, the velocity of blood increases. Look at this. This is a Doppler ultrasound of the internal carotid artery in the neck. And the normal velocity of blood in the carotid in the neck should be around 50 to 60 centimeters per second. But look what happens here. It's 745 centimeters per second. It's more than 10 times. This is what the stenosis looks like in a CT angiogram. Same patient. This is the stenosis in the internal carotid in the neck. And this is what it looks like from the inside. You can see friable debris in a friable plaque, which is subjected to forcefully turbulent velocities of blood. What's going to happen? This debris is going to fly off, go to the brain, and cause a stroke. Sometimes there are warnings in the form of transient ischemic attacks or minor strokes. 2 out of 10 strokes will have a warning in the form of an index event or a transient ischemic attack. And therefore, after the index event, it is imperative that you act with absolute urgency. A massive stroke is probably on its way. Look at this study. In patients who had had a stroke and had an earlier transient ischemic attack, 17% of these patients had it on the same day as the stroke, 9% on the day preceding the stroke, and 43% in the preceding 7 days. So a TIA is a warning. If you were to pursue the opposite line of inquiry and follow the index event or the TIA, 21% patients with significant carotid disease who had had an index event in the form of a TIA had a stroke within 14 days. The trouble is that not everyone can diagnose and identify an index event, not even physicians. This is massively important because the time to intervene and treat the carotid is within the first 14 days. So as primary care physicians, you must ask the following questions. Was this a stroke or a TIA? Which vascular territory is involved? And most importantly, should a carotid intervention be considered? Why is vascular territory important? I'll illustrate with an example. 57-year-old female, diabetic, sudden onset right-sided hemiparesis. Carotid Doppler showed bilateral critical stenosis in both carotids. But look at the MRI. She has a pontine infarct. This has nothing to do with the carotid circulation. Fixing her carotids will not help the patient, will not prevent a stroke. This is because of vertebrobasilar deficiency. But indeed, if you have identified in a patient it is indeed the carotid plaque that is responsible for the index event, then a vascular surgeon must swing into action. The question now is, which procedure is the best for the patient? Carotid endarterectomy or stenting? We do both of these in prolific numbers. So I'm going to show you videos and animations of both procedures, and I'll allow you to make up your own mind about which is the superior procedure. Let's start with carotid stenting. What we do is, under local anesthesia, puncture the groin, put in a sheath, take a guide wire through the aorta into the ascending aorta and the arch, and then take the wire into the carotid. And you can see that this wire will negotiate the stenosis. While it is negotiating the stenosis, it could abrade against or bump into the friable matter in the plaque and thereby causing a stroke even during the procedure. But once you've negotiated the stenosis, we deploy a filter proximal to the stenosis, then balloon dilate the plaque to make space for the stent, deploy the stent, do post-stenting repeat balloon dilatation. You can see that the debris that's flying off is now captured by the filter. When the procedure is done, the filter is retrieved and then taken out of the carotid. Interestingly enough, you'll see that what we've done is just lateralize the debris and lateralize the plaque, just squished it against the wall of the artery. You haven't removed it. And if the debris is loose, you can see that through the struts of the stent, it can still fly off and cause a stroke in the brain. Conversely, surgery, carotid endarterectomy, is also done under local anesthesia. We make an incision in the groin. All of this is while speaking to the patient. We dissect all the way down to the artery, clamp the arteries, and then make an incision, an arteriotomy, extending from the common carotid artery into the internal carotid artery. You can see the plaque. A shunt is placed to make sure that flow to the brain is not impeded during the procedure, and then we use a special dissector to remove the plaque from the arterial lumen. And the artery is closed and repaired using a fine Prolene suture. This was animation. This is a video of the procedure underway. You can see this is the arteriotomy being given. The artery is now open. That's the plaque. Look how nasty that is. Imagine trying to pass a guide wire through that. Look at the lipid-rich necrotic core. Imagine trying to squish that against the wall. And this is a Watson chain dissector that's used to actually dissect between the layers of the artery. Endarterectomy means separation of the intima and the plaque from the remaining layers of the artery. It's a very precise maneuver, and this is how the plaque is extricated from the artery. You can see that on the left is an image that shows the debris, which is friable. On the right side is an image of the artery that's clean. It's as clean as a whistle. Now, there have been numerous head-to-head trials, randomized controlled trials and comparisons that have been done to try and ascertain what the comparative complication rate and success of both procedures would be, carotid endarterectomy and surgery. This is a busy slide, but I just ask you to focus on the row under CAS, which is carotid artery stenting, and then compare it with the figures under carotid endarterectomy. You'll see that the complication rates are twice or thrice as much in carotid artery stenting as compared to carotid endarterectomy. This is multiple randomized controlled trials. So therefore, countless guidelines have established that if after an index event, a procedure has to be done for stroke prevention, surgery or carotid endarterectomy is far superior to carotid artery stenting. And I'm repeating this ad nauseum, but this is mostly because the transient ischemic attack is caused by some sort of thrombus or friable matter sitting on the plaque. So one shouldn't try and fool around with this with a guide wire or a balloon. We have to raise awareness on early referrals. Even in the best centers in the world under the NHS, like this one at Oxford, look at this. Median delay from symptom to hospital referral was 9 days. From event to getting a CT angiogram was 33 days. From event to carotid endarterectomy was 100 days. This should be the take-home message. A terrible surgeon operating within 2 weeks of an index event with a 10% procedural risk, that's terrible, will still prevent more strokes than an excellent surgeon deferring surgery by 4 to 12 weeks and operating with a 0% procedural risk. The genius of carotid endarterectomy is that it can be performed in any kind of carotid anatomy. Look at this, hostile anatomy, all kinds of kinks in the internal carotid artery in the neck. Stenting is not possible, surgery is possible. Dense calcium, stenting would be a disaster. Thrombus in the internal carotid artery, stenting would be catastrophic. And even in ulcerated plaques, surgery can be very efficiently performed. This is our little contribution to the discourse. We've evolved a novel technique of doing carotid endarterectomy where we give a very tiny incision on the carotid bulb. We do not extend it into the internal carotid artery. Clamping times are much less, and we evert the plaque. You can see this, evert the plaque out of the internal carotid artery. This is the plaque being removed, and this is the clean artery post-endarterectomy. In summary, remember, after an index event such as a transient ischemic attack, the big one, the big stroke might be coming soon. Time is brain. Therefore, an early intervention is absolutely essential. And as an early intervention, surgery is superior to stenting. Thank you.
Thank you, Dr. Satvik.
Sir. Sir. Yeah, so that's an excellent question. We have objective parameters of finding out if perfusion to the brain is not enough. We do what is known as stump pressure evaluation. It's a technical detail, but if we feel that the stump pressure, which is beyond the clamped internal carotid, is less than 50 millimeters of mercury, we put in a shunt, which I had shown in the animation, which ensures continued perfusion to the brain. And clamping times in carotid endarterectomy can be as low as 8 minutes to about roughly 20 to 25 minutes.
Thank you, Dr. Savdik, for explaining very simple way in animation the different intervention for the stroke patient. May I invite Dr. Sangeet Agrawal, who is a head and neck oncosurgeon and specialized in head and neck oncosurgery. He is a consultant at Gangaram Hospital, head and neck oncosurgery. So, Dr. Sangeet Agrawal, please.
Good afternoon, respected chairpersons, my colleagues. Today I will give an overview of surgeries in head and neck oncology department of Sir Gangaram Hospital, what we are doing and what are the surgeries. So basically what are the main surgeries in head and neck are the oral cancer surgeries, laryngeal cancer surgeries, salivary gland tumor surgeries, mainly parotid tumor surgeries, then thyroid malignancies, then parathyroid tumor surgeries, sinonasal, and some of the neck masses like carotid body tumors, parapharyngeal space tumors, skull-based tumor resections, etc. So we start from oral cancers. So the most common cancers in the India is tongue cancers, which is the lateral aspect of the tongue. There is a non-healing ulcers. So what is the standard treatment of these type of ulcers is first we should do a biopsy, and after that if there is a squamous cell carcinoma, which is most common. So the most common is the treatment is a surgery. And the surgery should be oncologic surgery. There should be no partial excision or incisional excisional biopsy. So there should be a standard surgery like partial glossectomy with block dissection of the neck, and it may be primary closure or it may be free flap surgeries. So the next common surgery in the India is buccal mucosal carcinomas. So the most of the buccal mucosa needs reconstruction. So the standard surgery is oral composite resections with neck dissection and the flap reconstructions. Previously these surgeries were called as a commando surgery. So now there is a newer nomenclature, which is the oral composite resections with marginal mandibulectomy or segmental mandibulectomies. So this is our patient, which we did almost total glossectomy, anterior total glossectomy, and we reconstruct this with anterolateral thigh flap. So these are the some our commando surgeries in which we did segmental mandibulectomy with appropriate reconstruction. So these are the alveolar carcinomas, which we did partial maxillectomy, upper alveolectomy with radial artery free forearm flap. So these are the some surgeries of the oral. This is the neck dissection. We routinely preserve marginal mandibular nerve, which is the supply of the lower lip. If it sacrifices, then there is a dripping of the lower lip. So the next most common cancer in the head and neck region is the laryngeal cancers. The standard treatment is total laryngectomy with the neck dissections. So these are the some our laryngeal specimens. So this is a total laryngectomy, and we do routinely tracheoesophageal fistula and for voice. The next most common surgeries in our group is thyroid malignancies. So most of the time thyroid malignancies present with a node also. So we do total thyroidectomies with neck dissections. So we have a international complication rate of less than 1% of recurrent RLN palsy and hypocalcemia. So this gentleman had a coconut size of tumor we removed safely in our hospital. So this is the very rare phenomena of non-recurrent laryngeal nerve in one of our thyroidectomy patient. So what is non-recurrent is it is arising from the lateral aspect of the vagus nerve directly in the neck. So in case of when we sacrifice the recurrent laryngeal nerve, if it is inside the tumor, we do re-innervation surgery by ansa cervicalis nerve. So we are doing routinely parathyroid surgeries for a hyperparathyroidism. So hyperparathyroidism is a common phenomena with the renal stones, with gallstones and pancreatitis. So our gastro people and renal people and endocrine people routinely diagnose these cases and send for surgery. So it is a protocol of parathyroidectomy in which we send PTH levels on the operating table and we find the result in half an hour. So if PTH level falls more than half within 10 to 20 minutes, it is the successful surgery. So this is our parathyroid specimen, and this is small incisional, hardly 1 to 1.5 centimeter neck incision. So salivary gland tumors are our very common tumor surgeries in our setup. So we routinely do parotoidectomies with a very less complication rate. We usually preserve greater auricular nerve, which supplies the ear pinna. So these are some smiling faces after the parotoidectomies, and these are the dissected nerves of our specimens. So these are the big tumors also. So she is a young female of 20 years. We are doing in a young female with a facelift incision. So we don't find any scar after a few months. So the pediatric parotoidectomies is a very challenging because of facial nerve. So we are doing regularly pediatric parotoidectomies with, these are the some children with smiling faces. These are the less than 15 years of age. So we are doing sinonasal tumors, which are very complicated tumors, and the standard treatment is total maxillectomy and the partial maxillectomies with plus minus neck dissection and appropriate reconstruction. So this lady with a mandibular tumor, we reconstruct with free fibula flap. So this is our carotid body tumor excision surgery. So in overall 3 years, we did more than 600 surgeries in the head and neck oncology department with a very less complication rate. So in the take-home message for all the my colleagues is that for head and neck oncologic tumors, the standard treatment is only the surgery. So don't delay in the cancer surgery. Thank you.
Dr. Sangeet. The next talk is on treatment of acne vulgaris by Dr. Shilpa Garg. I think we should listen very carefully to what she has to say, because she probably never had a pimple in her life.
Very good afternoon to all of you. Thank you, respected chairperson. The topic of my presentation is management of acne. To understand the management, we first must know what causes acne, the pathophysiology, because that tells us the corresponding clinical features that we are going to see and then the treatment that we are going to pick up. So this is your hair follicle, and it opens on the skin through this opening. And attached to the hair follicle is the oil gland, which we called as the sebaceous gland. So the first thing that goes wrong in patients with acne is that there is hyperproliferation of cells and retention of cells. That means the cells are forming in larger number and then they are not getting exfoliated. So they form what is called as the keratin plug and they block the opening of this hair follicle. The second thing that goes wrong in these patients is that they produce normally high quantity of oil secretion, and the composition of oil secretion is also altered. So once the opening of the hair follicle is blocked and the contents, oily contents and the cells accumulate, This we see, the ballooning of the blocked hair follicle is seen as a comedome. So comedomes are basically your white head and black head. They are those skin lesions which we see which are not red in color. This constitutes grade 1 of your acne. Once this happens, the third pathophysiological factor that sets in is invasion of bacteria, Propionobacterium acne. So once the bacterial invasion happens, it leads to inflammation, cytokines are released, neutrophils are attracted, and inflammation sets in. Once the inflammation sets in, all the skin lesions that you see will be red in color. So if the inflammation is less, you will see them as red solid papules. The inflammation increases, you will see these papules turning into pustules. And as it goes further, you will see these pustules forming deep-seated nodules. So skin lesions are basically inflammatory and non-inflammatory. Why this is important? Because the treatment that you're going to choose depends on what you see. So your grade 1 acne, if you're only seeing comedomes, that means you are seeing a blocked duct. But bacterial infection has yet not set in. So for treating this part of acne, you are only going to use keratolytic agents, that is agents that will help you to open the blocked duct. So no antibiotics are needed to treat this stage of acne. From here on, as you move from grade 2, 3 and 4 of acne, inflammation, that is bacterial infection, has set in. So apart from opening your pores by keratolytic agents, you will need an antibiotic, whether oral or topical, that will depend on the intensity of inflammation that you're going to see. So this is the basic of pathophysiology, the corresponding clinical features, and the kind of treatment that you're going to choose for treating your patients. So how do you begin your treatment? It is on general advice of cleansing. How often one should clean? 1 to 2 times a day. Please instruct your patients to do not scrub on their acne lesions. Any face wash or home remedy that is coarse on your skin will add and increase the existing inflammation. The face wash that they are supposed to use. Most of acne patients have oily skin, so you will choose your products which have benzoyl peroxide, salicylic acid or glycolic acid. So I'll just let out few trade names. There is no conflict of interest here. If your patient comes with oily skin, a good product to choose would be something like a Reguglow face wash or Yappy Glow face wash. And if the patient has dry skin, a good product to go with will be Cetaphil Gentle Face Cleanser. Second is, do we moisturize? Not needed in all patients. If your patient has a very oily skin, it is not necessary. However, in most of the patients, we end up using moisturizers. Why so? Because all your patients will be treated with some form of keratolytic agents. These keratolytic agents can cause a lot of redness, irritation and scaling of skin. So moisturizers are added, otherwise it is difficult to tolerate these products. If the patient has oily skin and you are in summer season, good moisturizer to pick up is Aquasoft FC cream. If you are in winter season and your patient has very dry skin, good moisturizer to choose is Max Rich U cream. Any product that you choose for treating your patients should be non-comedogenic. This is written on the product that it is a non-comedogenic moisturizer, non-comedogenic sunscreen. So choose non-comedogenic products. Sunscreen routinely never prescribed. It is only used because certain products, the topical retinoids that you use as a keratolytic agent can cause irritation and leading to photosensitivity. And doxycycline, the antibiotic that you use for treating your patient, can also result in photosensitivity. So if your patients suffer from photosensitivity, then you ask them to use a sunscreen. Otherwise, excess products are always avoided. Makeup, if you have to choose mineral makeup. All the brands make mineral makeup. You have to choose choose that. Advise your patients against squeezing and picking at their lesions in order to avoid scarring. Role of diet in acne is still very controversial. The baseline advice is you ask your patients to avoid foods which they feel aggravates or leads to acne. Now, treatment of your grade 1 comedones. If patient is coming only with whiteheads and blackheads, like we have discussed, there is no role of antibiotics for such patients. You have to only open their blocked pores. So you will choose a keratolytic agent. We have options of 3 topical keratolytic agents, which includes your topical retinoids, benzoyl peroxide, and azelaic acid. This is in their order of efficiency. Now, amongst topical retinoid, you have 2 options. You choose tretinoin cream or adapalene. Efficacy-wise, it is said that tretinoin equals adapalene in efficacy. Side effects-wise, it is believed that adapalene is much softer on the skin as compared to tretinoin. However, practically speaking, tretinoin gives excellent result if you know how to use it well in your patients. So how do you use tretinoin so that it does not cause the irritation it is supposed to cause? It comes in 2 strengths. Always choose the lower strength to start with, that is 0.025%. So tretinoin is always applied at night because it is photosensitive. So in the night, patient will first wash their face, and then they will use a moisturizer to moisturize their face. And on top of that, they will apply tretinoin. The quantity of tretinoin to be used is pea size, just about this much. And it is applied all over the face because acne can come on any part of the face. And they are instructed to avoid sensitive areas of face. So you don't take the cream close to your eyes, nose, or mouth. If they feel there is little irritation, they can start by using it on alternate nights. That's how you begin your tretinoin cream. Always put it on your prescription. Most of these girls or boys usually wax their face, thread their face, use bleach and other products. Since this cream can cause irritation, you must tell them to stop this cream 7 days before they do any procedure on their face. If the patient comes back with irritation on the skin in spite of all these steps, you stop the tretinoin cream. If the irritation is too much, that's what the face looks like. It becomes red and scaly. You stop your tretinoin cream. You give them a moderate potency topical steroid 3 to 4 days. After that, you stop your steroids and tell them to continue the moisturizer for next 3 weeks. And then rather than tretinoin, you can then shift them on adapalene cream. Very important thing about tretinoin is, so acne now we know is a chronic disease. It runs for years. So once the idea of treating is that we introduce many products, and as and how the acne decreases, we start withdrawing one by one. But baseline tretinoin cream or keratolytic agents are continued for next 1 to 2 years also, in spite of not having any lesion. This is to retain the success that you've achieved and to prevent relapses. Otherwise, if you're going to stop tretinoin cream, your patients will come back to you after every 2 months and you will be giving them antibiotics again and again. So benzoyl peroxide comes next to tretinoin. It has its role. It is safe in pregnancy. So in patients planning pregnancy, you can use it. Azelaic acid, I have never used it practically, but good part is that the amount of irritation is very less. So if you have a patient with atopic dermatitis, it is a good keratolytic agent to start with. Now coming to once the inflammation sets in, that is, you have to use your antibiotics. Please, if the inflammation is less, you are seeing papules and less number of lesions, go with topical antibiotic. Inflammation is more, you will replace your topical antibiotic with oral antibiotics. Which topical antibiotic to choose? Nadifloxacillin is most effective, followed by clindamycin, erythromycin. Dapsone I have never used, so can't say. Oral antibiotics, we have 2 groups, tetracycline group of antibiotics and macrolide. Tetracycline are preferred. In tetracycline, you have 3 antibiotics that you use, doxycycline, limicycline, and minocycline. Don't use minocycline because it can have some drastic adverse effects like hepatitis, drug-induced hypersensitivity syndrome, SLE, and it can cause staining of your skin, which may be permanent. Between doxycycline and limicycline, doxycycline is cheaper, limicycline is more expensive. So start with doxycycline. The advantage of limicycline is that the onset of action is slightly early, practically speaking. So if you have a patient who's getting married, you can start them with limicycline, but the end point of 40 days result will be same with both. Baseline rules with antibiotic in order to prevent antibiotic resistances. There is no concept of monotherapy. You will always combine them with a keratolytic agent. Don't use your antibiotics beyond 3 months. And role of azithromycin is in patients less than 8 years where you can't use tetracycline. It has safety during pregnancy, and you can combine it with the isotretinoin, which you cannot with doxycycline since they both can increase the intracranial pressure. Treatment of severe acne is with oral isotretinoin. To conclude, I would like to say that please remember there is no role of antibiotic in treating your grade 1 acne. And always combine your antibiotic with benzoyl peroxide or keratolytic agent to avoid resistant. Don't go using antibiotics beyond 3 months, and always emphasize the concept of using tretinoin cream for a very long time in order to prevent recurrence. Thank you. We have 2 books for general practitioners of skin in case you are interested. Thank you. Sir.
How does it act in acne?
Sir, azelaic acid. No, it is for acne also, sir. It says that it has action against Propionibacterium acne. It is anti-inflammatory, and it also reduces the pigmentation, which is an advantage because most of the acne lesions result in hyperpigmentation. I'm not a big fan of azelaic acid because you have better products that you can use in a better way. It is a keratolytic agent, sir. It is a keratolytic agent. Please, sir. So, sir, aloe vera gel has anti-inflammatory role, but a practical problem with using aloe vera gel in your patients with acne is that you will be using tretinoin as a keratolytic agent. So when the skin is irritated and in the morning you are going to apply aloe vera gel in any inflamed skin, sensitive skin, aloe vera gel is usually not very well tolerated. Of anxiety? So, sir, acne is a multifactorial disease. I think you can't take stress away from any disease per se, but technically speaking, anxiety is not involved in pathophysiology of acne as such. It is, sir. Yes, all the glands, the hyperproliferation comes from the background of hormones.
Very much. Okay.
It's available on Amazon, sir. Amazon.
Please.
No, sir.
Thank you very much.
No, thank you.
Well, for information of all, Dr. Shilpa is writer of 2 very nice books in dermatology, and those people are interested in any type of skin disorder with good photographs. She has got the books. You can go take it and take a really very nice book. Well, for the next topic, I call upon Dr. Dhiren Gupta. He's a senior consultant pediatrician at Gangaram Hospital. He's going to talk on asthma, allergy, crosstalks, what is new in childhood asthma.
Good afternoon, friends, and thank you, Beta sir. One disclaimer, I am not only suffering from asthma, but also allergic rhinitis. So my presentation may be carrying some matter of experience too. In my brief presentation, it's not moving. ये मूव नहीं कर रही है. Yeah. In my brief presentation, I'm going to talk about in which group of patient we should use allergic tests. Lot of commercial tests are available nowadays. It poses lot of confusion among us. Even if I'm doing pulmonology for almost 22 years, it confused me to get an answer which type of allergic test. Secondly, often we call that pediatric asthma is always no objective test is available. PFT is difficult to perform. So what new thing have changed over the time? Again, it's not moving. Yeah. When we talk about cough, any patient who is come to us is going to have a repeated cough. Only 20% of the patients will have allergic etiology. That thing should be kept in mind. Not all repeated cough are going to have allergic etiology. No patient is going to come to us with repeated cough or persistent cough as a label of asthma. This slide is probably the most important slide. Whenever a patient with cough comes to you, you decide what type of cough this patient is having. Is it a wet cough or dry cough? Wet cough can be present even in infant. Whenever you find a patient having failure to thrive or there is a clubbing, you rule out asthma. You think of something different, maybe cystic fibrosis, maybe primary ciliary dyskinesia, maybe immunodeficiency, right? But today our focus is dry cough, which is repeatedly happening, and likely the patient is suffering from asthma, okay? Whenever we deal with an infant with a dry cough, where we think asthma is the etiology, we should be very cautious. There can be congenital anomalies in this group of patients. Also, you should rule out many other diseases like laryngomalacia. But the typical patient of asthma who responds to beta-2 agonist, who has got repeated episodes, especially happening in the early morning, not only you are able to demonstrate reversibility by spirometry, which is, say, many decades old gold standard, but less than 6 years also, we can have one more modality, that is impulse oscillometry, right? We'll talk about that. And very important is the diagnosis of comorbidity. When we talk about comorbidity and when we think of allergy, that is the whole soul aim in this presentation, these 5 points are very important. History of atopy in the family. If family is having strong family history of asthma and allergy, this is a very strong indicator of atopy in the present child, right? History of eczema, allergic rhinitis, food allergies, night and early morning symptoms, and seasonal variation. Keep these points in mind when we are thinking of to subject this patient for allergic test. What are the different type of allergy test? Which patient we should subject for allergy test? If you find, yeah, okay, I think it's just stooped down. When we talk about asthma and history of atopy is there, you talk about test of sensitization. There is no test of allergy, right? We just want to know whether the body is sensitized or not, and the gold standard test is your skin prick test. If you want to do blood test, then immunocap is the best test. In many of the patients where I am confused, history of atopy is doubtful. Predominantly, it may be some obstructive feature, not an allergic feature. I may go for a screening test. We call it Fadia-Top screening test. This costs you just 700 or 800 rupees. This is a good test to rule out allergies. Though skin prick test is a gold standard. Let's take an example. This is a 12-year-old child who is having recurrent cough and cold for since 8 months of life. I'm going to give you the history, and this black gives you idea what a clinician is thinking, what is happening in the patient, right? This patient presented at a, Diwali season when he was 8 months old with recurrent cough cold. At 1.5 years of age, the oxygen dropped in the night, right? A clinician, when the family is giving you history, you start thinking there must be adenoidal hypertrophy, probably has pitching at this stage, right? At 6 months of age, this patient had rash, itching, loose motions after milk injection. You start thinking of milk allergy, right? At 3 years of age, this patient had urticaria, then the patient had recurrent ear infection. Likely now adenoidal hypertrophy has actually flared up. This patient must be having neglected adenoids. And thereafter, at 8 years of age, grandfather died. And thereafter, he repeatedly started having cough. You start thinking like a psychogenic cough. So what I'm trying to extract from this patient, is this one. This is known as allergic march. If you find allergic march is there, is family history of there, likely we need to find out atopic sensitization. And as I told you, the best test is skin prick test. In this patient, skin prick test was done. Interpretation of test is very important than just getting these tests. Look at it is house dust mite sensitivity. It is also sensitive to the cockroach. Now you have to find the second history after this test. Which type of antigen is actually playing the role? You may be positive to so many antigen, but actually that antigen is leading to allergic symptom or not, that is the most important one. So it is a long process. We can't explain here, but what I can say, this patient was started on allergic immunotherapy after controlling everything. One point about role of immunotherapy, if you are thinking of immunotherapy, choose a young patient. Choose a special antigen allergen, especially house dust mite. So if you let the disease set in for 10 years, probably irreversible changes set in, right? So it is not going to work. Now we talk about another 3 slides, just about one modality. This is known as impulse oscillometry. This is a 12-year-old female who was diagnosed to have an anxiety-induced hyperventilation, and she was admitted with us. Lot of beta-2 agonists were given in preceding 1 hour. The chest became clear. So everybody thought that she's so anxious, it's actually all psychogenic. It is not an asthma, right? The patient was discharged on antipsychotic medication. Within 15 days, she landed up in my OPD with actual wheezing, with actual cough. She was not able to take the spirometry. That is a very common problem in less than 10-year-old child. So this is a very simple test. Patient underwent because this is an effortless test. Patient has to just take in the mouth and everything machine does. Now this patient was subjected for this test, and what we found, actually patient was suffering from asthma, right? This is the beauty of this, you can say, modality. It is an effortless. And this way we made diagnosis in this an uncooperative patient, and presently patient is on Foracort and is doing well. So in conclusion, my friends, we all know that asthma is very common, especially post-COVID era. Which patient having allergic test? Most of these patients will have childhood origin. Even in adult, if you're trying to apply the knowledge in yourself, if you had onset at the childhood, say 5 years, 7 years, very likely you may be asthmatic with allergic predisposition. Allergic immunotherapy is a good modality, but selection of the allergen and the patient is paramount, right? And objective tests like impulse oscillometry, FeNO, that is fractional excretion of nitric oxide, this gives you type of asthma the patient is suffering from. And of course, phenotype is very important, especially in 10% of the patient, it is going to help us. Thank you very much for the patient hearing. Sir, Fadya type screening test. Is there 2 types of screening tests? One is adult and one is child. Child contains some oral antigens also. Adult contains some common antigens. So there are group of antigen that includes house dust mite, cockroach, and lot of antigen. It is clubbed in one. So it is a very good negative screening test. Negative carries more value than the positive. It's around 900.
Thank you, Dr. Dhiren.
Sir, nowadays, juvenile asthma term is not used. We use phenotyping, right? Is an allergic asthma Th2 type or Th1 type? In Th2 type, what type of disease process is having? It's what type of drug is going to act in this patient? So like inhaled corticosteroid, nasal corticosteroid, or macrolide. So this way we approach.
Thank you, Dr. Dhiren, for the... Can we have a discussion?
I can answer you one time
after this.
Thank you, sir.
Thank you for excellent presentation on how to approach a patient with the pediatric asthma and what investigation to be done. May I invite now the next speaker, Dr. Piyush Ranjan, who is a senior consultant in gastroenterology, to speak on the topic when to refer a patient for liver transplantation.
Good afternoon, everybody. So, this very important topic stands between you and the lunch, and I'll try to finish in 8 minutes, and bear with me. This is a very vast topic, very important topic. I'll try to make it as short as possible, as simple as possible. And it is very appropriate that Dr. Johari is chairing this session, who has been a yeoman of the organ transplant in Gangaram Hospital. So what is a liver transplant? Let's start from very basic. Liver transplant is when a diseased liver is removed and a new liver is put in its place. Orthotopic liver transplant is when the liver is placed in the normal anatomic position. Variants include heterotopic liver transplant, auxiliary liver transplant. Depending on the type of organ, it can be a living donor liver transplant and it can be a cadaveric liver transplant. Living donor liver transplant is most commonly done in our country because of disease donor organ shortage. So, what does it take to do a liver transplant? The issues in cadaveric liver transplant, as I mentioned, is shortage of liver donors, and it's a worldwide phenomenon that nearly a quarter of patients die while in the wait list. Living donor liver transplants offers a solution because there is no waiting period. The patients and the recipient can be optimized, and the technical issues like storage and the preservation of organ is taken care of. So basically, the liver transplant involves these 3 steps: the recipient assessment and indication of liver transplant, donor evaluation, and surgery and post-operative care. And in this brief talk, I'll mention about the assessment of the indication of liver transplant. So the indication of liver transplant can be divided into 4 broad categories: acute liver failure, cirrhosis, metabolic, and different malignancies. And predominantly we'll discuss about acute liver failure and cirrhosis. So coming to the liver transplant in acute liver failure is defined as INR prolongation of more than 1.5 associated with hepatic encephalopathy. So this is very important. Isolated prolongation of INR does not mean acute liver failure. It means severe acute hepatitis. If the patient is conscious, has prolonged INR, this is not acute liver failure. The causes, as we all know, can be acute viral hepatitis, drug-induced hepatitis, antitubercular drugs, and a host of other drugs, being antitubercular drugs being most common, and paracetamol poisoning being most common in the Western world. Autoimmune hepatitis and Wilson's disease can present with acute liver failure. Now, is transplant the only option for acute liver failure? The answer is no. For all these conditions, like for paracetamol, for hepatitis B, for autoimmune hepatitis, you have steroids. For Wilson's disease, you have the copper binding agents and other supportive therapies which help to reduce cerebral edema, antibiotics, maintaining glycemia, maintaining ventilation, and plasma exchange. I'll mention plasma exchange very briefly. But despite doing all these things, there is 60% to 70% mortality despite all this. So, who are these patients who need liver transplant in setting of acute liver failure? This is a very dynamic situation. You will have a very frayed family with very frayed tempers, and you have very little time. So you have to identify which patients does need a liver transplant. There are various criteria. The King's College criteria is the most time-tested criteria, varies for the paracetamol and non-paracetamol poisoning. I will not go into the details. You just look at the INR, the total bilirubin, age, and the factors like non-A, non-B hepatitis and drug-induced liver failure. Then there is this Clichy's criteria, which is based on just 2 factors, the presence of HE and factor V level. And this is one score which has come up from India. This is the ALFED score, which includes HE, INR, arterial ammonia, and bilirubin. You do it on day 0 and day 3, and it's a dynamic score. It helps you identify better and plan the transplant better. So basically, you identify the patient. If the patient does not have any apparent contraindications, the apparent contraindications are listed in the 3rd row, where you have the stop. Then there is a indication that the brainstem is not working, when there is severe sepsis, or when the patient is hemodynamically too unstable. In all of the situations where the patient is not showing sign of improvement, you go ahead with transplant. And as I mentioned, this is a very, very dynamic situation. The challenge here is to maintain the patient in a good condition, to control cerebral edema, to control infection, and a very rapid workup of the donor. Is there an alternative to transplant? In the last 5 to 6 years, there have been 2 important papers on plasma exchange. This was the first paper in 2016. And this is the second paper. This is a retrospective study. And we are now also using plasma exchange, which can be used either as a bridge to transplant. And in many situations, in Indian setting from CMC Vellore, there is a brilliant paper where in rat poisoning, they have been able to salvage as many as 70 to 80% patients who would otherwise fit into the King's College criteria. So having understood the acute liver failure, we move on to liver cirrhosis. Liver cirrhosis basically is a consequence of liver damage due to many other conditions. The etiology, we do not need to go into detail. The clinical manifestations of cirrhosis, we all know. And top it up with hepatocellular carcinoma. Liver cirrhosis is divided into two stages, compensated, decompensated. And in decompensated cirrhosis, if you look at this, nearly 57% mortality in short term. The management, non-transplant, treatment of the underlying causative agent, and managing the complications like diuretics for ascites, beta blockers, endotherapy for bleeding, and managing hepatic encephalopathy. So in a setting of liver cirrhosis, how do you select patients for liver transplant? Two criteria which are used. The child score we are all aware of, and if you look in the child C, there is nearly 40% mortality in the 3 months for patients, and a patient with a child score more than 7 should be listed for transplant. This listing criteria, the concept is more common in the deceased donor liver transplant. In the living donor liver transplant, you have no such listing criteria. If a patient fulfills the criteria of transplant, he can be transplanted. And there we use MELD score. If there is MELD more than 15 and any of the decompensating event, the patient can go for transplant. In a patient with a MELD score of less than 15 and hepatocellular carcinoma, you can offer them transplant. There are many contraindications. We'll not go through this list. Now again, the timing of OLT in cirrhosis, in DDLT versus LDLT. In DDLT, you have a listing criteria. In LDLT, and you have MELD exception points. In LDLT, the biggest benefit is that you do not need a waiting list. Now, acute and chronic liver failure is another upcoming entity where a person with normal liver has an acute insult and there is systemic inflammatory response and organ dysfunction. And this is an algorithm which shows you that even in this situation, you can select these patients with ACLF grade 2 to 3 for transplant. Patients with ACLF grade 3, the most left side of your screen, they will probably come out of their problem, and with ACLF grade 4, they will not go for transplant. Two specific situations, hepatocellular carcinoma, the Barcelona Clinic liver classification is used most commonly. Patients with early stages are selected for transplant. Very broadly, patients with no vascular invasion, no extrahepatic spread, and good performance status are candidates for liver transplant. And there are so many bridge therapies which have come up for these patients, that is patients who are even having portal vein invasion, can be treated with TACE, TARE, immunotherapy or SBRT, and then they can be subsequently transplanted, and we are frequently using it. And beyond the established criteria, there is a list of criteria which you can use, like this Milan and UCSF. These are the two most common criteria which we use. Liver transplantation in severe alcoholic hepatitis. This is a very important condition. You have young, otherwise patients who were well for some time back. We use alcoholic hepatitis scoring system, the Glasgow, the MDF with a DF more than 32. You can treat them with steroids, and the patients who are steroid ineligible or who do not respond to steroids can be offered transplant if there is no contraindication. And the first time liver patients who are decompensating for the first time, patients with a good psychosocial support, and patients need to get their clearance from the local transplant committee, and this has been studied in a prospective study. This is a very important study which shows you that these patients with acute alcoholic hepatitis, severe alcoholic hepatitis, in whom the normal mortality in 6 months would be around 70%. Look at the 1 year survival, 94%. Look at the 3 year survival, it is 84%. So severe alcoholic hepatitis transplant is doable, and it is being done. What happens after the liver transplant? In live donor liver transplant, the liver which is, the graft which is there in the liver, this recovers within 2 to 3 months. And look at the 5-year survival, it is 80% plus, both the graft survival and the patient survival. And there are a number of complications, you know, that it's not a very rosy story post liver transplant. You have complications, the early complications, the late complications, the patient has to be on immunosuppression. So, in conclusion, liver transplant is the only curative option in patients with acute liver failure and cirrhosis. LDLT is a viable option in the absence of active cadaveric donation program. It has got excellent short-term and long-term survival. Post-transplant, need for immunosuppressive and monitoring of complications is required. So, in essence, the gist of my talk is the key to good outcome in patient is timely referral, and all of us as a physician, as medical care providers, we should all increase the awareness of organ donation. Thank you so much.
What is the fibroscan and elastic? We are also using that also.
Sir, fibroscan, I think Dr. Harbans Lal sir is mentioning that we can answer these questions outside. Fibroscan is not used for liver transplant criteria. Child score is a score which is used on ascites, encephalopathy, bilirubin, albumin. These are the simple 4-5 factors, and MELD again is a score which is, you can there is a MELD calculator, you can put in simple values like prothrombin time, serum creatinine, and you will get the MELD score.
Thank you, sir. I think we should.
Itraconazole can cause acute hepatitis. Any severe drug-induced hepatitis can cause acute liver failure, not antifungals. Itraconazole is very common. Yes, drug-induced hepatitis, itraconazole is very common.
Thank you, Dr. Ranjan. And I think it's time now for lunch.
Thank you, sir. So please join us for lunch, and at 2:30 we'll reassemble over here. At that time there will be inauguration for 30 minutes. And we are going to have a really those who came early, very good mega prizes and lucky draw at that time. So do join us for inauguration.